Mic check, 1, 2, 3. Mic check, 1, 2, 3. Testing, 1, 2, 3. Testing, 1, 2, 3.
But there's like a mess.
Testing, 1, 2, 3. Testing, 1, 2, 3. Testing, 1, 2, 3. Testing, 1, 2, 3.
Testing 1. Hello, testing. Everything is on.
Testing, 1, 2, 3. Testing, 1, 2, 3. Testing, 1, 2, 3. Testing, 1, 2, 3. Check, check. Testing 1, 2, 3. Testing 1, 2, 3.
The button Kyle was referring.
I'm going to ask all members to please take their seats. This hearing of the Senate Committee on Insurance, Licensing, and Forestry is called to order. And I'm going to ask the clerk to please take the roll. And if we do have one member that is going to be phoning in.
Senator Felskowski.
Here.
Senator Staffschl.
Here.
Senator Jagler.
Here.
Senator Taylor. Senator Ringhand.
Here. Did you hear?
Yeah, we got you, Senator. Okay. You bet, Senator. Well, good morning, everyone, and welcome. We have one item on our agenda today, and that is SB 753. If anyone here would like to testify, you can do so at one of the registration stands outside in the hallway, and the sergeant staff is out there and they'll help you get registered on it. Today, we have our committee legislative council attorneys with us, Marguerite Kelly. Thank you for being with us, and thank you for all your help on SB 753 so far. I also want to remind everyone that Wisconsin Eye is in the room with us today, and they will be recording these proceedings. I'm looking forward to an informative and productive hearing. So let us begin this. All right, guys, we will be hearing SB 753 related to prohibiting certain practices relating to insurance coverage of clinician administered drugs. I'm going to say Representative Kurtz, and then we have Rachel from Senator Darling's office testifying. We also have Hannah Amford from Reedsburg Area Medical Center and Dr. Chris Spar, the Chief Quality Officer of Children's. Tony, do you want to start it off and then we'll switch? Is that okay?
Thank you very much, Chairwoman Fritzkowski and committee members for hearing Senate Bill 753 and allowing me to testify today. Senate Bill 753 prohibits the use of white bagging, and that term will be explained quite in depth today. By insurance companies when patients are in network and are prescribed a clinically administered drug by their provider. White bagging is a practice used by insurance companies that require life-saving medications to be shipped from a source that the insurance company dictate, rather than using the patient's local hospital pharmacy. Patients with conditions like rheumatoid arthritis, cerebral palsy, multiple sclerosis, Crohn's disease, hemophilia, and cancer are affected by these policies. I first learned about white bagging when I visited one of my rural hospitals in Reedsburg and met this wonderful lady to my left, Hannah. I met with the hospital staff who told me that they were having issues getting medications for their patients because of this new policy. To hear the patient's stories of having health insurance, paying those monthly premiums, and going to a provider that is in network, and we all understand what in network means, and then out of the blue being told by their insurance company, or in some cases by their doctor, that they cannot receive a drug that they've been using for that disease, simply because the health insurance company wants them to go somewhere else so that they may reduce costs. The worst part of this whole situation is that hospitals and insurance companies agree in a contract on the price hospitals will charge those insurance companies for those drugs. They negotiate it and they all agree and sign a contract. Yet insurance companies will change their mind mid-contract, which what happened to Reedsburg Area Medical Center. They negotiate and all agree on a contract, yet the insurance companies change that. They tell the patients they must adhere to these new policy changes or else they will have to foot the bill on their own. And the bottom line, who this affects is the patient and patient care. I heard from a local patient in Wisconsin Dells about white bagging and how it affected her. Her name is Christina. And she was dealing with severe psoriatic arthritis for the past 17 years. And if you ever talk to anybody that had psoriatic arthritis, it's incredibly painful. And so she required treatments approximately every 6 weeks, and it was a 30-minute infusion. And she would get those at Reedsburg Area Medical Center. She was notified before one of her appointments for an infusion that her drug had not arrived at the hospital from the pharmacy, specialty pharmacy that the insurance company dictated so she could get her medication from. And therefore, she would not be able to receive her infusion the next day if it did not arrive on time. She was told she had to call her insurance company to try and get the drug shipped to her hospital. And you can imagine, she couldn't believe it. She needed this infusion to be able to move, to get around, just to bring that pain level down. And she had to call her insurance company to be able to find out if she would be able to get the medication on time. You're going to hear from other stories today, like from Christine, who are going through their healthcare journey and are interrupted from getting the healthcare they need because their insurance company gets in the way. We can't let this become the norm for patients in Wisconsin. We must allow patients and their healthcare team to be in charge of the patient's healthcare journey. We cannot have health insurance companies dictating where a patient gets their clinically administered drugs. And in some cases, this life or death for patients dealing with cancer or other high-risk diseases. They can't wait for the insurance companies to figure out their shipping issues, or in some cases, even if the medication arrives on time, since these medications are mixed several days before a patient's treatment, particularly for cancer patients, these prescribed medications, it may not be the correct formulation when that patient actually receives the treatment. Patients are being harmed by this practice, and that's why we need to make sure it isn't mandated by insurance companies. Not in my prepared remarks. I just wanted to say today you're going to hear from healthcare providers from all over our state. They got up, some of them probably got up 4 o'clock in the morning in minus 10-degree weather and drove down here. For many, it's the first time they'll be testifying. And you have to think, we're going through a lot in our state with healthcare. You know, we're at a crisis point. And for them to take the time to come down to Madison, I just, on the record, want to appreciate you doing that, because it just shows the problem that this policy is having with our patients, and it is affecting healthcare. So I will be followed by Rachel from Senator Darling's office. Thank you.
Thank you, Chair Pelskowski and committee members for taking the time to hear this bill. Representative Kurtz did an excellent job kind of going over the issue before us today, and I will just be doing a pared down version of the senator's remarks. We do have her written testimony up there with you. This bill came before the senator when a constituent in her district was negatively impacted by a white bagging policy that was implemented that would have delayed his care by almost a month. Ultimately, that can't be an acceptable way for constituents to receive their care, which is why she's gotten involved. Ultimately, this bill comes down to making sure that patients have access to covered drugs when they're receiving them from in-network providers. We're trying to make sure that patients don't have to jump through additional hoops to get their needed care. We have a bunch of experts in the room today, so I will be here to help with questions, but I will turn it over to Hannah Ambord.
Chairperson Felskowski, Ranking Member Taylor, and members, thank you for the opportunity to testify today on behalf of Reedsburg Area Medical Center, and I'll refer to it as RAMC. My name is Hannah Tibagwa Ambord. I've been a pharmacist for 25 years, 6 of which I've been a director of pharmacy at Reedsburg Area Medical Center. As a child, I once needed daily injectable treatment over several days, and every time my father and I went to the clinic, we had to wait several hours because there was no pharmacist. The doctor did it all. It was then that I decided as a 6-year-old child in Uganda that I wanted to become a pharmacist, so other children like me did not have to wait for hours to receive their medication. As I fast forward to today in the United States of America, in Wisconsin, I'm here to advocate for my patients that are not waiting for hours, as I did as a child, but for days and sometimes weeks in order to receive life-saving care. As a pharmacist, I took an oath to embrace and advocate changes that improve patient care. For the sake of our patients, RAMC tried and embraced white bagging because our patients were not given the option to get their medication from RAMC. Or if they did, the medications would not be covered and RAMC would not be compensated for providing pharmacy services. Many of our patients have been coming to RAMC for years to receive care, and their medications have been available to them when their provider and the patient needed them. Unfortunately, this has not been my more recent experience at Reedsburg Area Medical Center with the practice of white bagging. The unilateral decisions made by insurance companies have created an undue burden for our patients. They're increasing our costs, and along the way, they're tarnishing the image of Reedsburg Area Medical Center, which we work very hard to make sure that our patients are comfortable and trust where they receive their care. I have multiple patients that have been impacted. Specifically, I'm here to advocate for my 70-year-old patient that has been coming to Reedsburg Area Medical Center for years for osteoporosis treatment. Last year, she was notified that her medication was to be white bagged and she could no longer receive her injectable treatment at RAMC. During one of her clinic visits with her doctor in which she would have received her treatment, I stopped by to see how she was doing. My patient expressed frustration and a high level of anxiety with the process. She did not appreciate not being able to get her medicine during her visit while she was seeing her doctor in an environment that she was very comfortable with and care from a team that she has known and trusted for years. My patient asked to be switched to another medication that was not white bagged so that she could stay at RAMC. She was opting for the next best option instead of standard of care. Just last week, I received a call from a nurse in the clinic asking with other treatment options I could offer to a patient who did not want to change treatment, but the medication she had been receiving was being white bagged. What I'm seeing is patients are opting for the next best option. And as a pharmacist that took an oath to always advocate for change, positive change, it is quite disturbing when patients are asking for that. Another example is my 53-year-old patient with a potentially debilitating inflammatory condition. She has been on the medication since June 4th, 2020. In working with her rheumatologist who practices outside RAMC, the patient chose to receive her treatment, her pharmacy care at RAMC. She received a letter in the middle of her treatment that her medication had to be white bagged. My patient had an appointment on October the 22nd, but her infusion medication was not received until 5 days after her appointment on October 27th. Her next dose was scheduled for December 12th, and the medication was not received until December the 22nd, 10 days late. Her next appointment was January the 19th, and medication was not received until February the 26th, 1 month and 7 days later. She had an appointment scheduled on April the 13th, and prior to this appointment, we again noticed that no medication had been received. Something was not right. We know our patients. So I called the patient to check in. My patient shared that she had spent a significant amount of time trying to coordinate her medications and when it would not ship out, and when it would ship out, and when to schedule appointments. She said it was quite costly to coordinate everything, taking time off to coordinate care. In the end, this straw broke the camel's back. Essentially, the message we sent to this patient was that you do not have to take or receive your medication on time or as scheduled by your doctor. The back and forth with the specialty pharmacy took a toll, and she decided to stop treatment. The treatment for this patient was interrupted. Her quality of life was diminished, and in the end, she will have a worse condition. When this happens, the overall cost to healthcare system is higher and not lower. Our quality control systems have been disrupted and bypassed with white bagging. We purchased our own drugs. We monitor dispensing, compounding, and dosing. We ensure proper preparation and storage of drugs from purchase to administration. We also complete a full medication review of all our patients and adjust dosing in real time based on the patient's condition. With white bagging, we have implied liability and are forced to receive and accept product that is not ours with little to no notice. Under our normal process, RAMC owns the medication and we can guarantee from the point of origin of the drug. We can demonstrate a clear chain of custody to ensure the highest product. We follow the Drug Supply Chain Security Act, or DSCSA. We cannot simply hope and trust that medications are made under safe conditions. The DSCSA standards came about concerns resulting from an incident in Massachusetts in 2012. The DSCSA adds a variety of restrictions and regulations, and especially in regards to labeling, new drug requirements, and track and trace requirements. We saw what happened in Massachusetts in 2012. We must, as pharmacists, do our due diligence to ensure patient safety. When drugs are white bagged, we spend a significant amount of time coordinating medication deliveries instead of focusing on clinical monitoring. We have been put in an uncomfortable middleman position between the patient and specialty pharmacies. Pharmacists are calling to apologize when we've done nothing wrong because the medications did not arrive as expected. Pharmacists are now coordinating with patients to help them reschedule clinic appointments as needed and based on when the medications arrive. There's a lot of rework and added expense. At RAMC, like many hospitals in the United States, we have streamlined automated billing processes. After the patient comes to the clinic and receives their medication, the bill is processed using standard billing systems and a bill is sent to the payer. With white bagging, the pharmacist must now intervene and manipulate the bill before it goes out to the payer and must work with accounting to document why the bill was changed for audit purposes. This can get complicated, especially if the patient has more than one medication where some are white bagged and some are not. Now extrapolate this to 10, 30, 50 patients. As more payers get involved with white bagging, we will need to add staff in order to manage and oversee these dismantled billing systems and processes. We have other added administrative costs with white bagging as well. For example, we have to segregate and add storage for white bagged medications that have to be held until the patient comes because appointments have been rescheduled. We have tried white bagging, and from my own personal experience, it gets messy very quickly. Instead of being lean and efficient with white bagging, our healthcare delivery system is being put back in reverse mode, with white bagging increasing the overall expense to our healthcare system. I have more similar stories. I have heard similar stories from my colleagues in Wisconsin. Reedsburg Area Medical Center is contracted with these payers to dispense medications to patients. Patients and doctors should have a say and the right to be at the table and they should have a right to be at the table to decide where to get their medications. As we continue to disrupt patient-provider relationships, our patients are suffering. We need to go back to team-based care with the healthcare providers, payer, and patients at the table. Together, we need to answer the question, what is the best for my patient, our patients? When the patient is at the center, I believe we can get this right. Once again, I'm here because I took an oath to embrace and advocate for changes that improve patient care. I have never testified before any committee, but I see the distraction to my patients, and I know that this is preventable. I see the quality gaps that are being imposed in the procurement and preparation of these medications, fragmented patient medical records, the implied liability, and the increased cost to the overall healthcare system. If this is allowed to continue, we will need to add staff just to manage this process. Reedsburg Area Medical Center asks for your support of Senate Bill 753. Your vote can ensure that this does not happen any longer. Thank you very much for your time.
Yes, thank you and good morning. My name is Dr. Chris Spar. I'm a pediatric emergency medicine physician at Children's Wisconsin. But primarily today, I'm here in my role there as the Chief Quality and Safety Officer, and I've been in that role for almost 7 years now. As we do at pretty much all of our quality and safety meetings and a lot of meetings just in general and discussions around the care that we're providing, we lead with patient stories, and so I'm going to do that this morning as well. I apologize for reading, but I want to make sure that I'm providing this verbatim. We do have permission from the family to share this today. So this is a statement from the family of 8-year-old Landon Clays from Grafton. We are Megan and Mike, and we live in Grafton with our sons, Robbie and Landon. We'd like to share some about our 8-year-old son, Landon. Landon has cerebral palsy due to brain damage sustained at birth. Landon's cerebral palsy affects his motor control, sensory processing, and his reflexes. Landon's doctors at Children's Wisconsin have used Botox injections on a regular basis to help loosen Landon's muscles that get tight, which make it harder for him to do daily activities and cause him significant pain. We regularly scheduled his injection appointments for every 3 months so we could better manage Landon's muscle pain and tightness and allow us to plan for time away from school and work. A couple of years ago, our insurance company suddenly started a policy called white bagging, which would change the process for how Landon would receive his medications. Rather than using the medicine already in stock at the hospital's pharmacy like we were used to, Landon's doctors would have to order the medication from a specialty pharmacy, which would then ship the medicine to the clinic for the appointment. Because of insurance company approvals and shipping delays, we had to reschedule an appointment of Landon's. Unfortunately, the new appointment would be a month later. Landon's doctors and nurses, also depending on how Landon's condition is at the time of appointments, Landon's doctors and nurses may need to adjust the doses of his Botox injections. With this white bagging process, we'd have to come back for another appointment once the additional doses were ordered and delivered. Before white bagging, the hospital could just use their stock of Botox to meet Landon's needs and made scheduling and the whole process simpler for us. For kids and adults with complex or chronic health conditions, navigating the healthcare system is already complicated, stressful, and sometimes frustrating. Eliminating this policy and supporting SB 753 would help healthcare providers to better care for kids like Landon. Thank you. So I'd like to keep my remarks fairly brief today. And again, it's mostly in the context of my role as a Chief Quality and Safety Officer at Children's Wisconsin. And there's 3 things that I'd like to share today, which is reflective of my testimony and really the testimony of Children's Wisconsin at large. You have the full written testimony. I'm not going to go into the details of what's in there. You're going to hear a lot of those details from those that will follow me today as well. But the 3 things that I'd like to share today is, number 1, a broader quality safety perspective and put white bagging in that context. Secondly, I'd like to share a little bit more of a local perspective, which again is shared with other healthcare systems and other care providers. But again, it's truly local to us because every healthcare system and every patient care needs are truly different. And then finally, I'll close with a recognition of, we talked a lot about cost, I think, with this issue, but I'd also like to kind of recognize some of the unintended or downstream consequences of white bagging and what we've already recognized and what will continue to happen if this continues. So from a broader quality and safety perspective, it's been only about 20 years that the quality and safety movement in healthcare has been really recognized, and pretty much every healthcare system in this room and across the country have committed to that commitment to quality and safety. So what does that mean? We've committed to things like high reliability and safety in our processes. Those are nice buzzwords, but what does that actually mean? It means that we look at some of our most complex processes, like the medication delivery system. You've heard what that entails. It entails appropriate ordering by care providers, procurement and processing of those medications, delivery to the right place, the right patient, and then the actual delivery to that patient by the care providers, and then the monitoring for the response, either adverse outcomes, which sometimes happen with medication delivery, or again, ideally, the best outcome that we're looking for, which was the purpose of ordering that medication in the first place. The reality is the white bagging process is a step backwards. And again, in my role as Chief Quality and Safety Officer, I'm hard pressed to think of another situation where we've taken a high risk, very complex process like medication delivery, and we've intentionally introduced workarounds, more complexity to the process, Again, we spent 20 years building systems and processes with the highest levels of reliability and safety. That includes things like information systems. I'll give you one example. We've gotten sophisticated enough in working with medical equipment companies to actually program our pumps that deliver these medications that link to the patient's record such that we know that it's the right dose, it's the right amount, it's the right patient. Those are things that we've been able to build in our system from a partnership perspective to produce the highest reliable processes and the safest and best outcomes for our patients. And so what we've done with this white bagging process, as you've heard, is we've been essentially intentionally, again, not because healthcare systems want this or our patients want this. You've heard this from Landon's story. It doesn't make sense to them. We had a process that was working. And now all of a sudden, the process isn't working for our son. So I just want to provide that perspective. The final thing I'll say from a broader quality and safety perspective is, again, I can't think of any other process. So we're accredited by the Joint Commission. That's a requirement for us if we want to provide services and ultimately receive reimbursement for those services through the Centers for Medicare Services. And when they come and accredit us, they would look at a process like this and say, that's not good enough. You know that there's risk in this process and there's real harm that's occurring. It's not acceptable for you not to address this and improve this process. So that's my broader quality and safety perspective. From a local perspective, I can tell you, as the Chief Quality and Safety Officer, we look at every single safety and harm event. And so one of the things you may hear today is, well, it's only a certain number of patients. It may only be 20 or 30 patients at Children's. It may be 100 at another organization. You know, the errors that are occurring, they're not happening that frequently. Is it really that bad? So I just want to put a little bit of perspective about how we approach. And again, this is actually a requirement from some of our accreditation and verification organizations, that we not only quantify the number of harm events and those risk events and safety events, but we also evaluate the actual harm that's incurred and actually the risk of harm. And so with that in mind, at the end of the day, if there's a significant harm to a patient that we're serving, we are required, first of all, we're committed to, it's the expectation that I think our patients and families deserve from us, but also we're required by some external agencies to look at every single one of those events. And if there are breakdowns in our processes, we are required to fix them. And we need to provide documentation, not only that we have a plan, but the plan is working as well. So again, it's just, as a Chief Quality and Safety Officer, it's just hard for me to understand how this white bagging process can be allowed to occur when it really kind of runs counter to what we've been trying to accomplish from a quality safety perspective, particularly with medication administration over the past 20 years. And I'll leave you with my final point, which is this idea of, from a quality perspective, yes, there's usually a primary outcome you're trying to focus on, but you also have to understand that a change in one spot has downstream consequences and unintended consequences in other areas. So I think about Landon's story. You say, okay, well, maybe it was less costly for us to procure or secure these medications from a specialty pharmacy. But what if Landon, with his intense pain now for a month, has to visit me in the emergency department? There's a cost to that visit. What if his pain is so severe that despite my best efforts, I'm not able to get under control and Landon is now hospitalized? Again, I will still argue that at the end of the day, my primary concern is the harm to the patient. But if we're going to bring cost into this discussion, let's also recognize the unintended costs and unintended consequences that can occur from this process as well. Thank you.
And Senator Fiskowski, subject to your questions.
Okay, well, I want to say thank you to everybody for their testimony today. It's a very complex issue. And I never want to see a patient not be able to get their medicine at the time that they especially need it, especially with these types of drugs, because we know that these are for some of the most serious conditions out there. On the flip side, as a small business owner and as a small employer and living in the world I do and trying to help people obtain health care as an insurance agent, we are forcing more and more employers to have their people go into these high deductible health plans. So they have insurance coverage, but that doesn't mean they always have insurance care. So costs in the system have to be primary in this discussion also. I do have some questions, and these are going to be directed at the author because they're part of the language in the bill. So all of the testimony here today was around white bagging and that practice, but you did not touch on the discussion of brown bagging and why you are making that part of this bill. Can you elaborate on that, Representative?
Well, brown bagging, once again, that's something that where the medication is now sent to the patient's home. And in many cases, that patient will take that to the hospital and then ask for that medication to be that for many hospitals, like for Reedsburg, and I'll let her cover that as well. They've since outlawed that as well because of the concerns about that medication being in the hands of the patient and the condition of that medication before it is taken to the hospital. So, I mean, I'll let Hannah, because I know she's had actually a very good story in reference to that.
So with brown bagging, the medications are shipped to the patient's home, and then the patient brings those medications to the hospital. And I can tell you many examples where the patients, when it comes to storage of those medications, sometimes it's -1 degree. Those medications are kept in the car, or it's the summer, those medications stay in the cars. We've had many instances where one example that stands out is a patient just brought a bottle with medications mixed in really a paper bag, and they wanted to use those medications. And as we looked at those medications, one was morphine, and another morphine 15 milligrams, one was a morphine 30 milligram tablet. But everything was mixed together. And to the patient, all the pills looked the same. But as we went down to try and identify what was what, if this patient had been given the morphine 30 milligrams, that would have been a disaster. That patient would not have survived. And
the reason I ask this is after I went through, I had stage 4 cancer a few years ago. So I had Nuestra the next day, and that was shipped to my home. And then I went into the clinic and had the injection. And I mean, it was a cost saving. It was 1/10 of the cost by having it shipped to me. And I found it very safe. Let me ask one more question here, and then I'll turn it over to some of my colleagues. So you are basically removing pre-authorization in this piece of legislation. You do not define medical necessity, but you're saying that the insurance company cannot deny anything prescribed by the provider. And pre-authorization is kind of a standard in an insurance contract, and it is done for a cost control. Why are you removing pre-authorization?
I want that physician or care provider to give the best quality, quick care to that patient. And what concerns me is what currently, like white bagging, you have some in the insurance agents, insurance companies that are taking that process and basically questioning that provider's medication delivery, what that patient is going to receive. So I think you're putting somebody that may not be sitting there with the patient, could be 100 miles away. You're putting that patient in the middle of it. You're putting that person in the middle of the provider and that patient's care. And so that's one of the reasons why we put that in. I want people like Hannah making that decision, not somebody sitting hundreds of miles away at a screen saying, well, this is what I'm seeing, where she's seeing it, or one of the doctors are seeing that firsthand.
So what is your definition of medically necessary? Whatever the doctor says.
And I will let a lot of people behind me address that, because there's some pretty smart people that deal with that each and every day.
So how do you find the balance in cost control then? If we're removing the pre-authorization and removing some of the tools that have been a standard in the industry to control these costs, how then going forward are there going to be cost controls in place?
So, Madam Chairman, we've got systems in place whereby we negotiate with the insurance companies. So a lot of times these rates are all set and put in place ahead of time. So it's not a decision that the end user is doing at the point of time before that order is written. We negotiate with the insurance companies, and the payers signed on the dotted line the same way we sign on with the same contract. So those rates are agreed upon ahead of time.
So then the last question I'm going to get around the bill, and I don't know if this is a typo or if this was intentional. And section 9, in the last part of the legislation, when you're going through there, you refer to or clinic of the provider, and you eliminate participating provider. Can you explain why you did that? What the purpose is or what you're trying to get at there?
Okay, what line are you referring to? I'm looking at 9 right now.
So it's line 6 on the last page.
I'm still not seeing it, Madam Chair. I'm sorry.
Okay, so you're on page 5 of the bill.
Yep.
Okay, then you go to subsection 9, line 6. The third word in is provider instead of participating provider. So that's basically taking it, and it's taking it out of network. And I'm wondering if that's a typo, if that was the intent, or why that is that way.
The intent was to keep it in network with the provider.
So it should be participating provider.
We'll work on that. We'll have some other people talking about that.
Okay, thank you. Questions from committee members? Senator Ringhand.
Thank you, Madam Chair. Dr. Spahn, you had mentioned CMS, and I know I served on a hospital board years ago.
Yeah.
And I know how thorough and intense those reviews are. Could
Yes.
you explain some of the issues that this creates for your passing those exams?
Yeah, so essentially, yeah, so thank you for this opportunity to kind of expand a little bit on that. So, and at the end of the day, we take responsibility. If it's a patient that we are caring for, we take responsibility ultimately for the outcomes. And as such, accrediting bodies, the Joint Commission being one of them for overall kind of scope of services and provision of services. But like many other health systems you're going to hear from, as a pediatric health system that's a level 1 trauma center, the American College of Surgeons comes in and it basically, gives their verification that we can continue to provide trauma care as a certified level 1 trauma center. That's just one example. Honestly, even as the chief quality and safety officer, I can't keep track of all of them because it's amazing how many, but they're all consistent in what they're looking for. They may be in a specific domain or, like trauma, but they're all looking for the same thing. And that is that we are constantly assessing our systems and processes, that we're identifying when they're breaking down or when there's risk of harm because of breakdowns. And number one is if we don't have a process in place to do that constant assessment, that's an automatic, you don't pass go at that point, okay? Then as we start to assess that and we identify where we can get better, because the reality is that there will be new challenges that come up to us in healthcare delivery all the time. The complexity just goes up year after year. Specialty drugs is one example of that. These are highly complex, patient-centered, individualized drugs in many cases. So the complexity of getting the exact thing to the exact patient at the right time is so critical today. And so with that in mind, our requirement, when the Joint Commission comes in, they look at as many processes as possible. And they look for breakdowns in those processes. They look for data that shows that we're reliable with those processes. And if we either can't demonstrate the data that those processes are reliable, or there's harm that our patients are incurring because of our systems and processes, again, our requirement, if we want to pass that certification and continue to provide care either for specific things like trauma or generally, is that we fix those problems. And so it's tense. The Joint Commission visit every 3 years. It's an intense time for us as an organization. But to be honest with you, because of what's happened with quality and safety over the last 20 years, even with the Joint Commission, it's much more of a partnership now. Because of the tremendous strides, and this isn't to be boastful for Children's Wisconsin, everybody else here that's going to speak with you today has done the same thing, because that is our commitment to our patients and families at the end of the day. But that is the risk. And like I said, I'm trying to think of another process where we allow for something to come into the process. So traditionally, I'll give an example. So if we're going to use an implant in the OR, we have a contracted services with that vendor or that company to bring the implant in. Oftentimes that person, that representative is in the OR with our care team. And we have a whole series of contracting components. And then there's actually, one of the things the Joint Commission requires of us is that we actually have quality assessment of that contracted services as well, with specific language that the contract will essentially be severed if they're not able to demonstrate high quality as a partner with us in the care for our patients. So hopefully that helps answer your question, but there's a whole lot more detail around. And like I said, I'm still trying to think of another process. And I even told the group earlier today where this has happened and we've allowed it to happen. So I'll stop there and just see if there's any further follow-ups.
Okay, well, just one further follow-up on that. If you don't pass your CMS reviews, there's also a financial consequence of that.
So, essentially, by and large, we could probably continue to provide care. And again, I'm not in the kind of strict regulatory business. I'm more in the quality aspects of it. But the bottom line is that if we're not accredited by the Joint Commission or DNV or another kind of a federally approved accrediting body, essentially, we're not eligible for reimbursement from CMS. And again, some other folks can probably speak more formally to that, but that's kind of the gist of the risk. There are financial implications.
Right.
In addition to, it's just a reflection that we're not providing the best and safest care that we can.
Thank you. That was what I was looking for you just to bring those issues up and make people aware that there are financial consequences and quality of care issues.
Yes,
If we don't have a clear pathway. So
Yep.
Thank you. I appreciate it.
you bet.
Representative Stashel, or Senator Stashel, sorry.
That's all right. First of all, before we start, we have a room full of people today. And I just want to say that this issue is tough for me. And I'll guarantee before the day's over, I show my ignorance to the inner workings of what you people do. So thank you all for coming. Please take baby steps with a couple of us, myself included. I think that this is an issue that is hard because it's two different ideas. One is saving money and making healthcare affordable. And the other, and you folks are tasked with the best care possible for your patients. And both of those are valuable goals. Representative Kurtz, when you gave your testimony, you said that sometimes they change their mind in the middle of a contract. Wouldn't that then be a contract dispute that these providers are changing their contract in the middle of a contract? Isn't that a breach of contract and therefore a legal issue and maybe not one for the legislature?
This is where and we've heard that quite a bit. This is a much bigger issue. It's back to consumer protection and patient safety. And so we have, I counted it, there's going to be 9 different health systems here today. That's just here today. And when you take that across the entire state of Wisconsin to say, well, like for Reedsburg, what happened to Hannett and Reedsburg Area Medical Center? Mid-contract, they did, hey, these are 22 drugs that we are going to white bag from now on. And Reedsburg Medical Center had no say in this. This is what we're doing, and we'll take our patients elsewhere. And so to your point is, well, let's just do the legal challenge. So you have 9 different systems here today. So now we're going to have 9 different legal challenges to this process. That is my concern. And so my concern, my bigger, and there'll be other people talking about this as well. It's just, it gets back to, this is consumer protection. And if it is one system, which we know we have 9 different systems here, it's not just one system being changed midstream in contract. So
talk to me about, and I agree with you. So if they say we'll take our patients elsewhere, talk to me about what that choice looks like, especially in your district, rural areas, and for that matter, urban areas too.
And all due respect, Senator, I'm gonna let Hannah, because like I said, she's on the front lines.
Yep. So I guess my question is that an actual choice?
Senator, for my patients just got a letter. They got a letter saying that your medication will be white bagged, or call us and we'll come up with some other options. So for some of them, we don't know where they ended up getting their medications or if they got them. We called them to speak with them personally, just to make sure we gave them and shared what their options were. And as I shared, some of them just decided I'm done, or switch me to another medication. And for one patient specifically, that was told, we'll come to your house to give you that infusion. And she said, I don't want anyone coming to my house. What if something goes wrong with me? She was a patient that lives alone, and I did not want other people coming into her house. So she didn't have a choice and asked to be switched to a different medication. But again, it was, as a pharmacist, I know that it was not the first choice medication. I would have.
You said there wasn't a choice, but you just said she had a choice to switch to a different medication.
No, the patient asked if she could be switched to a different medication, but it was not the best.
Oh,
It was not the best. It was not the standard of care. It's not what I would have selected for her to have as a pharmacist.
Gotcha.
Or for my own family member.
Senator Jegler.
Thank you. And thank you, everybody, for coming here today to walk us through. As Senator Stachel said, there's going to be some hand-holding that may be required, an explanation on some of this stuff for me in particular. Dr. Spar, on the situation that you're talking about with the young boy needing perhaps a different amount of dosage per treatment, is there a process in place to allow that? If you have it in your your pharmacy, can you?
Oh, yeah.
I mean, walk me through what happens on that treatment day. I mean, can you do that and then go back later?
Yeah, no, so I really appreciate that question. And it goes back to, again, what we've tried to accomplish with our design of highly reliable and safe systems. And so, again, if we try to minimize the number of steps, the number of handoffs. And so you think about that example. So if there was a child in the hospital and I ordered a dose of medication and suddenly his condition changed, his or her condition changed, simply what I would do is cancel that first order, place the second one. The delivery from that time, from that second order to that child, the only quote delay is the appropriate change in the order. Our pharmacy, again, is stocked with these medications if we know that they're needed by our patients. And we have pharmacists on staff 24/7. And so it's an immediate adjustment to the treatment options. And again, in Landon's story, that immediacy is not possible with this white bagging process.
There's no option for you to do that and then bill later?
We could try to procure that medication otherwise. And again, I'll let some of my pharmacy colleagues talk about some of the inpatient, outpatient components and what's reimbursable and so forth. So at the end of the day, yes. And at the end of the day, would we do the right thing and provide that medication for the patient? Yes, we would. But the reality is that because of the white bagging process, potentially we're not going to get reimbursed. Or potentially, and again, I defer to my pharmacy colleagues, there's some pretty like relatively bright lines between kind of outpatient delivery and inpatient and so forth in terms of kind of reimbursement and how that gets kind of billed and coded and all those things as well. So again, it just introduces some complexity that quite honestly is just not needed and ultimately leads to delays in care.
I'm going to do a follow-up on that. Obviously, it's no secret that we've had the hospitals talking to us, whether it's in our district, outside of our district on this committee, and we've had the insurers talking to us. And Hannah, I want to kind of pinpoint this on you Because in your testimony, you said, but for days and sometimes weeks that this can be delayed. But now our insurance friends that are in the room today, I think they're going to testify to this, that says that there is a clause in most of these contracts, or I'm going to say in all the contracts, I'm not quite sure, that if a drug does not show up, that then you can substitute. Can you speak to that at all?
Oh, sorry. Not that I'm aware of in the contracts that we have.
If that drug does not show up, there's no.
No.
Okay.
No, because if you provide it, you're told that you will not, as he just mentioned, you will not get reimbursed for that medication. And just as an example, yesterday, a friend of mine works in Hillsborough, and medication was supposed to be white bagged and it did not come. And so they called a specialty pharmacy to find out where is the medication. And they said, oh, it's on its way. Can you just take one of your product from your shelf and utilize that? And when the white bagged one comes, just switch it out and take that one. So it's confusing. It is, as he said, we will do what's the right thing for our patients. We will give them that medication and we'll eat the cost and just not get reimbursed, because our patients come out, they've taken time off work. They've rearranged their lives and schedules to get there. And so we will do what we believe is the right the right thing to do, but we cannot simply take a product that we don't know point of origin and take it and introduce it into our inventory. We will not take that liability. Patient safety is key.
Senator Fiscal, that is a good question.
Yeah.
And so in reference to Hillsborough, I know the pharmacist at Hillsborough, and that has happened to him there. The issue is, in some cases, that small rural hospital pharmacy doesn't have that medication. And the fact, they're only, like in the case of Dr. Larson, if he knows he's going to give a medication, he can order that. He's not going to order a medication in these small rural hospitals if, well, I need to order this because it may not arrive on time. And that's where I'll let the other pharmacists talk about that. Because yes, do I think a large hospital system could do that? Yeah, but not a small rural hospital like in you and Senator Safsol's district. That it's a little difficulty for our smaller rural hospitals with a limited supply. And once again, better than I do, they have shelf lives with them too. Mm-hmm. And so he's not going to order something and just I might have to give that. And so there's a little nuance to it. And I know, like I said, there's some really smart people that are going to talk behind me that can address that better than I. But that is a good question, and it's a great point to bring up. So,
Senator Taylor, are you out there and do you have any questions? She's probably at judiciary. Okay. Senator Stashel?
Just one quick follow-up question. I guess, what is the value in white bag? Why did we switch to white bagging? What was the purpose or the goal, or why did that start?
I'm going to let a lot of people behind me address that, because I'm sure they have their reasons why they do that, and I'll let them address that. So,
no further questions by committee? Thank you very much for your testimony. Thank you for coming down today. We really appreciate it.
Thank you very much.
Up next, we have Willard Walker and Mark Gelhaus with Walker Forge speaking against.
Can you hear me now?
Yep, we got you. Thank you.
Thank you. Good morning. It's an honor to be with you. Thank you for giving me the opportunity to offer my testimony. My name is Willard Walker. I'm CEO of Walker Forge, a 350 employee company with locations in Milwaukee and Clintonville, Wisconsin. I'm testifying on behalf of the Coalition of Wisconsin Employers concerned about healthcare costs. And the coalition is composed of a rapidly growing number of employers who are learning about this legislation and are opposed to it. Before I go further, I just want to give you a quick overview of what my testimony is going to be. It's going to boil down to 3 basic points. The first is that the market for healthcare in Wisconsin is broken. It's unaffordable. And this legislation will make it worse by causing harm to employers, employees, essentially the working people of Wisconsin who foot the bill. Higher healthcare costs are a tax on the working people of Wisconsin. My second point is that I'm sad to say, I think this is more about profits than it is patients. And my third point is that the free market and free market principles are the answer to Wisconsin's broken healthcare system, and the free market should be allowed to work in this case. So Wisconsin's healthcare prices are already higher than most every other state in the country. Wisconsin employers and employees are struggling to pay for healthcare, and passage of this legislation would drive up costs even more. The legislation is inherently anti-competitive, and it would force health plans to purchase very costly medications from hospital-controlled pharmacies. And that is going to drive up costs incredibly. Let's be clear on something, you know, and I saw this in the testimony that's taken place thus far. There's talk about the insurance companies and the hospitals. The party with the biggest stake in this fight, in this legislation, is employers and employees. It is the employers and the employees who foot the bill for most of the health care delivered in Wisconsin. And that bill, it's a big bill. It's a very big bill that we cover. For most businesses, healthcare costs are the second largest expense, or in the case of manufacturers, the third largest expense. And it's gotten out of hand to the point where employees really ultimately pay the bill, and they pay the bill 3 ways. They pay it through employee contributions, premium contributions. They pay it through out-of-pocket costs, deductibles, and then they also pay it through getting less wages than they otherwise would. The point being that employers can't spend the same dollar twice. Every dollar that an employer spends to cover increasing healthcare costs is a dollar that can't be spent on higher wages. So it's no secret that wages have been way outpaced by medical premiums and medical costs over the last umpteen years, and that continues to this day. Again, healthcare costs are in essence a tax on employees. Now, I said earlier that Wisconsin has some of the highest healthcare costs in the country. There was recently, in September of 20, a report issued by the RAND Corporation. The RAND Corporation is a nonprofit organization, and according to this RAND report, Wisconsin has the 3rd highest physician prices in the country, the 7th highest outpatient prices in the country, the 10th highest hospital prices in the country, and the 12th highest prices for inpatient services in the country. How did we get here? How did we get to this place where Wisconsin is such an outlier? Well, we got here for 2 principal reasons. The first reason is hospitals have acquired tremendous market power, and they've acquired that by through anti-competitive mergers and acquisitions, of competing hospital systems, clinics, and physician groups. And the second thing that they've done to promote their market power is they've made shopping for healthcare essentially impossible by hiding from the public, by refusing to disclose the prices that they charge for their services. How can you possibly shop for anything if you don't know the price? And then what this does is, predictably, it results in this crazy situation where prices for the same procedure vary widely from one hospital to the next. Often, even within the same hospital system, you can have widely varying prices for the same procedure. But it makes perfect sense because none of the consumers or the employers who contract with these providers can know the prices, or the prices are hidden because the providers insert gag clauses in the insurance company contracts that they sign. So they just make shopping completely impossible. So here we are. The hospital systems have stifled competition through anti-competitive mergers. They've stifled competition by keeping prices secret. And now they seek to fatten their profits and enhance their market power by seeking a legislative ban on employers' ability to control costs through alternative sourcing of specialty drugs. And I should mention, I call it alternative sourcing, not white bagging. White bagging is a pejorative. I don't even know where that term came from. I think it came from, I tried to find out. I think it came from the American Hospital Association. I think they coined the term. Hospitals are keenly focused on this issue of white bagging or alternative sourcing. And the reason why they're so focused on it is because they want the markups. The administrative fee that they receive for injecting or infusing these drugs isn't enough. I mean, one study shows that the markups on these drugs is between, on average, 200 to 400%. Do you know of any businesses that can mark up purchased goods by 200 to 400%? I'm unaware of any. And these meds are expensive before they're marked up. So it's a huge, huge profit opportunity. And passage of this legislation would force purchasers to pay whatever the hospitals charge. Okay, so as bad as it is now with the markups that they have, this legislation would essentially give hospital providers, in effect, a monopoly that nobody could use an alternate source. It's between the doctor and the patient. Now, my company, our company, Walker Forge, is a perfect example of why this legislation would take healthcare in exactly the wrong direction, and why the legislature should instead encourage employers to use free market principles to control healthcare costs. In fact, the state should start buying healthcare using the same kind of free market principles that we do. The message being, don't kill competition, encourage the free market. I want to give you just a very brief history of our company and our experience in healthcare, and I think it's going to be instructive. For most of the last 20 years, our company struggled to pay healthcare costs. It was really painful each year. You know, I would appear in January and tell people what we were going to raise their wages by. And I was always very kind of moderate in doing that because I knew that a couple months later, I was going to be receiving the healthcare renewal. And I only have so much money that I can devote to employee compensation. So I give them a moderate increase for years and years, maybe 2.5%, something like that, maybe even throwing a little lump sum. And And then in March, after we completed the negotiations for our renewal, I would have to appear before them and tell them how much of that increase that I just gave them was going to be taken away when we had to raise our employee contributions for healthcare. And the looks on their faces during those meetings were so disappointing. It happened year after year. I think at one point they even asked if they have to come to those meetings because they knew what was going to be said. And you know, it was just painful. And I got to the point where I really felt like I was failing my employees. And I felt like I couldn't do for them what I wanted to do. And, you know, it reached the point where, well, the other thing I forgot to mention too is not only did I have to raise their premiums, but we would cost shift. Cost shifting is a term we've all heard. Okay, we know what that is. That's raising deductibles. It's raising out-of-pocket limits, raising copays. We did some of that too. So those meetings were really sad. And I finally, fortunately, at a certain point, probably 3 or 4 years ago, I woke up and I learned that the free market, applying free market principles, could be a solution to our problems. And so we redesigned our plan to embrace free market principles and to incentivize our employees to be smart consumers of healthcare. And since then, things are a lot different. I can tell you, in fact, I'm happy to tell you that today, Walker Forge makes healthcare available for free to our employees. We make it available for free, and by free, I mean the care itself, not the employee contributions to the effort. So we do still ask them to pay a portion of their premium, okay? But after that, it's free. They don't have to dig into their pocket if they see the right provider, if they see a high value provider. And that's true for primary care. It's true for specialty care, including mental health care. So if they need a hip replacement, they need a colonoscopy, as long as they're seeing a high value provider, doesn't cost them a thing. Walker Forge can do this because we have taken so much waste and unnecessary cost out of healthcare that we can provide this care for free and still have lower overall cost. We opened a clinic. We're in Clintonville, and we have a choice of one healthcare provider in Clintonville. Kind of goes back to what I was saying earlier about consolidation and the effect that has on competition. We had a choice of one for primary care. And so what we did was we decided the hospital system needed another competitor. So we banded together with 3 other employers and created our own employee clinic. So we've got probably a clinic with 1,500 employees who can now get primary care for free in Clintonville. And the care that the clinic doesn't provide, the specialty care, Walker Forge employees, as I said earlier, can get that for free as long as they're working with a specialty care provider with whom Walker Forge has negotiated a direct contract using free market principles. So, you know, with its free market approach to healthcare, Walker Forge has been able to offset annual healthcare inflation and has now, for the 3rd year running, been able to maintain flat employee contributions for our employees. So we take no more out of a check today from our employees than we did in January of 2020. And my personal hope and goal is to be able to keep doing that. That's really our overarching mission, is to hold healthcare costs flat. And so far we've been doing it. We're on our third year of being able to do that. And during that time, as a result, we've saved an average family, a family coverage employee at Walker, over $1,000 in avoided healthcare premium increases. And what I mean by that is if we had not done what we've done, the premium contributions would have increased by 6 or 7%. And in 2021 and 2022, that would have amounted to over $1,000. Okay. And it was interesting. The other day I was reading in the paper about how the legislature and the governor had put in a $2 billion tax cut recently for the benefit of the Wisconsin taxpayers, which I think is a great thing. I mean, compliments to all of you who were in favor of that. But the thing that struck me is that that tax decrease amounted to about $980 for somebody making $61,000 a year. So what that means to me is that if Walker Forge had not done what it's done with its free market approach to healthcare, the tax cut that we're grateful for from the legislator would have been completely wiped out in 2021 and 2022 by the increase in healthcare costs felt by our employees through the contributions that they make out of their paycheck. And I'm sad to say, I assume that there are a lot of people, a lot of employees in Wisconsin who don't have necessarily employers who are as far along the healthcare road as Walker. And those employees probably did have that tax cut completely wiped out in 2021 and 2022. Now, it's very concerning to me that the Wisconsin Hospital Association, or I should amend that. It's very concerning to me that the legislature, at the urging of the Wisconsin Hospital Association, is considering taking away one of the important tools that Walker Forge and other employers use to control healthcare costs for the benefit of our employees. Alternative sourcing has been an important tool for us, and we've been able to use it quite successfully without interruption, without disruption, without delay. It's been smooth. I can tell you that we do have a very simple policy at Walker Forge. The policy is if the prescribed medication cannot be delivered in time for the patient's needs, then the hospital can procure the drug directly and supply it. The thing is, though, we've never had occasion to act on that policy because we just haven't run into any delays. There have been no delays, no disruptions at all, but the policy is there just in case. The thing I want to really emphasize is we care about employees. We care about our employees and their dependents. We want to make sure that they get the medication they need when they need it. I mean, in this day and age where all employers can talk about is we don't have enough people. Employees are like gold. Do you think any employer, any enlightened employer really doesn't care about delivering benefits to their employees? I think employers are a lot like Walker Forge. They want to do right by their employees. It's not only good business, but it's the right thing to do. But in addition, what we want to do at Walker, besides making sure they get their medication on time, we also want to protect them. We want to protect them from unnecessary healthcare costs that they're going to pay otherwise. Alternative sourcing saved our company and employees more than $170,000 in 2021. And that works out to be about $500 per employee. Walker Forge is an example of what can be achieved when employers choose to apply free market principles to healthcare. And the biggest beneficiaries of that effort are the working men and women of Wisconsin. Our example demonstrates why the state legislature should be doing everything it can to support, encourage, and emulate Wisconsin employers' use of free market principles to control healthcare costs. Now, hospitals want to kill alternative sourcing because it threatens their revenue and profit. I get that. I do. You know, buy and bill, traditional buy and bill is extremely profitable for hospitals. And this explains the growing trend of hospital provider integrated pharmacies. You may not be aware of it, but specialty pharmacies owned by hospitals and health systems and physician practices have more than doubled their market share of accredited specialty pharmacy locations over the past several years. They are rushing into this space. It's a gold mine. This legislation is just not necessary. You won't hear me suggest that it be modified. It's just not necessary to protect patient safety or protect patients from delays and disruption. Employers and their insurance companies all have a strong incentive to have in place policies and procedures and practices to avoid delays and disruption. I would never say that there aren't delays. If it may be before I get out of this chair, I share with you a personal story that happened to me 2 weeks ago. It had nothing to do with alternative sourcing, but I think we all know that delays, especially when dealing with hospitals, it's just a fact of life. It really is. And there's nothing the legislature can do to eliminate delays with hospital care. It just, you could try, but we'd have to take over the entire system. So we have a strong incentive. We care about our employees, and we haven't run any problems thus far. I can just throw out for your information that Walker Forge is not alone. I know on a much larger scale, Purdue University is successfully embracing alternative sourcing. And they're doing it and saving the university system there at a rate of $10 million a year. I did a quick check and saw that the UW system has 2.5 times the number of employees. So, you know, maybe, you know, I know there's all this budgetary pressure with the University of Wisconsin. I bet they could save $25 million a year. Wouldn't that be nice for the taxpayers of Wisconsin? I want to make sure you understand, my employees do not need the WHA and this legislation to protect them from Walker Forge's alternative sourcing program. It's actually just the opposite. I am here to protect our employees and employees generally, because I'm with this coalition across the state, from the WHA and this harmful legislation that will, in essence, act as a tax on my employees. Another cautionary comment that I'm going to offer up is that legislators need to be aware that if this legislation does become law, self-funded employers may be left with no other alternative, no other choice, but to exclude certain high-cost medications from coverage. Most of Wisconsin's largest employers, and there's 600 of them in all, over 600, have chosen to be self-funded. And as self-funded employers, they have the right to exclude specific drugs from coverage. I don't even know, I mean, that to me alone is a reason not to pursue this legislation. And I was racking my brain thinking, okay, well, what if they exempted self-funded employers? I don't even know how that would work. How does that work? How do you exempt certain employees of certain companies and then have the fully insured folks be exposed to this legislation? It's completely unworkable. Employees care about their employees. No employer wants to be put in a position of having to make that kind of decision, but passage of this legislation may lead to this unfortunate result. I'm going to wrap up. You've been generous in allowing me to speak. I appreciate it. In conclusion, I'd just like to say this legislation would cause healthcare costs to increase. It would harm the people who ultimately foot the bill, the working men and women of Wisconsin. The free market is the solution to Wisconsin's unsustainably high healthcare prices. And legislators should stand with employers and employees who want and deserve high quality healthcare at an affordable price, and resist this brazen attempt by hospitals to choke off the free market. Thank you, and I'd be happy to take any questions that you have.
Well, thank you for your testimony, and I just got to do a shout out for the Republican-controlled legislature. As I do sit on joint finance, it's a $3.4 billion tax cut, and it's a $1,200 savings with between property and income to a family of 4 with approximately $80,000 income. Just had to reiterate that.
Fair enough.
Thank you for allowing that. You brought up something, I mean, you are self-insured, and being self-insured, it allows you a lot of flexibility around ERISA and how you can do plan design.
Mhm.
My concern is for all those small employers who are not self-insured, you know, where their employee size does not allow them to go down that road and now are under the constraints. And the insurance companies are their only negotiating tool to help them actually control costs.
Mhm.
And I applaud with what you've done. I had the great pleasure of meeting John Torinos about 25 years ago when John was just starting down this path with Serigraph, and everything that he accomplished and has brought to light around self-funding, transparency, and controlling of costs. So thank you for that. So you testified that you saved your company, I should say, about $170,000 through alternative sourcing, and that you have not had complaints from employees. Was that in the Milwaukee area or was that in the Clintonville area? And does it differ being in that small rural setting of Clintonville versus in the Milwaukee area where you have larger providers?
Well, to answer your question, I believe that the cases that resulted in those savings were in the greater Fox Valley area.
Okay.
As opposed to Milwaukee. Yes, and no, I don't think that that's something that is especially unique, though. In other words, I mean, if we were to encounter that kind of situation in the Milwaukee area, I think it would pretty much work the same way.
Thank you. Do we have questions from committee members? Thank you very much for your testimony.
Thank you.
Up next, we have John Russell, President and CEO of Prairie Ridge Health, Joanne Allig, SVP Public Policy, Wisconsin Hospital Association, and Todd Nova, Paul Render. And Joanne, I apologize if I slaughtered that last name.
Actually, Madam Chair, you got it just perfect.
Oh, thank you very much.
Most people do slaughter it, but that was good.
So I think what we'll do is we'll let you all testify, and then we'll just hold questions to when you're all done. Is that's okay? Thank you.
Thank you, Madam Chair and members of the Senate Committee on Insurance Licensing and Forestry. My name is Joanne Allig. I'm the Senior Vice President for Public Policy at WHA. I'm joined today by John Russell. He is our WHA Board Chair, and he is CEO of Prairie Ridge Health in Columbus, Wisconsin, and Mr. Todd Nova. Todd is a attorney with Hall Render, and his particular expertise is in pharmacy practice matters. So thank you for the opportunity to testify in support of Senate Bill 753, known as Kareen's Law. Sorry, I'm still just thinking about the previous testimony. So 1 year ago, we were largely unaware of this issue of white bagging, and we certainly didn't anticipate that it was going to take up so much of our time and attention. Hospitals and health systems, as you all know, work with, negotiate with, and partner with even health insurance companies on many, many issues. And in Wisconsin, if there has been conflict, most of those issues have historically been worked out between the two parties. But there is a growing trend by insurance companies to unilaterally, without negotiation, restrict patient access to their in-network medical providers. In the case of white bagging, this is occurring at the worst possible time when patients are trying to treat or manage life-threatening conditions. This practice has now crossed the line, and this issue now has changed from a dispute between two parties into a matter of consumer protection, patient safety, and therefore public policy. We agree with the previous speaker, the free market should work, but we are here today because insurers are single-handedly using program changes that are outside of the contract negotiation process that serve to limit access to their medical care providers, to financially benefit their affiliated pharmacies and PBMs, and the limitation on patient access to their medical providers are those providers that are already in network. And this happens both in the middle of the benefit year for their enrollees, their consumers, and in the middle of the contract with the healthcare provider or hospital. What happens then is that the healthcare provider's normal in-house pharmacy is suddenly out of network for these particular medications. Sometimes the insurer will allow the pharmacy to remain in network, but only if they agree, if the healthcare provider or hospital agrees to the insurer's demand for a lower payment. It's important to know that Senate Bill 753 is not about all specialty medications. It is solely about those medications that a patient cannot administer themselves. These are medications or therapies that are processed and then administered by a clinician like a doctor, a nurse, or a physician assistant, and then they're usually infused or injected intravenously. And as Representative Kurtz described, patients receiving these treatments have life-threatening diseases, as you can imagine, cancer, multiple sclerosis, rheumatoid, psoriatic arthritis, all of those conditions that he described. So the normal process, as I think you maybe have gleaned from some of the testimony, is that healthcare providers usually buy drugs from wholesalers, and they can keep a stock on hand in the pharmacy, or they can get a needed drug for a patient within a short amount of time. The prescription medications in question are often costly, yes, and they involve special handling and storage. For example, they have to be kept at the appropriate temperature, light, and humidity. The doctor then, working directly with their patient, determines the best treatment for the patient. At the time of the patient's treatment appointment, the doctor and pharmacist can then ensure that the right medication is available in the right dosage for the patient's needs, often on sort of that real-time basis. And I know there was a question about that earlier, that can't you just adjust the dose? When a prescription is dispensed, and I think Mr. Nova might talk about this, when a prescription is dispensed from a separate specialty pharmacy, it's for that specific patient and you can't change that dose. So the in-house pharmacy can make sure that the right dose is available. Under white bagging then, the insurer has decided that the patient must use only the insurer's designated pharmacy. It's a third party or a separate pharmacy. And it's that process where that third party pharmacy then sends the drug or ships the drug to the hospital or physician's office, where the clinician then administers the drug. It's that process that we call white bagging. And I think it came about because when you go to the pharmacy and you get your drug, it's in a white bag, right? So So that's white bagging. The process of white bagging certainly is not the same as the hospital or physician's office normal process for buying, dispensing, preparing, and administering clinician-administered medications. Compared to the normal process, white bagging requires the entire healthcare team, including the pharmacist, the doctor, nurses, and other staff, to take on significant added workload and risk to provide needed care to their patients. The normal process involves many of the same kind of preparation and many of the those aspects, but this is an added cost on top. And even with their extraordinary efforts, the process is so flawed that they can't always protect their patients from the negative outcomes of delayed treatments and higher costs. The people you have heard from today already have shared some of the problems with the process, and I know my written testimony has more elaboration on that, but I'm not going to go into that here in the interest of time. Insurance companies have said that there are always exceptions to their policies to address the problems, but our members' experiences found that if those policies exist, they're largely inaccessible. As you will hear in the testimony from Corrine Holmes, patients and healthcare provider staff spend hours on the phone with insurance companies. And as you heard from Hannah and board, sometimes patients give up. When policies like white bagging fail, it's the medical care team and it's the patient. It's not the insurance company and their call center employees who are left to clean up the disruption in care. So I would like to get to the question of cost. Insurers will say, and employers will say that hospitals mark up drugs significantly, and that's why we need to white bag drugs. So first, there seems to be this impression that hospitals can just unilaterally mark up the price of a drug whenever they want. The reality is that these prices are negotiated with the insurance company. In this instance of white bagging, it's actually the insurance company that is unilaterally demanding a specific price. Second, with white bagging, the cost to the physician's office or the hospital do not go away. The infrastructure to handle the medication still needs to function. And with white bagging, arguably at an even greater cost. And then white bagging has on top of that, the added risk of harm to patients. Some of the studies that the insurers are using to make their case would suggest that reimbursement for treatment should match the drug acquisition cost, but that is not reasonable or sustainable. The preparation and administration of these complicated therapies involves significant expenditures of time, equipment, and labor capacity of highly trained professionals. One of the studies the insurers point to even acknowledges that it doesn't account for quality, and that the difference in price between the hospital and non-hospital setting for some cancer drugs may actually have to do with the differential in spending on staffing and other dimensions of care that affect quality. Moreover, it's important to know that what hospitals are able to accept in a contract for providing a service needs to not only account for the cost of delivering that care, but also to make services available to anyone at any time of any day. Without hospitals, these services and many others would simply not exist in your communities. That is why the determinations of appropriate rates belong in the contract, where a conversation can be had between payers and providers and employers about what is necessary to maintain a high quality healthcare infrastructure that is needed in Wisconsin communities. And contrary to what the previous speaker suggested, Senate Bill 753 itself is clear. The applicable reimbursement rate for clinician-administered medications is the rate specified in the contract. The insurer might not be happy with the negotiation they conducted, but the reimbursement rate should be addressed through the contract negotiation process instead of through policies that reside outside of the contract, interrupt the provider supply chain, and endanger patient safety. I would also like to touch on some of the other aspects of the bill. Chairwoman Felskowski, as you suggested earlier, brown bagging is included in the bill. we strongly support Senate Bill 753's prohibition on brown bagging when medications are sent to the patient first, and the patient then takes it to their provider, which is, you've heard from Hannah, it has some even greater safety concerns. And the reason why we see that that is related to white bagging is that instead of white bagging, the insurer might say, okay, well, we won't send the drug to the hospital directly, but we're going to send it to the patient, and then the patient needs to take that in. And that's brown bagging, because think about your brown bag lunch, right? So anyway, so home infusion, the other piece of another part of the discussion, when we support the bill prohibiting mandatory home infusion, because we strongly believe that whether home infusion is suitable or safe for a patient should be up to the patient and their doctor. And that decision to administer medications in the home, it can be a good option for some patients, but again, that should be left to the patient and the provider. And what we're seeing is that some insurance companies are instead of white bagging, just denying a patient the ability to get their drug at the hospital and saying you have to get it at home instead. So the bill doesn't, it still allows home infusion, it just says that you can't require it. And then the other aspects of Senate Bill 753 related to utilization management, we support those because we see that limiting the use of those tools solely in this instance of clinician administered medications closes other loopholes that insurers might use to get around the intent of the legislation. So members of this committee, you have rightly expressed past support of the exact issues that are at the very core of this bill. A primary argument used in support of the passage of the PBM legislation earlier this session was that decisions about prescription medication regimens should be made between a prescriber and their patients, and patients should not be at risk of losing access to the drugs they need. We agree. We are asking the committee to apply that same policy position in support of Senate Bill 753. We're asking that you take patients out of this process and ensure that these complicated issues are dealt with through the contract negotiations between providers and insurance companies, not patients. Thank you. I'm going to turn it over to John.
New members, good morning. I'm John Russell, CEO at Prairie Ridge Health, a rural critical access hospital in Columbus, Wisconsin. Thank you for the opportunity to testify in support of Senate Bill 753. I just want to start by saying thank you to Senator Jagler for his past support for hospitals and patients in his district. Senator Jagler took the time to attend a meeting at Prairie Ridge Health in September of last year to discuss the impact of white bagging. There were a number of rural hospitals represented and other legislators present as well. Senator, thank you for always taking the time to listen. You're a class act, appreciate it. Healthcare is complicated. I think we've heard that already. I think it's fair to say that when a patient needs an expensive infusion, it is likely one of the most difficult times in their life. Hospitals and health systems work with patients to coordinate their care, ensuring patients receive the right medications at the right time in a convenient location during a difficult time in their life. As a rural community hospital, access to care for our patients is always a priority. Driving long distances for infusions is a hardship for patients. They generally need multiple treatments at a time when they really don't feel well. These are regular people like all of us in this room. They have families, they have jobs, and they have busy lives. Receiving care a long way from home costs money, time away from work and time away from their family. The health insurance companies have already charged these patients premiums for their coverage. Then when they need coordinated local care the most, they're asking them to seek that care outside their community and away from their trusted care team. Coordination of a patient's care is one of the most important roles a provider plays. We know these people personally. We know their health history and we know their needs. We are an important part of their support system during an extremely difficult time. I believe people need people when they are sick. They need support and understanding. Instead, with white bagging, they are spending time on the phone attempting to navigate a complex health insurance system. This shouldn't need to be the patient's top priority during these difficult times. Their health should be their priority and their focus. White bagging represents a fundamental shift in the relationship between patients, hospitals, and insurance companies. Up until now, we have agreed, all of us, that providing high quality, coordinated early treatment is the best care for the patient and in the end will reduce expense. White bagging appears to be more about reducing costs for the insurance company than quality patient care. This practice takes the patient's trusted clinical care team out of the role of coordinating their care and instead places this burden on the patient. In addition, it greatly increases the risk of providing the wrong treatment at the wrong time. It's a bad precedent. I think it's important to note that coordination of care has been universally accepted as a way to improve healthcare outcomes and in the end reduce costs. Taking the provider out of the equation may save money upfront in this case, but fragmentation of care ultimately leads to poor outcomes and more costs on the back end. Insurance companies have in the past been a part of the focus on coordinated care in the industry. White bagging is a clear departure from this focus and in the end will lead to bad outcomes for patients. This practice has just recently begun. If it is allowed to continue, we will see even more patient harm. Harm due to delays in care can be difficult to quantify, but it is clear that delays in care do cause harm. We already have direct examples of breaks in supply chain custody resulting in improper storage and incorrect dosages received and flagged by hospitals. Some of these have already resulted in quantifiable direct patient harm or near misses. Please don't let this practice continue. Thank you again for the opportunity to testify.
Thank you, Joanne. Thank you, John. Chairwoman Felskowski and members of the Senate Committee on Insurance, Licensing, and Forestry. My name is Todd Nova, and I'm a shareholder with the law firm of Hall Render based in our Milwaukee office. Our firm focuses solely on health law issues nationwide. My legal practice on health law issues for healthcare providers across the country included integrated healthcare systems, pharmacies, hospitals, healthcare group purchasing organizations, and provider clinic organizations. From a personal perspective, I'm both a Crohn's disease patient and covered by private employer-funded insurance. These issues include those affecting the sourcing, delivery, dispensing, and reimbursement of pharmaceuticals. I routinely speak and write on these issues nationally and address specifically issues related to federal and state pharmacy practice matters, government payment issues, collaborative practice models, healthcare licensing, distribution, sourcing agreements, private payer issues, and the 340B drug discount program. My work also includes advising providers responsible for caring for underserved and rural populations. The WHA team asked that I share with the committee core legal considerations that Korean's law is intended to address. My testimony today will therefore address 4 key areas implicated by insurer-mandated white bagging models. These include legal risks to frontline pharmacists and providers arising out of the manipulation of already dispensed drugs, common drug reimbursement misconceptions, distinctions between nonprofit healthcare providers and for-profit health plans, and the role of hospitals as safety net and emergency services providers. Before I go into my prepared testimony, I would like to cover a couple of substantive comments that Mr. Walker made. To be clear, the law as proposed does not remove prior authorization. That process, Chairperson Felskowski, which is a great comment and a fair comment, the process would still remain. If you note in the law, there's a clarification that it would be for covered drugs. That coverage determination would still occur consistent with normal processes. Also, with respect to a pharmacy suggesting from Dr. Ambord's comment that, well, we'll just ship you the drug and then you can go ahead and stock that and give them one of your own. I'm going to talk in some technical detail so you understand why that's not permissible. Dr. Ambord again referenced the DSCSA, the Federal Drug Supply Chain Security Act. There are state law analogs that adopt that by reference, which say that they literally can't put that back on the shelf. So when that does occur, the hospital has to eat the cost. And then finally, with respect to price transparency, effective actually January 1st of this year, hospitals do have their prices and are required to have their prices on the websites. So again, certainly not to diminish Mr. Walker's points, but I wanted to clarify that pricing transparency as part of this will improve. Okay. So I'm going to get into a couple of details. I was sharing my comments actually with my kids and my wife last night, and she said, I hope that there are some people in front of you that are going to explain what white bagging is. It gets pretty technical. I understand that. But in all seriousness, I want to talk a little bit about some of the supply chain security issues. So as you've heard, right, white bagging models require significant pharmacy and pharmacist involvement for the safe drug handling, preparation, and administration. The model, though, only allows for technical component or administration fee reimbursement to the hospital. Ingredient cost reimbursement is not available for the receiving hospital. Instead, a dispensing pharmacy that often has a financial relationship with a mandating payer or benefit manager retains the dispensing fee and the ingredient cost for reimbursement and gives the hospital a limited processing or technical component fee. In spite of what you may have heard, white bagging does not reduce the need for hospital pharmacy and pharmacist oversight. In fact, it materially increases administrative burdens and implicates key legal risks, placing managing pharmacists in the position of having to carefully monitor an institutional process dictated by a third party. More, that third party is the insurer is insulated from direct oversight by our state agencies, including DHS and the Board of Pharmacy, relative to the hospital's pharmacy license. Among other issues, hospital electronic medical records do not have baseline functionality that allows for the automated scanning, tracking, and billing of white bag drugs. For pharmacists who are professionally responsible for the administration of safe, unadulterated drugs, this results in a massive administrative and ultimately personal burden. From a legal perspective, manipulation of drugs that have already been dispensed pursuant to a prescription may only be performed in accordance with FDA labeling. That is, if mandated white bagging requires any non-standard manipulation, as we already heard, like dosage modification, it could be construed to be impermissible wholesale distribution rather than patient-specific dispensing. I know it's technical, but it's an important distinction. Given the complex nature of conditions typically treated in the hospital, it's not uncommon for that manipulation to be required. The distinction, though, between a drug that's been dispensed for a particular patient and one that's been distributed to a pharmacy for further patient-specific manipulation is relevant. It's illegal in Wisconsin and really all states, in my practice covers effectively with respect to understanding federal pharmacy law, all of those states. For a pharmacy to receive a process and then redispense a patient-specific drug is not allowable because it wouldn't have been received via a permitted wholesale distributor. Dr. Amborg talked about the Drug Supply Chain Security Act that is intended to maintain the integrity of our drug supply chain. To be clear, the delivery of a patient-specific drug that only requires reconstitution or manipulation, consistent with FDA labeling, would be permitted. In that instance, the receiving pharmacy would simply be viewed as the patient's agent for receipt. While this raises fundamental fairness concerns relative to appropriate reimbursement given operational efficiency, it would not be legally impermissible. While this may seem straightforward to a layperson, determining whether or not manipulation of a drug is consistent with FDA labeling is not easy. It's a labor-intensive undertaking that must be carried out at the drug-specific level. The task is just not supported by current care delivery models and technologies, as you've already heard. It introduces unnecessary risk into the care delivery system and places a significant burden on hospital pharmacists in particular to ensure compliance with detailed labeling requirements. As such, while white bagging has been positioned as a cost savings mechanism, at best it serves to increase complexity and costs. At worst, it serves to increase the risk of patient harm due to the required implementation of non-standard processes unsupported by information technology infrastructure that exists currently. Let me provide an example. Let's say there was a white bag drug that was received from a specialty pharmacy, or any pharmacy really, as we've heard, the definition of specialty is a term of art. And so that drug was received, comes along with FDA approved labeling instructions that address the mixing, reconstitution, or other actions necessary to prepare the drug for administration. For example, it's not uncommon for an ampule to come in. It has to be cracked, and then it has to be drawn through a filter. It has to be kept in sterile conditions, and then it's injected into a patient. There's a significant amount of risk. The drugs might include a finished dosage product that with the labeling and instructions that state the name of the drug, the amount of the diluent that has to be added, the type of diluent required, for example, saline or something else, the total resulting volume of the solution, the concentration, and the expiration date. It's pretty complicated. In addition, all these activities, as I mentioned, have to be performed under state and federal law governing sterile procedures. The point is that when one of these drugs is delivered in the hospital setting, from a legal compliance perspective and a licensure perspective, there's a lot of work that has to go into it, and that cost is not appropriately recognized. The drug hasn't really just been dispensed and shipped to the hospital. There's a lot that has to happen just to process that drug for administration. Pursuant to the Wisconsin Pharmacy Practice Act, prohibited unprofessional conduct includes a failure to comply with applicable state laws regarding sterile procedures and federal. It means that hospital pharmacies have to obviously observe those policies. And at the end of the day, it's pharmacists and physicians like Dr. Ambord who are required to comply with that law, often at a loss. The compliance with these sterile procedures is a bar that's actually, as I mentioned, raised by the practice of white bagging. Counterintuitively, it's not lowered. Okay, I want to turn and talk quickly about some common drug reimbursement misconceptions. As you know, there are those that have taken the position that hospitals charging very high amounts would naturally result in very high profit margins at the expense of patients directly and indirectly through increased co-payments and payer costs. If these drugs were actually reimbursed at these direct rates, that would be understandable. However, they're typically not. While drug reimbursement methodologies, depending on the age of the agreement, can vary, many older contracts pay based on a percentage of charges, and that's the issue that we have here. Even then, it's still just a limited percentage of charges and very rarely 100%. That being said, more recently, there's been a lot of pressure by consolidated payers to move beyond charge-based methodologies, and they're pushing to implement and very, very often successfully are implementing a negotiated fee schedule or bundled payment rates, right? So there's an episode of care, for example, someone that comes in for a hip replacement, oftentimes everything will be included in that bundled rate. So those negotiated rates, though, will very often be a discount off of average wholesale price, or AWP minus. Drug costs obviously are related to charges, but they're also independently established by the manufacturers. This is a complicated issue, and this addresses a lot of factors. As a result, though, ultimately these charge master amounts that we're hearing about have less and less to do with actual drug reimbursement. Suggesting that charges are equivalent to reimbursement is an incomplete description at best. Distinguishing also between nonprofits, healthcare providers, and for-profit health plans, I think is important. The overwhelming majority of Wisconsin hospitals are tax-exempt nonprofit entities, and Joanne, you can correct me, I think it's only 2 or 3 that are not. This distinction creates different incentives as compared to for-profit entities and results in fundamentally different allocation of resources. For those curious about how revenues are allocated or spent by hospitals, exempt hospital organizations have to submit annually an IRS Form 990. That details the activities, policies, community benefit provided by these hospitals, and information regarding its facilities and businesses that it owns. The filings require disclosure of charity care expenses, community building efforts, bad debt, and as I said, organizational facility structure. Those filings are public, anyone can see them. Among other resources, a review of virtually any Wisconsin hospital's 990 would illustrate the vital safety net emergency and COVID-related services that these hospitals provide. Even if prescription drug revenues support these nonprofit missions, reallocating those amounts to for-profit institutions via white bagging could diminish further the emergency response resources upon which our communities rely, and which are provided solely for the state's hospitals, or relied on, I should say. Also, unlike for-profit payers, a material portion of hospital revenues enable availability of emergency department services, irrespective of a patient's ability to pay. Though already a part of the organic mission of our hospitals, it's required by law. This means that the commitment to frontline emergency services is assured in its longevity. Specifically, Congress enacted the Emergency Medical Treatment and Labor Act, EMTALA, which ensures access to emergency services regardless of a patient's ability to pay. The law imposes obligations on Medicare participating hospitals that offer emergency services to provide treatment for emergency medical conditions. Compliance with EMTALA requirements is in part funded by revenues from all hospital operations, which obviously include prescription drug revenues. To demonize margin on any aspect of care provided, including prescription drugs, is unfair and diminishes the importance of ensuring continued availability of services in our communities. In reality, some white bagging models serve to divert drug revenues funded by patients to payer-owned pharmacies with no IRS community benefit or EMTALA-related requirements. Moreover, white bagging requirements in certain circumstances could frustrate a hospital's ability to comply with EMTALA obligations if, for example, they were required to assess whether or not drug coverage is available. And finally, when read together, mandatory white bagging rules create legal and operational risks for our frontline pharmacists. They rely on common drug reimbursement misconceptions. They fail to distinguish between nonprofit providers and for-profit health plans and ignore the role of hospitals as safety net and emergency services providers. The proposed law is cognizant of the fact that white bagging can be appropriate in certain circumstances. However, the issue here is promulgation of unilateral and broad-based white bagging requirements that create patient risk, divert scarce pharmacist resources, increase costs, limit access to care, and shift savings to for-profit entities not required by law to provide care to our Wisconsin communities. The continued availability of healthcare access in our underserved communities, whether rural or urban, is being impacted. We therefore respectfully request your support of Senate Bill 753. Thank you.
Well, thank you, everybody, for your testimony. Mr. Nova, I have a quick question for you. So when it comes to prior authorization, you said that these are covered drugs, so there would not be prior authorization, so you wouldn't be eliminating it. But yet, in my experience with utilizing healthcare, even covered procedures and covered drugs that a lot of times have to have a prior authorization on it, whether I get drug A or drug B. So you're taking that out where there is no prior authorization. If the doctor or the participating provider says drug A, the insurance company has nothing, and that drug A could be $50,000 or drug B could be 10. And so we're just saying the $50,000 drug gets used. The insurance company has no say in that. So isn't that removing prior authorization?
The Chairperson Felskowski, I'd respectfully disagree. If we look at the law, and we were cognizant of that, it's absolutely a fair question. It's an important question. The law, so subsection B sub 1 addresses participating, it says refuses to authorize, approve, or pay a participating provider for providing a covered clinician administered drug. So the drug, it presupposes that it has to be covered, right? This is about saying, yeah, the drug is covered, but you have to get this drug here. If the drug isn't covered under a plan design, white bagging or no, that would not be required. So for example, there are tiered, as you know, right, with respect to tiers, if the patient has to do a step, right, go through a step methodology where they go from tier 3 to tier 2 to tier 1 to make sure that it's clinically appropriate and it's having the desired clinical effect. If it's covered at tier 3, you have to have it at tier 3. That's a coverage question, and that would still apply under this law.
I think you and I are going to disagree on that a little bit, but we'll probably hear from some insurers on that. So I think we're going to get into some of the tough questions now. And as the insurers come up, I think they're going to have some of those also. So I guess as this has progressed, we've been inundated with different studies that say different things. Do you agree? Yeah. So a lot of these studies are showing that hospitals are marking these drugs up between 200% and 400%. Some even as high when it comes to Medicare, over 300 and some percent of what Medicare. So is it your testimony today that you are not, as hospital systems, increasing the price of these drugs to 200 to 400%, and that insurance companies, by doing the white bagging, are not able to save on the cost of the drug?
Go ahead.
So I'll start. So it's a good question because we have seen all of those studies as well, right? Study after study. I would say a couple of things. One is we could probably sit down and go through each of those studies, and we could talk about, I'm a policy person, I'm a nerd, so I'll go through those and talk about the issues with each of the studies. The 200 to 400% in particular, is concerning because they're looking at that, as Mr. Novak said, in terms of looking at it based on the charges, right? They're comparing it to charges. And if you, as we all understand, charges are not the price paid, right? So in Wisconsin hospitals, in 2020, according to all the information that's on our website, and that's transparent, hospitals received only 36% of their charges across the board. So charges are not what is paid. So if you're looking at some of those studies, I think we have to look at sort of that methodology.
So let me interject in that. So if what you're saying is true, then why would an insurance company, if they're only paying around 36% of the charged rate, why are insurance companies resorting to white bagging when we know a company has an MLR? They have a maximum loss ratio. So that's kind of a cost that's prohibiting them from overcharging on premiums and keeping that. So they can only go to 85% of that, 15% for overhead. So why would the insurance companies want to go down the white bagging road if it's not saving them dollars?
So I would say a couple of things. I hear you on the medical loss ratio. I think it would be fair, as we're looking at all of healthcare costs, to go back and look at how the medical loss ratio is calculated. You can look at over the years, the rules and regulations and what goes into the benefit side versus what goes into the administrative side. In the case of white bagging, we also know that many of the insurers have financial affiliations with the PBMs and the pharmacies, right? So to the extent that they're able to sort of have that financial affiliation, we don't know what happens to the MLR under that. Is it a way to sort of shield those benefits and the profits they make from that from having to be part of the MLR?
So I'm going to just say something right now, and I have a hunch a lot of my colleagues would agree with me. I think there's one thing that we're missing, whether it's on the insurance company side or the provider side, and that word is transparency. Because we are being asked to make a lot of decisions up here around hospital markups, what's being charged, patient protection, and we're kind of flying in the dark on this one.
So I would say we're flying in the dark in terms of obviously what the insurers are paying the specialty pharmacies, right?
Yep. And how do we really know what you're charging?
And
we got to take your word.
There are steps being taken to sort of have greater transparency. Hospitals have to publish their prices now, and all hospitals have been taking steps to meet all of those requirements. So that is on the hospital side. The insurers, I believe they were supposed to have done that this year, but I think they've got another delay from CMS to be able to do that.
Okay, I will defer to my colleagues here. Questions? Senator Jagler.
Thank you very much for your testimony. This is a situation where, as the pool of private insured patients continues to decrease, dollars are much more important. And let's be honest, that's a good deal of what we're talking about here. The legislature is constantly put in the role of picking winners and losers in this argument, and employers still seeing their costs go up, patients continue to see their costs go up, your bills continue to go up. The problem is not getting, this bill is like a microcosm of what is really wrong with our healthcare industry in this country. Now, having gotten off that soapbox for a minute, the last line of your testimony, you said, "We are asking you to take patients out of this process and ensure that these complicated issues are dealt with through contract negotiations between providers and insurance companies, not by patients." If there is no legislative fix here, if we were not here, if we were out of session, we're done, we can't resolve this issue, we're not going to take a vote on this issue. If that happens here, and it comes back again next session, nothing happens, what do you foresee the market, or as the contract negotiations between providers and insurance companies, how do you see the fix happening? I mean, surely something's going to happen because you're not getting the satisfaction of the dollars that you need. What do you foresee happening?
Well, I think these policies have been mandated so far, And so I think that hospitals are trying to make it work as best they can. And they are going to continue to see patients having treatment delays and having all of the complications that you've already heard and that you're going to continue to hear today. So I think that from our perspective, the sooner the better, right? Because patients are being harmed by this practice.
No questions.
Mr. Stashel.
So take,
Madam Chair. Oh, sorry, go ahead.
No,
Me?
one and then two. Sorry.
my apologies. So taking off what Senator Jagler said, and I asked Representative Kurtz earlier about the contract negotiations, and if this is under contract, and then the insurance company comes in and says, okay, but these are the white bagging policies that we're going to implement, that breaches the contract. That's a breach of contract. So tell me, why is the legislature involved in a contract? We try really hard to not inject ourselves into private contracts.
Right.
Some of
And so maybe I can kind of describe how the policies come about. So in the contracting process, normally there is a mechanism where insurers can make changes over time. And those are typically claims processing. Here's how you process the claim. So there are these bulletins and these policy changes and process changes that can come out monthly from insurers, and providers are always watching those. What has happened is that the insurers are really pushing the envelope on those changes. And this one we think really does cross the line. This one is not just about a dispute between the two parties. This one is about patient safety. It is about consumer protection. And so we see that's why this has become a public policy issue.
Right, but if you have a contract and you say, okay, as the hospital, our duty is to provide quality care to the patients, and this breach of contract doesn't allow us to hold up our end of the agreement, that's a contract breach between you and the insurance providers. Tell me how that ends up in the legislature. And I understand consumer protections. I understand that, but this is a pretty well-defined contract. I mean, there's some pretty intelligent folks in this room and outside this room that are support in the legal world and legalese. This is a contract that you all have agreed to and signed. You probably don't love all of it, which probably means it's okay.
They probably don't love all of it either, right?
Well, and that's what I find in this building. If we have a bill that nobody loves 100%, it's probably a pretty good bill. So, unless we love it all. But the point of that is, tell me why the legislature of the state of Wisconsin should inject themselves into a private contract dispute.
I will try again. As we look at this at white bagging, we don't see this as just a dispute, a reimbursement issue. If this was just about the reimbursement, that would have to be taken care of during the contract, right? But this is a practice that interrupts care, that puts the patient in the middle, that requires enormous added cost to the system, that requires patients to have treatment delays to their already in-network providers. And so that's why we see this as a higher level public policy issue, not just a dispute between the parties.
And if I may make a comment about that as well, it's a fair question. It's an important question from a technical perspective. The way that it's typically addressed, given the changing nature on an almost daily basis of care, the payer contracts will refer to a payer manual. Payer manuals now they're online. They're typically long and they can be unilaterally changed. with some consolidation that's been in the industry, there's not necessarily meaningful ability to address some of those provisions, but it in some senses, it can be a circumvention. And this is about mandating and helping support the oversight of the hospital licensure requirements, whether via DHS or the Board of Pharmacy. It is putting, in certain cases, hospitals in the position of having to make some very difficult technical choices and devote significant resources, often at a loss, to properly maintain, manage, track, and do all of those things for those drugs. So from the legislature's perspective, in my view, this is less about a private right of contract and more about the regulatory oversight of care delivery models being incentivized, or in fact, in many cases, or most cases, mandated by third-party payers.
Okay, a follow-up question with you. Actually, it's not a follow-up. I had a separate question for you. Early in your testimony, you used the term non-standard manipulation. Can you give me a definition of term for that, please?
Yeah, absolutely. So, and I tried to go, so FDA, when the FDA approves a drug, it has labeling, and it will discuss what's necessary to prepare the drug. So a drug may be in a powder form, a drug may be in a concentrated form, and then go to a facility and then have to be mixed with a certain concentration of saline. That's permissible. Okay, that when the drug's been dispensed from a pharmacy and they say, okay, you have to, and it's consistent, and then you have to do something that the label says. For example, in a home infusion setting, that happens all the time. That's okay. That's less controversial. A non-standard instance would be, for example, if you have a vial of 500 milliliters of a drug, and you don't know if the patient's gonna, because it depends on their then current labs, day of labs, if they're gonna get 430 milligrams, if they're gonna get, or milliliters, if they're gonna get 470 milliliters, it's to a certain extent, then it becomes a subjective question relative to the practice of pharmacy about whether or not that drug was in fact dispensed or if it was distributed. So if a drug is dispensed, it has a patient-specific label, it cannot go back on the shelf. That's pretty clear. And you have to do something to the drug that's not listed in the label. That's non-standard, and that implicates Pharmacy Practice Act restrictions.
Thank you. One final question if I can. And I don't know who exactly I had to direct this to, but you folks, it's an association of the hospitals, which is a great association, a lot of friends in the room. In my head, I'm questioning, because in the state of Wisconsin, we have health providers that also own health plans. What do those folks say about this bill? Like, for instance, UW Health owns Courts, SSM Health owns Dean Health Plan, I believe. Where are they at on this? They're coming next. My apologies. We'll ask.
Senator Ringhand.
I have a little more simple question. A few times it's been mentioned that patients had to go on the telephone and make calls to try to find the drugs. Could you explain how that happens and how a patient would even know where to begin that process if they had to do that?
Yeah, it's a good question. It's a complicated process. So normally we would coordinate that care. If that drug was coming from our pharmacy, we would get that drug shipped in. We would make sure everything was in place prior to the patient's arrival, make sure that they get the medication that they need that day, the amount that they need, depending on labs, other things like that. When we're taken out of the mix, the patient gets put in the position of coordinating that pharmaceutical. And they get put in the position of trying to figure out when the medication will arrive, what happens if in fact that medication arrives and now it's not the right medication or it's not the right amount. And as we all know, this system is complex between the health insurance companies and the hospitals and health systems. It's definitely a complex system, and it's very difficult for patients to navigate.
I can understand that, and it just boggles the mind. Where would you even begin? You know, as an average person, and it's no secret that a lot of people with major illnesses are elderly, which further complicates that issue. So I can see where it would be a real.
I think you'll hear the Holmes family comment on how difficult that process is for sort of the average person to jump in and try to coordinate that for themselves.
Okay, thank you.
I got a couple follow-ups, and Mr. Nova, because you're the attorney in the room, I'm gonna direct these at you. In the bill, I asked this before, Was there a reason why, and I'm gonna assume, and this is not a bad thing, that the hospital association was involved in the drafting of this. So is there a reason why medically necessary was not defined in the bill? Does that not just leave it wide open to anything? I mean, we have a lot of definitions in here, but that one was left out, and I'm kind of curious as to why.
Yeah, it's a fair, it's a good question. Medical necessity, it's not a term of art, but it's one that's been developed and discussed, as you know, I'm sure, at great length in common law. And it's a subjective determination. I think it's very difficult to prescribe what that term means, but it is a very commonly used, commonly understood, and very, very heavily litigated and vetted terms. So I think you need to be careful about being overly prescriptive when drafting legislation, because that term medical necessity is something that in many cases is best left to providers. Now, whether that's the prescribing provider or a medical director in an insurance company who also has a valid clinical opinion, that would be something for those individuals to determine.
Okay, and then one further question, and we actually looked this up, and good Lord. On page 4 of the bill, it require encourage the clinician administer drug to an enrollee policy holder or insured in the manner that is inconsistent with the supply chain security controls and chain distribution set by the Federal Drug Supply Chain Security Act, which doesn't go into effect till 2025. Can you talk about that a little bit? The way, I mean, we started to look at it, and I am no way an attorney, but that seems to be between the wholesaler and the retailer. And how would that apply here, and why has that been added in?
Good question. Those internal references, right? You end up flipping pages. That certain parts of the DSCSA don't go into effect until 2025. Certain parts are in effect now, and so the DSCSA addresses that what I was talking about earlier with respect to redispensing of a drug. So things that are done outside of what the FDA approved labeling would require, patient-specific dosages, things like that. The purpose of the DSCSA is to make sure that drug supply chain is not interrupted.
Okay.
So for example, taking a drug, dispensing it, shipping it to a hospital, and then doing a bunch of additional things that could be viewed as redispensing, depending on how it's done, that would be prohibited by DSCSA, as we call it in short. So that's the reference, and it was in my view, it's an objective reference that's and Dr. Ambo referenced it earlier relative to the pharmacy in the Northeast that was the result of this. That's New England Compounding Center, where they had adulterated drugs that had fungal contamination and then were injected into a number of patients, and a number of patients died.
Okay, thank you.
Sorry, Chairwoman Felskowski. So I think the purpose of including that was because we had heard from some other states that there was a concern that somehow hospitals were trying to get around the DSCSA. So we just wanted to make it clear that wasn't the intention.
Okay, thank you for that, because I started reading that, and good Lord. It was a nap right there. Thank you do we have any other questions? Senator Taylor, I haven't asked if you're out there. I know you have judiciary. Okay, thank you very much for your testimony. We really appreciate it. Up next, we have Tim Lundquist with Wisconsin Association of Health Plans and Pat Corey with Courts speaking against.
Thank you, Chair Felskowski, members of the committee. Thank you for the opportunity to testify today. My name is Tim Lundquist. I'm the Senior Director of Government and Public Affairs at the Wisconsin Association of Health Plans. The association is the voice of 12 community-based health plans that serve employers and individuals across the state in a variety of commercial health insurance markets. I'm joined here today by Pat Corey, who's the Pharmacy Director at Courts, a community-based health plan with offices in Madison, Sauk City, and Onalaska. In a few minutes, Pat's going to speak about court's perspective on issues related to clinician-administered drugs. But I would like to first provide a few comments on behalf of the entire association. First, the Wisconsin Association of Health Plans is opposed to Senate Bill 753 because the legislation removes nearly every existing tool health insurance providers have to encourage lower cost, higher quality, and more convenient drug administration. Chair Felskowski, you've asked some questions to this point. The bill has implications far beyond white bagging, which is why some health insurers, even if they are not currently engaging in some of the practices under discussion today, are so concerned about this proposal. This bill directly asks the committee to decide whether white bagging and other payer strategies used to combat the growing cost of clinician-administered drugs should be permitted to continue in Wisconsin. But the breadth and complexity of this bill implicitly also asks this committee to answer many other important questions. Is it appropriate that this bill creates a special class of drugs that are to be administered and paid for unlike any other medical service, prescription drug, or medical device? Should this legislation toss aside every medical management tool currently used by health insurers for a rapidly growing class of high-cost specialty drugs? Is this the approach Wisconsin should take if we are collectively interested in ensuring patients receive high-quality, evidence-based care? Does this legislation help Wisconsin patients, families, and employers who are already struggling with high prescription drug costs better afford the care they need? Second, association member health plans take different approaches to the purchase and administration of clinician-administered drugs. Some member health plans have a white bagging program, while others do not. Some member health plans use white bagging for a subset of high-cost specialty drugs, while others use the strategy for a more limited set of drugs, and sometimes only at the request of providers. Sometimes providers request drugs be white bagged. However, while association member health plans may vary in the extent to which they use white bagging as a tool to safely manage the high cost of clinician-administered drugs, there is one practice that does not vary. Every insurer with a white bagging program has an exception process in place to prevent the disruption of patient care. It is in everyone's interest, including a health plan, to ensure that patients have timely, safe access to the treatments they need. Finally, as you've heard and we'll hear again today in other witnesses, the impact of this proposed legislation does not start and end with health insurers. Employers and employees ultimately bear the high costs of clinician-administered drugs through higher health insurance premiums and out-of-pocket costs. Community-based health plans are committed to ensuring their members are able to continue to access the right care at the right time, at the right setting, and at a price they can afford. We respectfully ask the committee to not take away tools many health insurers, and more importantly, their customers, use to try and achieve these important goals. With that, I'll turn it over to Pat.
Thanks, Tim. Good afternoon. Thank you for this opportunity. My name is Pat Corey, as Tim mentioned. I'm going to start just a little bit of my background in that of courts. I've been a pharmacist for 29 years. Earlier in my career, I was in a clinical practice setting. I was a clinical pharmacist in the cardiology unit and cardiac ICU at UW Hospital and Clinics. I then transitioned over to managed care. So I have had the opportunity to see both sides of issues such as the one we're talking about today. I feel lucky to work for Courts. Courts is a provider-owned and integrated managed care plan or a set of managed care plans co-owned by 4 healthcare systems with a presence in Wisconsin: University of Wisconsin Hospital and Clinics, Gunderson Health System, Unity Point, Meritor, and Advocate Aurora Health. And as such, their goals, our goals are the same as their goals. And that is really to achieve the best possible health outcomes for our members. And what role does Courts play in an integrated delivery system? It's really value management. We think in healthcare of value as being the outcomes our patients achieve divided by the cost it takes to get there. So anything we can do to improve those outcomes increases value for our customers. Anything we can do to mitigate increasing costs without improving outcomes or to decrease costs and get the same outcomes increases value. And we really think value is a patient-centric goal Because if we fail to manage for value, as we've heard earlier, that puts individual members and employers in a very difficult position as how do they manage those unsustainable costs. It takes more out of the patient's paycheck to pay for healthcare, out of the member's paycheck. And it also leads to decisions to buy down benefits, which means higher cost shares, higher out of pockets, as well as moving to high deductible health plans. So that's core to our objective here. So our challenge that we're facing, I think everybody is familiar with, is the costs imposed by specialty drugs is driving healthcare cost trends in an unsustainable way. Specialty drugs do represent significant innovation and positive outcomes for members, but come with a big price tag. It's about 1% of our pharmacy claims and about 48% of our costs today. But more importantly, it's the majority of our year-over-year trend. So if we take away that 1% of drugs and just look at the other 99%, we're not experiencing significant cost trends. Now, unique to clinic administered drugs, which is the focus of this legislation, those drugs that are administered in a clinical setting, usually infusions or other types of administrations, our particular challenge is that the traditional means of reimbursement, as we've heard, is a percent of charge. So the provider bills us a certain amount for a drug, we pay a certain percent of that. That percent that we pay is negotiated in part of a contract, but the amount they charge is not. So that markup on a drug is a unilateral decision by the provider. Now, what we've seen over the years is that percent of charge has grown. Several years ago, maybe this dates me, but 1.5 times, 2 times the cost of the drug was what you typically see. Today, our average charge we receive from providers is around 3 times the cost of the drug. What we see as high as 5 times and even more, not infrequently. So if you take this growing list, growing utilization and growing cost and growing number of new specialty drugs, so these very high cost drugs, and then you add on this multiplier effect of a provider markup, that creates an unsustainable situation. You think about it, a 3-time markup on a $1,000 drug probably isn't that big of a deal for overall healthcare costs. But if you mark up a $50,000 drug 3 times or a $100,000 drug, we even have a $2 million drug on the market now. That's when it becomes a significant challenge. We were digging through some claims data this week and came up with one example just to share a claim for ravulizumab or Ultomiris. It is a treatment for atypical hemolytic uremic syndrome. The CMS average sales price, and just for a little background on that, average sales price is a number computed by CMS that's meant to represent the average provider acquisition cost of that drug. So they collect data from manufacturers, from wholesalers, and it's supposed to represent the net of discounts excluding 340B. The CMS ASP meant to represent that average acquisition cost for that drug was $70,444. So it's an expensive drug, right? The amount that courts ended up paying after the provider markup and then the percent of charge that we apply was $105,000. So that was a $35,000 markup on a single drug. And mind you, this drug is administered monthly. So for this one patient going in for this one infusion once a month, it'll be close to $400,000 margin per year. That does not include administration fees, labs, or any other services provided in conjunction with that care. So yes, the percentage charge is built into the contracts, but this growing markup on these drugs creates a challenge, and it's just really not sustainable. So what are we doing about it? I want to mention that during discussions today, white bagging has sort of been presented as an all or nothing approach. That might be deployed that way sometimes by some payers. It's not the approach that courts has taken, or that it's always out there. We include outsourcing procurement of drugs, or otherwise known as white bagging, as part of an overall program, but it's only a portion of it. So first and foremost, we've attempted to negotiate with providers to move from a percent of charge reimbursement schedule, which is frankly archaic and doesn't represent the sort of price structures that we have in the marketplace today, and move over to an ASP plus methodology, which is what CMS uses. Take the average sale price, which is actually an externally valid benchmark that goes up and down with the actual net prices of drugs, and add a reasonable markup to that ASP. That's our, preferred option. If providers who accept those reimbursement terms, and we've had success with that, nothing changes. Patient continues to get the drug the way they always have. The provider continues to procure the drug the way they always have. For providers who, after negotiations conclude, not in the middle of negotiations, but only after negotiations conclude and we don't come to an agreement, we do use an outsourced solution with an external specialty pharmacy. And that external specialty pharmacy is not owned or affiliated with courts or any of our owner affiliates. And in that situation, when a medication is needed, that specialty pharmacy ships a patient-specific supply of drug to the provider to administer. The specialty pharmacy then bills courts instead of the provider buying and billing. Now, we respect, and based on a lot of testimony we heard today, that a lot of provider systems do not want to do white bagging. They do not want that administrative work within their health systems. And in those cases, we deploy a third component to this program, and that's home infusion. And a healthcare professional goes to that patient's home, they infuse the drug in that patient's home setting. So we very carefully and deliberately selected the drugs that would be part of this program to make sure that what was going to happen with patients was a safe approach. And of course, our goal is to save on cost, but not compromise outcomes. And as a health insurer, if we did something to save on a drug cost, but only cause poorer health outcomes, of course, we're on the hook for that too. So that's not really a winning solution. So the drugs we selected do not include acute care drugs. Anything that would be needed in a shorter time frame than what this system could provide for would not be part of our program. It doesn't include any drugs that patients may have labs drawn the day of therapy, and the dosage might be adjusted or the drug might be withheld if their labs would indicate such. We don't have any oncology drugs in our program. And for home infusion, we only have drugs that would be clinically appropriate and safe to be administered in a home setting. We also, as Tim mentioned, have exceptions policies in place. So in any case, if there's a misstep in the process, whether it's the provider or member or specialty pharmacies somehow not taking a step that should have been taken, and the patient shows up, they're at the clinic and they don't have drug on hand, we can make an exception for the provider to administer that drug and bill the courts in the normal fashion. So, white bagging again isn't the entirety of our program. It actually serves a small portion of the focus of the program, but it is an important tool that taking that away would compromise our ability to manage for value for our customers. But I do want to mention that the legislation, as there's already been some discussion about, goes significantly beyond white bagging. With respect to home infusion, not only does it allow us to prevent us from requiring home infusion, it also prevents us from having incentive programs whereby some of the savings that we might achieve could be used to incentivize customer members to take advantage of that opportunity. With regards to prior authorization, I'm not sure about some of the discussion today, but to me, the legislation seems pretty clear that it would prevent us from prior authorizing covered drugs. We use prior authorization as a tool to make sure that some of these high cost drugs are used where there's evidence to support their use and where it's appropriate for that patient, and not where there isn't evidence or where there's a more cost effective alternative. So the term covered drug, all these drugs are covered under the benefit with prior authorization being a step to get there. So if that's just simply language that needs to be amended to reflect what I was hearing earlier, maybe that's what needs to be happened. But I'm very concerned as I sit here today that it would prohibit our ability to have prior authorization on medical benefit drugs. And you can imagine a $2 million drug being administered with no check on whether it's being used for an indication where there's evidence to support it's going to help that patient. That's just not sustainable for our system. So with that, I conclude my comments and welcome any questions.
Well, thank you. So earlier, Hammett from Reedsburg Medical Center testified that there was no option for them to use the drugs on their shelf and then be reimbursed for them. And you're sitting here in front of us saying that, as far as you know, all of the plans have options for that?
I can't speak for any other carriers besides courts.
The courts does.
Our program, our first prerogative was to sign contracts with the providers to not have to change anything other than the reimbursement terms.
Okay, and then when you talk about CMS, so are you saying that CMS, the average sale price, is that on a Medicaid or Medicare? What?
Well, it's just the pricing benchmark index that they use to base their reimbursement on. So the index on its own just is meant to represent the average price a provider purchases a drug for. They then take that and build it into the reimbursement methodology for Medicare. And right now, Medicare reimbursement for drugs is ASP plus 6%,
Okay,
unless it's a 340B drug, in which case
Okay.
it's ASP minus something, 28% or something like that. So what we are doing is taking the pricing benchmark and applying, negotiating the plus. How much of a markup over ASP is appropriate, not at the Medicare rate, but that's the negotiated part, but meant to get to a market competitive and reasonable position.
and then when you said 1% of, are these the infused drugs, clinician infused drugs, make up 48% of the cost of the drugs, 2 quarts?
It's 1% of our overall prescription claims, drug
Oh, okay.
claims, yeah.
Make up 48% of the claims overall.
1% of the claims make up 48% of the cost.
Okay. Sorry about that. Yep. And then I'll stop right there. Questions from committee members? Senator Ringham? No, thank you very much for your testimony.
Thank you.
Thank you.
Up next, we have Corrine Holmes, Nate Holmes, Andy Bagnall, HSHS Wisconsin, Jessica Google, Previa Cancer Center at HSHA Sacred Heart Hospital, and Representative Jesse James. And you guys can just fill up the whole right across, whichever works best for you. Is Representative James here? Oh, they're on the assembly floor. I know that Representative James might be joining us in a minute. I know they're on the floor. So please go ahead with introductions and then whoever would like to start off.
Okay. Madam Chair and members of the Senate Committee on Insurance Licensing and Forestry, thank you for allowing us this opportunity to testify in support of Senate Bill 753. My name is Corrine Holmes, and this is my husband, Nate. This is incredibly important to me for many reasons. First, I've never had an experience like this before. And after being asked to share my story, it was an absolute yes. It angers me and frustrates me. And most importantly, it hurts me knowing that this didn't just happen to me personally, but that it's also happening to others as well. I'm not just here for myself, I'm here for others who can't be. This is my story. At 31 years old, and 36 weeks pregnant with a 2-year-old daughter, I was diagnosed with stage 3 triple negative breast cancer. On January 27th, I went into the hospital, and on the 28th, we delivered a healthy, beautiful baby boy. The following week, I underwent multiple scans, and then that Wednesday, I started treatment. I had 6 months of chemo, a single mastectomy in August, and I followed that up with 30 rounds of radiation in Madison. Triple negative breast cancer means that there's not a lot of treatment options for me, so receiving my recommended treatment is crucial for the success of my long-term outcome. Keytruda is a newer immunotherapy, and it's basically a triple negative patient's lifeline. On September 3rd of 2021, I was over halfway through my treatment, and my cancer center had called me, not the insurance company. They had told me a brief description about this new policy and how I had to call the insurance to ask for an extension. I spent 2 hours on the phone with a lady from the insurance who had no idea what I was talking about or what white bagging even meant. She expected me to tell her about this new policy that I wasn't even aware of myself. As a patient, it shouldn't be my job to help the insurance company figure out what I'm talking about when I don't even know. I spent 2 hours on the phone crying, frustrated, and extremely stressed out. No patient, regardless of their condition, should have to go through that. The insurance company had said that they tried contacting me, but that wasn't true. Not once did I ever receive a call, email, or letter from them, and not once during the entire duration of this ordeal did I ever get any form of communication from them. The insurance companies say that we have expectations, but that's not valid. The lady at the insurance company had said that she would help me do anything she could to continue my care and that she would call me back. And I never got a call from her. So the following week, I followed up with her. She said that she remembered me and was trying to figure this out and would again call me back. And she once again did not. In fact, I didn't hear from anybody except for my care team about this until my team reached out to me in October saying that I needed to get a hold of insurance because there was nothing else that they could do for me and I was getting denied. I was in Madison at this time getting radiation and there was nothing that I could do. So I panicked and I called my husband who was in a work meeting and I left a message crying about how he needed to drop everything he was doing to help me out. The treatment I received was one that I had to get every 3 weeks and I was approaching my next treatment date. So this became a deadline for me. What I don't understand, and I still don't really understand, was how anybody is okay with this. Not only am I a mom and a wife, but I'm a daughter, sister, and I'm a young cancer patient fighting for my life. And I'm just one person. How many more are out there? I have been with my team since January of 2021, and they know me. As a patient in general, it's crucial that you have faith and trust in your team. And that's exactly what HSHS became for me. They became my family. There was a point where I had to think about leaving them or going X amount of miles to maybe or maybe not get my treatment. And that was scary, frustrating, and honestly unfair. Not only would I have to possibly drain my savings account or file for bankruptcy if I was denied, but now I have to think about childcare, where I would stay, basically uprooting my life and finding a treatment center that would take me in a quick amount of time. This last year was really hard on my family in general, but it was especially hard on my daughter. And thinking about putting her through more hurt my heart. I'm asking you all to please support Corinne's law. This law, I believe, is crucial, and in fact, it is life-saving, and you have the opportunity to help stop this and prevent others from going through what I've been through or worse. Fighting cancer is scary. It's life or death. And I'm thankful that I can say that I beat this, but will the next person be able to say the same thing because of something like this happening to them? Because their medications got delayed or something worse? As someone who had to experience this firsthand, it's very real. Thank you for your time.
Did you guys bring copies of your testimony for the committee? No?
No.
Okay. Well, afterwards, can I ask you to give it to the sergeant staff and then so that the committee members can have your testimony? We'll make copies. Thank you.
My name is Nathan Holmes. I'm obviously Corinne's husband. I want to say, Senate committee members, we're here today to inform you about why this legislation is so important to us and why we are so passionate about this. Although we're the least qualified in the room, we are extremely humbled to be here and to share our story. This is the real world impact and the detriment that was caused by white bagging, and you can hear it firsthand from us. So we've never testified in support of a proposed law or even imagined we would do such a thing. But I hope that sharing our story and our experiences within the last year, not only battling cancer, but also battling the new white bagging practice, helps you to understand why it shouldn't be allowed. Last year was extremely tough for our family. Fighting cancer, welcoming a second child, all while being the sole provider for our family. I'm in a commission-only sales position, which financially is a burden in and of itself. So time away from work, just the time I have to spend on the road, all of those things factored in. All of a sudden, we were faced with a barrier that really came out of nowhere and left us to navigate and to really become our own advocates at a time that I, again, can't explain how difficult it was. Essentially, we started fighting for Corinne's life. In not only figuratively, but I mean, in a race against time. So I'll take you through my experience firsthand. And this starts with the day that I received that voicemail from Corinne. I was at work, and up until this point, everything seemed to be going pretty smoothly. We were checking the boxes, we were getting by, and we were beating cancer. All was great. Unfortunately, I was in a meeting and I wasn't able to answer my phone. And there was nothing worse than getting this voicemail from your wife, who was bawling, and who was completely distraught, telling me that I needed to drop everything and help her out immediately. This disrupted everything I had going, and I was panicked myself. The next call I made was to our care team. And fortunately enough, I mean, I can't thank them enough, but we met with Jess the next day, or met with Jess the next day and other hospital staff. They devoted time, resources, and really a whole day early on a Friday morning in October. So when I arrived, I wasn't sure how my role in this would influence the way that Corinne would receive her ongoing treatment. However, I was prepared to fight for my wife by whatever means necessary. This kind of pertains to what you had mentioned earlier about the experience that a customer or person would have for you, Miss Ringhand. So I called the 800 number on the back of my insurance card because there's no rhyme or reason as to what we were needing to do to continue receiving this treatment. So I called the insurance card number and we're listening to the phone tree, and I was optimistic. I thought, with hope that maybe we'd hear a prompt to speak to someone about the new white bagging policy. I was very much confused as to what this meant for us and why we no longer could get the treatment that had already been fully approved at the beginning of the year. Once again, there was no rhyme or reason to this. This disruption came out of nowhere in the middle of Corinne's treatment, and we were closing in on our next appointment. We remained on the line, and I talked to the first available representative, asking to speak to someone about white bagging and asking to be granted, the first I've heard of this, a continuity of care. This was the first time that I'd heard this terminology or had to start to advocate for ourselves. So I explained in full detail as best as I could what we were talking about. I explained that my wife had been undergoing treatment for triple negative breast cancer with the immunotherapy drug called Keytruda. The representative did not have any idea what we were talking about or what I was asking for. However, they transferred us to a different representative who we were told would be more helpful. This then began the whole story and the process over each time with a new representative. And so, as you can imagine, at that point, we were continually more and more frustrated and disappointed with each transfer. And I have to add, at this point, this wasn't just me. This was the whole staff that, again, devoted their time to take away from other patients within the hospital and to sit next to me on a phone, on speakerphone, calling my insurance company. Obviously, they had much better things that they should have been and could have been doing that day. But again, thank you, Jess, for doing that. And so we would tell the whole story over from the beginning. We were transferred a total of 6 different times and truly exhausted a full 6 hours on the phone, being sent around and around on a goose chase. So even after all of this, we were still unsuccessful. So as the day went on, it felt as if we were at a loss. We were completely unheard and countlessly misunderstood. And there became a point where the staff members and I had talked about seeking a new treatment facility and a new care team in any way we could to continue to get the necessary treatment for Corinne. And at one point I had called Corinne, and then we had to have a dark conversation around, well, what do we have to do here? The possibility of draining our savings account, or even worse, potentially having to file bankruptcy. As we've heard before here now, how expensive these drugs are. We knew that, so we thought, whatever we have to do, we're going to do it. This is Corinne's life on the line. So again, whatever we had to do to keep with our care team was our mentality. However, it was now 3:30 in the afternoon. This was on a Friday, remember, when we finally had received notice that a continuity of care was granted for a total of 90 days. So although we were ecstatic, we started celebrating, and we couldn't really believe it because it came at such a crucial deadline. Although we achieved the outcome we were seeking, I can't explain how much stress and worry and anxiety was riding on this day. And to think about what others who maybe don't have a care team or have a voice in the matter go through is completely devastating, and no one should ever have to experience this. So I ask you, in conclusion, excuse me, please support Senate Bill 753 to protect patients like my wife. Your constituents and possibly you or someone you love could be affected by this. Unfortunately, there are already many stories like ours across Wisconsin. And if you do nothing to stop this, there will be many more, and not all of them may have the positive outcomes that ours did. This could be at the expense of someone's life. Thank you.
Andy, do you want to testify, and then we'll do questions after? Jessica, we don't have your testimony. Did you bring copies? Will you then again to give it to the sergeant staff? Okay, thanks.
Good afternoon, Chairwoman Belskowski and Senators.
thank you for taking time to hear my testimony supporting Corinne's law. My name is Jessica Google. I'm an oncology nurse navigator at the Prevea Cancer Center at HSHS Sacred Heart in Eau Claire. As a healthcare provider, I am motivated by a strong desire to help and make a difference for the patients that I serve. I met Corinne and Nate almost exactly 1 year ago. I'm so happy to be here with them today now that she has completed her treatment and is back to living life. As a nurse navigator, my role is to build trusting relationships between patients and the care team, to reduce or eliminate barriers to care, and to advocate for my patients. I don't think I ever thought that would mean testifying before a Senate committee, but here I am because this issue is so important. A cancer diagnosis is extremely stressful for patients and their families. Having faith in their care team can alleviate much of this stress since providers and patients work together to design each step of the care plan down to the finest details. Policies such as white bagging are not good for patients. These policies take medical decision-making and treatment planning out of the hands of patients and their providers. They are disruptive to the care plan and can lead to disjointed, delayed, and possibly even unsafe care. These policies can lead to patients missing, delaying, or even foregoing treatment. We are talking about treatment that is so important, life-saving even, for patients, especially patients like Corinne with high-risk disease, patients who have so much to live for, like her 2 small children. Additionally, patient safety cannot be overlooked. These policies are prone to a host of problems, including shipping delays, delivery errors, and patient-specific factors that may require dosing changes. Typically, these medications are mixed just in time on the day of treatment to allow for dosing adjustments related to changes in a patient's lab results, condition, weight, or to help manage side effects and toxicities. The hospital pharmacy keeps these medications on the shelf. They're ordered and follow a strict chain of custody to ensure proper storage and handling. White bagging policies cannot ensure the medications don't sit on a dock somewhere in the heat or cold or end up delivered to a wrong location. All of these examples can cause delays in treatment. Treatment delays not only result in suboptimal care and outcomes, but also add to the stress and fear of patients wondering if a delay will cause their cancer to grow, spread, or come back. These policies add so much stress and anxiety to an already extremely taxing situation. The tears and frustration are very real. The hours spent trying to understand what is happening and why are exhausting. This high-level stress impacts patient outcomes and quality of life. For Corinne, fortunately, Corinne and Nate were extremely engaged in her care and have truly been their own best advocates. But the healthcare system is complex, and even with our help, days were spent by Corinne, Nate, myself, and other members of our team trying to appeal the insurance company's new policy. When this much time is spent helping one patient, others may not be getting the time and attention that they need. I know of other patients in our clinic who have been affected by policies like white bagging. And for this type of policy to impact even one patient, it's too many. Please support Senate Bill 753 so that I can continue to help people who need my care. It is devastating to see the look on a patient's face when we explain white bagging and tell them that our hospital won't, for their safety, practice white bagging. Our team is there to provide excellent care. Our hospital pharmacy is integrated with our cancer center, and the medications are on the shelf. We know they are safe because we've purchased, tracked, and traced them. But if we can't administer those medications because they're not from the insurance-directed specialty pharmacy, we are risking short and long-term outcomes, maybe even life for our patients. Thank you.
Madam Chair and members of the Senate Committee on Insurance, Licensing, and Forestry, thank you for allowing us the opportunity to testify today in support of Senate Bill 753. My name is Andy Bagnall, and I serve as the President and CEO of Hospital Sisters Health System. I'm the division president for Wisconsin. Our organization provides high quality care for thousands of patients in Green Bay, Sheboygan, O'Connell Falls, Chippewa Falls, Eau Claire, and Sturgeon Bay.
Many of our patients travel quite a distance from rural areas to receive our care. This means we work hard to make sure that we make the best use of their time with us and not to increase their travel time and costs. Our hospitals are an important safety net for those in our communities who cannot afford life-threatening medications like those that we've already discussed today. A couple comments, in regards, not my written remarks, but in regards to prior questions or follow-ups. White bagging for us is not about revenues or rates. Those rates have already been negotiated. They've already been covered between hospitals, providers, and insurance companies. We have lots of different kinds of contracts in place, as mentioned before, with respect to specialty pharmaceutical drugs. Those aren't all the same, depends on the insurance company. Simply put, from our perspective, this is about safety and quality of care for our patients. Not all insurers are implementing white bagging policies. We find that within our contracts, obviously not stated, but in practice as well. The other question I have is, who is medically managing the patient's care and responsible for the care delivery? I would say the providers in the hospitals. This practice, I know it was mentioned earlier about timely access to care. This practice does not achieve that goal. As you heard earlier, it's not timely and it does not help patient access. Our goal, simply put, is to put the patient at the center of everything that we do in healthcare. Not about throwing them in to figure out the complex medical system that we have today. Patient safety is our number one priority. A hospital, clinics, providers are where patients should feel comfortable and confident and safe in our hands. That was the case for Corrine Holmes, whom Corrine's Law was named after. She expressed to you today how vested she was in her healthcare team at the Cancer Center. Then in July of last year, she was told that she may have to switch care teams. And then suddenly white bagging became as important as her fight for cancer, as if the cancer wasn't enough. We see this every day. Wisconsinites are affected by white bagging, fighting complex medical conditions. The list of the safety of those medications and consistency of patient care is definitely in question as a result of this practice. Since this policy has began, nearly 50 patients of our hospitals have been impacted, and obviously we're just one of many healthcare systems across the state. As you heard, Corrine was one of the fortunate ones who, with the support of her husband, Nate, implored her insurance company to grant a 90-day extension and got it, which was just enough time to complete her cancer treatments. But what if that comes back? Then she's on her own to pay for expensive medications or find another hospital willing to infuse white bag medications. And what about everyone else who is starting treatment or in the middle of treatment? I wouldn't say that patient safety is guaranteed in Wisconsin if white bagging and brown bagging continues. For nearly 150 years, it's been our mission to care for all people through our high quality Franciscan healthcare ministries. Individualized superior care is a standard that we strive to achieve in everything that we do. That is our core business. We set our goal at zero harm. We don't want to harm any individual that comes in the care of our hospitals. That is our standard of care. If our clinical hospital staff cannot control the entire medication handling process from ordering to infusing, the quality of care that we provide is compromised, not in terms of how we interact with our patients or the extensive experience we offer, but rather the level of confidence we also impart if we were to infuse medications that we cannot guarantee the safety of, or that we have to reorder because the dosage wasn't correct or changed since the patient's last visit. Asking a patient to return another day because the medication we ordered was not correct is not high quality care. Recently, one of our patients at HSHS came to us with colitis, was overdue for an infusion. The patient was not aware of white bagging insurance policy, until calling the hospital to schedule the infusion. Because this patient then had to call the insurance company to request an exception authorization, which by the way was something the patient didn't even know how to ask for, our hospital staff had to provide the correct words and phrases for this patient to use when making the request. The infusion couldn't be scheduled. The exemption, if granted, would allow HSHS to buy and bill the drug instead of white bagging. By the time the exception was granted, the patient was a month overdue for treatment and was in such worsened condition that the patient did not respond to the medications. Today, this patient is still not in remission. Most GI patients who have had treatment delays because of white bagging were 1 week or more late for their infusion therapy. Some decided to go on steroids to get through delay until their next infusion. Those steroids come with their own side effects, and our hospitals typically would not use them unless crucial to control a flare-up. Interestingly, this is caused because the infusion treatment was not received. Not one of those GI patients said that they received prior notification that the policy change regarding medication coverage was happening. Many said they felt blindsided and situation caused added stress. Most providers in the markets where HSHS operates hospitals and do not and will not allow white bagging because of the safety concerns. Some insurance plans will not allow an exception to the white bagging regardless of the circumstance. This creates a situation in which patients are advised by their insurance company to seek the infusion from a provider that is approved with white bagging. However, more and more providers do not have the capacity to accept patients who do not have established care with them. So I want to repeat that. We got the patient to an approved white bagging center. That center, simply put, told us if that patient does not switch her entire care team over to that hospital or institution, they wouldn't continue to provide that care. To compound matters, often patients are, well, let me back up. If HSHS will not participate in white bagging and other providers won't accept new patients for treatments, where do they go? How far do they drive? How do they get what they need for care? To compound matters, often patients are well into their treatment regimen when the drug is placed on the white bagging list within specialty pharmacy that the insurance companies work with. Transitioning care just isn't an inconvenience, it's an entire disruption in their care. It forces patients to start over with a provider that they have no relationship with. It causes delays and duplication of services. Hospitals also never know what medications are on the list from month to month. The policy allows insurers to add or remove medications at any time without prior notification to patients or healthcare entities. This puts our patients and providers, colleagues, our care team at a clear disadvantage and adds a great amount of unproductive time as they must call insurance companies to verify the requirement prior to every single treatment. Also, white and brown bagging policy is not universal. As I mentioned before, each insurance company is allowed to maintain its own list of specialty medications. Care delivery is an important workforce challenge. As we all know, it does impact a lot of resources. Our people are a great resource in our system, and this becomes a challenge for us. I do want to call out that HSHS often experiences situations in which the patient is advised by their employer that their plan doesn't necessarily have white bagging policy, yet their insurance administrators applies it to their claim. And so this takes up a lot of our staff time then to educate employers who are self-funded in many cases about their own plan and what white bagging is or isn't. Now imagine yourself as a patient, you're told that you need to contact your insurance company to request coverage of the drug that you desperately need to fight cancer. In Corinne's case, she and her husband didn't even know what to ask for. Their own insurance company asked them, what is white bagging? In conclusion, patient safety, quality of care, and care delivery are most definitely compromised if this continues in Wisconsin. We don't allow it. This is definitely, as mentioned over and over, causes patient care quality issues all the way around. The consequences are great. This practice being implemented kind of unilaterally here are creating substantial care fragmentation problems for our patients, resulting in delayed care and potentially unsafe medications. Again, I went around back with what I said earlier. This is about safety and quality. We take our responsibility for caring for patients very, very seriously. This is simply put bad for patient care. I please just ask you all in short to support Kareen's law and Senate Bill 753. Thank you.
Well, thank you for your testimony and thank you for coming down and doing this. I know it can be a little intimidating. Even as an elected official, I remember the first time I had to testify. Oh my God. So thank you. Can I ask remission?
Cancer-free.
Congratulations. I am a two-time survivor and the last time was stage 4. So congratulations.
Thank you.
And I do apologize to you for what you had to go through. I know how stressful the treatment process is. So Andy, I have some questions for you. So you said you do not allow white bagging.
Correct.
Okay, so I just toured Oconto Falls and I had your pharmacist from Oconto Falls come to some listening sessions that I had in December. And she told me exact opposite, that they do allow white bagging, but they didn't like it. So I'm a little confused on that.
Well, we're not supportive of it. I can tell you
Okay.
that.
Okay. So now we just heard testimony that yes, the percentage paid is a negotiated contract, but the charge is not. We just heard that from an insurer. Will you speak to that a little bit? Because I'm sure as a CEO, you're involved in contract negotiation.
In short, every contract is different. It could be a percent of charge, or it could be a markup of what was mentioned earlier, depending on that rate.
Okay, so
it could be a percentage markup.
okay. So the other thing is you also testified that this is not about the financial reimbursement. It's about patient care. Has HSHS looked at becoming one of these specialty pharmacies with the insurance companies so that continuity of care? I mean, is that an option? Why would we not? As a legislator, I'm wondering why are you guys,
We have chosen not to do that. And that's our own system has decided not to get into the specialty pharmacy business as a system.
But my question is, if this is not about the reimbursement and the money, and it's about the continuity of care, if ABC Insurance Company is saying, okay, we'll pay 1.5% of whatever the APS is or whatever, your decision is not to accept that. Is that correct?
We have negotiated rates outside of that. That's part of our contract with the insurance company.
Right. But instead of them because your insurance, put yourself in my shoes. Insurance companies are here testifying that they're doing this for cost control, right? I've got employers here testifying, don't do this law because it's cost control. Our employees can't afford anymore. You're telling me this is not about reimbursement. It's not about money. It's about patient safety, chain of custody of the drug, the mixing, the liability, everything else. How come we can't, I guess it goes back to Senator Stachel's question. Why is this in front of the legislature? And why are you guys not working this out?
Well, we have a lot of contracts in place that have value initiatives involved, whether that be quality and or other types of incentives to reduce and help deliver, great care, right? We negotiate those rates in good faith on an annual or triennial or biennial cycle, depending on the contract. We take that very seriously. And we do have, not all of our contracts are exactly the same or cookie cutter. We are very open to negotiating with insurance companies on varying contracts that add value for our employers, simply put. For us, this is about safety and quality. This is a policy and a practice that's been put in place that's interfering with our relationship with our patients and is putting patient care at risk. That's where we're stepping in and why this is such a challenge for us.
So also, one of the hospitals that I've visited in the last few months said that they actually have a drug that they have to administer that just blows my mind, is $750,000. So in that sense, they like the white bagging because they don't want to have that drug on themselves. Now, does that ever apply in your hospitals?
I can't say I've run into that situation where white bagging has got into the way of that particular type of a drug. For us, I might not be the best to answer that question, but.
Okay. All right. Senator Jagler.
Thank you. Thank you for your courage. It's interesting. I can't imagine what it's like to have your name on a bill, potentially a law. A lot of testimony today about the chain of custody and safety. And I mean, when it comes to these medications being mailed, being packaged, stored, however, that's all federally regulated, right? I mean, are you suggesting that with white bagging, those steps when that medication goes from point A to point B aren't being followed by the federal regulations? Or if those steps need to be tightened or fixed, shouldn't that be a matter for changing those federal regulations?
Well, that chain of custody is essentially broken, at least in my mind. And I know there's other experts that are closer to that issue than I. If a patient is delivering that medication to us from their home, we can't control
I'm not talking about brown bagging. I'm talking white bagging. I mean, isn't there a problem then with the federal regulations that they're not strong enough? Or
I'm not sure how to best answer that question. I can't, I'm not the best person to answer that question.
Okay.
I'm sorry, Senator Ringham.
Thank you, Madam Chair. Well, thank you for being here today. We really appreciate your firsthand stories. Those are more impactful to us typically than corporate stories. So thank you very much, but sorry for the process you went through. As I mentioned earlier, I don't know how a patient can navigate that system when you have no knowledge or medical background. It really puts you in a difficult position. And then hearing from you that patients that you did find a place to get their treatments were denied unless they transferred all their medical care. That to me just seems totally unethical. And that's the first I have heard of that happening. And do you know if that happens often? Maybe you're not the best person to answer that either, but if you ran across
It's happened in one of our communities recently.
and I don't know if that's a common practice, but it seems like a very bad practice. But well, thank you for being here and testifying. It's very impactful. Thank you very much.
Senator Stasholt.
First of all, I'd like to caution you because a long time ago, somebody called me and asked if I'd like to sit in that chair, and now I'm sitting in this chair. Be careful. But thank you very much for coming, and Senator Ringham is right. Real life implications when we're talking with industry folks on both sides of an issue, and we tend to agree with at least partially both sides of those, to have the real impact of your personal lives and things you've gone through. I appreciate you coming. I just want to say thanks.
Thank you for your testimony. Thanks for coming down. Okay. Up next, we have Cheryl DeMars and
Sarah Haynes.
Sarah Haynes with the Alliance speaking against. Good afternoon.
Good afternoon. Thank you for allowing us to testify. I'm Cheryl DeMars. I'm the president and CEO of the Alliance. And the Alliance was started by employers about 30 years ago as a way for employers to work together to help control healthcare costs while ensuring high quality care that's affordable both to their businesses and their employees. Today, we represent 300 employers across the state of Wisconsin, also in Illinois and Iowa, who work together to do just that, to find ways to control costs and ensure that their employees get the care that they need. Our employers are largely self-funded, as you've heard mentioned today, and I think the significance of that is that employers are paying the cost of healthcare services that their employees use directly. They're not buying healthcare through an insurance company. They're experiencing these costs as they occur directly. And I can say that to a person, the employers that I know through the Alliance are deeply committed to the health and well-being of their employees. And if I may, Corinne, I will just say that I wish you continued good health. You will be in my prayers. I cannot think of an employer who would want to have happen to you what you experienced. That said, I want to just provide a little context, and Will Walker mentioned some of these things, so I will keep this brief and just reiterate a couple of, I think, key points that provide the context for why we're opposed to this legislation. As you'll see in my written testimony, healthcare prices in our country are high. They're higher than any other industrialized country, and that creates a competitive disadvantage for businesses. What's more, healthcare prices in Wisconsin are high compared to the rest of the United States. Overall, we're 10th highest. And when you look at just physician level prices, we're 3rd. That is a significant concern for employers and their employees who are increasingly struggling to be able to afford health benefits. It's not only a burden on employers, but remarkably, medical debt is the leading cause of bankruptcy among consumers, and that includes those with insurance. So it is really, in my mind, no wonder that employers have sought to take more control of healthcare delivery even and healthcare costs by implementing strategies like worksite-based clinics, employee health and wellness programs, and yes, alternative sourcing of high-priced medications when they can do so safely through a provider that delivers the same medication at a much lower cost. I think that's the price and the markup that we see on prescription drugs. And so far I've talked just about healthcare costs, but focusing specifically on prescription drugs, over the last 10 years, we've seen 114% increase. And while some of that increase is attributable to new medications that have come on the market that are life-changing, and we applaud that, another portion of that increase is attributable to the price hikes that come with hospital-administered medications. And that's what's giving rise to this strategy of white bagging. It is really in response to the high prices that we see coming from hospital provided medications. And there's alternatives in the market that provide the same medication at a much lower price. The employers that I know who are using white bagging strategies, and Sarah will talk more about this, are doing so with great care to mitigate the risks that you've been hearing about today. These are not things that we're hearing about happening among members of our cooperative. So in closing, I think passing Senate Bill 753 will in fact limit market competition. This is important. You'll see in my written testimony that hospital markups range from 200 to 400% of the acquisition price, and that through strategies like white bagging, employers are able to realize savings between 25 and 78% of the price of the medications that would have been administered through the hospital. Senate Bill 753 will limit market competition and will make important drugs even less affordable. This is not a step that Wisconsin lawmakers should take. And Senator Stafsholt, I believe it was you that said, why are we in the middle here? I I don't think you should be. I think this bill is unnecessary. And it's coming at a time when even more important life-saving and life-changing medications will be coming to market. We need to be working to find ways to make these medications more affordable to employers and employees, and this bill will do the opposite.
Good afternoon. My name is Sarah Hamus, and I am with NBS Advisors, and I've spent the last several decades helping employers, particularly self-funded employers, who pay their own bills, manage their healthcare plans by introducing innovative strategies to control costs and to give their employees a better experience with healthcare. We know that one of the biggest problems in healthcare is a huge difference in cost for the exact same procedure. And that cost can be anywhere from I can get an MRI for $800 or I can pay $4,000 for it. I can get a mammogram for $150 or I can pay $1,700 for it. And I have no way of knowing those costs before I incur the service. Unlike anything else you buy in your life, any service or product, you know what that cost is, but not healthcare. I know it was mentioned earlier that the hospital price transparency rule has taken care of that. But the reality is the majority of hospitals haven't been compliant. And if they have put it on their website, it's very difficult to find, particularly for a consumer. So that has been very little help at all, when it comes down to reality. And if the prices are on the website, they're pretty hard to find. Hospitals would rather pay the minute penalties put in place than, publish what their prices are. And the price of specialty medication is no different. These costs range from hundreds of dollars to thousands of dollars to tens of thousands of dollars. And again, if we're not alternatively sourcing those, we don't know what that cost is. I've heard a lot today about, hospital markups and maybe, misinterpretations of that or how it really works. Well, I look at claim data and I found a claim, actually 16 of them from a hospital here in Wisconsin for a rather common drug. It wasn't a compounded or complex one that, we've heard about today. And the retail price on that is about $600. Well, the hospital marked it up to $6,000 per drug. So the self-funded employer wound up paying $96,000 when he should have paid $9,600. That's not fair to our employers, and it's certainly not fair to employees either. And what if you are that employee that, it can pay up to $8,700 out of their pocket for these, drugs? And if you're one of the 50% of our workforce who has less than $1,000 in their savings account, what do? That's a choice between potential bankruptcy and skipping your treatment. But that's our reality in Wisconsin, and it is not fair. Patient safety should always be taken into consideration. And my clients have proven that we can do it safely. We have put rules into place, much like you heard today, that through that pre-authorization process, if that claim or if that drug cannot be sourced alternatively and get there on time, or it's the wrong drug or the wrong dosage or something is wrong with it, we back off and let the hospitals do what the hospitals need to do. But most of the time it is sourced on time, it is the right drug, and the pricing is so much less than getting it through the hospital in the traditional way of getting it. But that patient safety has to be there. And Corrine, again, my heart goes out to you as well, but I can confidently say that under a properly designed plan with the right controls in place, that situation should never happen. And the patient safety should be, whether it's in the workplace or through a health plan, always comes first. But let me give you a little more concrete examples of what this savings can mean to an employer. I had one client who began alternatively sourcing their medications, white bagging, as I guess it's referred to here today. And in the first year, they saved 49%, on their prescription drugs of their initial healthcare spend or prescription drug spend. That means they can turn around and give their members access to these drugs at low cost, sometimes even no cost, depending upon the situation, because the savings has been so great. I have another client, a school district, who has not a particularly big one, 400 employees on the health plan, who is on track to save $700,000 this year by alternatively sourcing their medications. $700,000. That's about the ability to hire what, 7 new teachers? Reinstate a lot of programs that they may have cut in the past. And they too share that savings back with the members and provide access to all these medications, every medication that a member might need for either no cost or low cost. That is powerful. And that can happen with just about any client who chooses to, construct their plan that way. Now, I know self-funding isn't for everybody, particularly the smaller employers that the chairperson had mentioned earlier. That is true, but you can't take that free market tool away from us. When we use our imaginations and we look at healthcare differently and use free enterprise, we can make a huge difference for both our employers and our employees. But finding these safe alternatives, it's not just an employer's right in a free market, it's now their fiduciary responsibility to do that. They need to look at how they spend, their money across their entire employee population. But let's think a minute about what happens if this bill does pass. Most certainly, employers are going to stop covering some of these, and that drug that Corrine did finally get access to may not be able to have access to it any longer because employers simply can't afford those prices. I think there's this misperception that employers have an unlimited budget when it comes to healthcare. They've done remarkable jobs, following that healthcare trend and managing it somehow, but generally, like Will Walker had mentioned earlier, by cutting compensation, by taking other benefits away. And that's not fair to them. There is a better way. And some employers actually might consider moving their business out of the state of Wisconsin. They can go one state over across the big pond, but settle in Michigan, where healthcare costs are about $2,000 less per employee per year. If you have an employee population of 1,000 employees, that's $2 million that employer doesn't even need to think about anymore. And they can still get great healthcare. These consequences of passing this law are not good for Wisconsin. Clearly, we've got to find better healthcare solutions, but passing this law is not one of them. Thank you.
Thank you for your testimony. Cheryl, you put out this right here, this study by Peter G. Peterson Foundation.
Yes.
About healthcare cost per capita in I'll say the developed world.
Yep.
So the United States is 2 times the average. Does this study talk about outcomes at all?
Yes, this is just the cost component. The rest of the story is that the outcomes of care in the United States are not better. We're not living longer. We don't have better outcomes of care. I'd be happy to send you the full analysis, but we're not getting what we're paying for.
I would actually like that. And then
if I may add, Chairperson,
Sure, absolutely.
According to the World Health Organization, I think the United States, at least the last time I looked, ranked about 37th. We're not even in the top 10 or 20. So to emphasize Cheryl's point, the outcomes don't support the
and a
cost.
commercial price paid for professional services relative to Medicare. We have a huge cost shift to the private sector is what this is showing.
You're referring to the RAND study?
Yes.
Actually, the RAND study, which I'm also happy to share in full with you, looked at an analysis to try to ascertain whether cost shifting was what was happening here. So did states with higher prices have a higher, or hospitals with higher prices have a higher percent of Medicare or Medicaid patients? And they found no correlation. So it raises the question about what is driving our higher prices if in fact it's not necessarily directly attributable to the public sector programs not paying their fair share.
We've had a lot of testimony here today, but there's one group that is totally unrepresented, and that's the self-employed who are purchasing these coverages on the marketplace. And
I hope to represent, a lot of them. That's who I work with, the self-employed. Oh, I'm sorry. I was thinking self-funded. I apologize.
Self-employed.
Right.
Yes.
They're not even part of this conversation. And I know healthcare is one of the largest factors of self-employment. Questions from our committee members? Is there anything? Thank you for coming in and testifying today. Next up, we have Madeline Feldman, Coalition of State Rheumatology Organizations, and Nilsa Cruz, Milwaukee Rheumatology Centers. While you guys are coming up, I just want to say thank you to everybody in the room. I mean, today is a long day, and I appreciate everybody's patience, but this is very important legislation, so I appreciate everybody, hanging in there with us. Thank you. Ladies, take it away.
Rheumatologist, and I am, thank you. I'm president of the Coalition of State Rheumatology Organizations, which is over 30 states of state rheumatology organizations, of which Wisconsin is one. And we are home based here, and I'm proud to say, in Milwaukee, Wisconsin. So we've heard a lot about, as a practicing rheumatologist, I actually am a small business and I have to purchase insurance for my employees and myself as well. So I fully understand premiums going up every year. We've heard about delays and how perhaps it doesn't occur that often. I look at this from a couple of different ways as a practicing physician, but also with a daughter who was diagnosed with juvenile rheumatoid arthritis when she was 9, and also a cancer survivor myself. So I do understand the importance of timely care and full care as monitored and directed by their practicing physician. We've heard over and over and over again that it's delayed. Perhaps there's wrong medication that's sent, the wrong dosage. So CSRO went about doing a survey, and the Wisconsin rheumatologist did answer us. 83% had forced white bagging for some insurance. And of those 83%, 67% had problems. Whether it was delayed, whether the wrong medicine was sent, the wrong dosage was there. I have the list from the Excel sheet of all of the problems with white bagging and brown bagging. And I can tell you one of the other problems is when we have a patient that can't afford their cost share, we'll let them pay $10 a month. There are some practices, the insurance company would not send that medication until the patient had paid their entire cost share. And that, I think, is unconscionable. At least we know in our offices, patients, if they can't afford it, they can continue to get their treatment. So I think the survey sort of rebuts the idea that this really isn't happening and that there's absolutely no problems with white bagging. Let's also look at the waste. If you are an employer and the medication is alternatively sourced to the physician's office. Now, I am not employed by a hospital, so I have no facility fees. I have nothing like that. My charges are probably a little bit different. But if it's white bagged to me and it's delayed, then the patient can't use it. They may not be able to take it until the next week or the next week. At this point in time, that medication cannot be used again. And that has happened in my office. So what happens is the employer pays, could be $4,000 for that, and no one gets to use it. It's discarded until the next white bag is sent to our office. So if we're talking about cost to employers, we really need to make sure that there's not the kind of wastage. And Nilsa, who's an office manager in Milwaukee, she can testify to this. I did have, I'm old enough that back in the early 2000s, our office did something called the CAP program, where Medicare basically decided to do white bagging. And what they did was, and we actually made more money on it because they gave us more for administrating than actually what the margin was when we bought and billed. It was a disaster. The patient came in, their clinical status had changed. The medication that Medicare sent us was not the right dosage for what happened on that day. And Medicare eventually just stopped doing it because it doesn't work. It just plumb doesn't work. Running a business, inventory becomes a very important part
for small practices. And I can tell you, there are rheumatologists that are going to be retiring because of this. We look at workforce shortages around the country, but even here in Wisconsin, and those that are in private practice and not employed by a health system are going to be impacted by this, perhaps even more than those that are employed. Imagine a grocer, and bread to his customers has to be sent to him from an outside supplier. And each customer has their own bread that has their name on it. And each supplier has a different kind of bread. The grocer now has to find a place separate from the other breads where this customer gets this bread, this one gets this bread. The customer comes in and the bread has mold on it. Oops, can't use that. Can you imagine the kind of inventory a grocer would have to keep in their grocery store? That is what we are going to have to do in our office. And it may be a drug the patient comes in that day and they're sick and they can't have it. And by the time they can have it, or they're in the hospital, it's expired, wasted, employer paid for it, nobody ever took it. We say, well, why are they doing this? Why would the insurance companies be doing this? When the medical insurance companies merged with the pharmacy benefit managers, and we know the big three PBMs are either owned by or own their own PBM, the things like provider administered drugs have been moved from the medical insurance side to the pharmacy side. And no, the medical loss ratio doesn't occur. They can make profit on the pharmacy side and not have to have it applied to the MLR. So there is a reason for doing that. And if we're talking about waste and transparency and cost to employers, there is an employer, self-insured employer, that was his patient had a prostate cancer metastasis. And he was forced to pay for a $10,000 a month drug because the rebate and fees were much higher to the PBM than the $400 generic. So there's guilt all around when we're talking about transparency and where the profit comes in. I can only speak for the private practice rheumatologists, and I can tell you mandated white bagging will cause closure of our infusion suites. We may make 1%, 2% margin on the medication. And if we can't keep the infusion suites open and the hospitals aren't taking white bagging, those patients are left with nothing. It might be that a mother can't hold her child. It might be that a father can't walk his daughter down the aisle, things that maybe you can't see, or they may lose a joint entirely. Or if the disease is not controlled, rheumatoid arthritis leads to heart attacks. How many employers want to pay for the ICU? Lymphoma. So if we have delayed or non-existent care for these patients, we are going to see the cost rise exponentially. And then I always tell that there are employers that can negotiate directly with providers. And when it comes to provider administered drugs, there are a number of self-employers around the country that have contracted directly with the doctor's offices, and they have saved lots of money taking out the middleman. Now, I know as an insurance agent, maybe insurance companies don't like that, but there are creative ways to save money that actually go around the insurance company directly with the provider. So if we're going to talk about true cost savings, let's go where the cheapest and most effective. And I will tell you that one of the reasons why the United States has higher priced drugs than Europe, the formularies constructed by the pharmacy benefit managers are essentially based on the highest price drug. They say the lowest cost, but their benefit is a percentage of the list price. So when our manufacturers here in the US compete to get on the pharmacy, it's the highest. I can use the word kickback because they have the safe harbor from the anti-kickback statute. In Europe, it's based on the lowest price. So let's talk about competing to get on. If we're talking about true competition, let's talk about competing to get on the formulary with the lowest price. There's blame to go around everywhere. But I'm here because I took an oath, no harm to my patient, and that's why I'm here today. Thank you.
Thank you so very much. I am honored to be here. This is the very first time that I have to present in front of a committee. And my heart is beating faster than my Yorkshire Terriers. My name is Nilsa Cruz. I am the practice administrator at the Milwaukee Rheumatology Center, which is a private specialty practice. I am also a payers committee member of the CSRO. And most importantly, I am a patient advocate with various members of the Wisconsin Rheumatology Association. The business owner I work for is my husband. Our practice is a one rheumatology office. I have 4 supportive staff members and myself. So yes, I am a small business owner as well. I would like to tell you today about my patient, Daniel. Every 6 to 7 weeks, I take a deep breath and I have to say a prayer before starting the white bagging administrative process for him. Daniel has been established for almost 17 years at our practice. He was in his late 30s when he first came to us due to pain on both feet. That was it. He was diagnosed with an aggressive autoimmune chronic condition involving all of his extremities and also his spine. At times, he could barely move. He counts on us for his timely treatments, which for him are every 8 weeks, to control his disease, to be able to provide for his family through work, and also to have quality of life. White bagging is an administrative, burdensome process for patients and healthcare providers alike. Fast forward to present, and through this process, which involves the white bagging mandate for this specific patient, I have personally documented 55 unnecessary phone calls between 45 minutes to 1 hour to try to coordinate benefits investigation, prior authorizations. I do believe on prior authorizations because these are very expensive drugs. In tandem with the PBM for the drug, and then the health insurance company for the administration of it. So you have 2 different parties, and this coordination literally has to take place. The process may take longer, and this has been previously testified on, depending on who you talk to, which telephone number or department are you being transferred to, assuming that the call does not get disconnected, as it often happens, and then we have to start all over again. Not fun. None of my patients, and I mean 0, enjoys their phone calls with their payer nor PBMs, not only because of the extended hold times, but also because of the misinformation, total misinformation that is being provided by one, the other, or both. Total disconnect. White bagging PBM mandated drug presents safety and logistic issues, oftentimes disrupting patients' treatment and inflicting emotional harm and stress, as Corinne testified. I'll give you some examples. Last year, Daniel's PBM refused to send us his medication on a timely basis because he had a patient balance with them. They were holding him hostage. No medication until he paid the PBM his portion of the bill. The difference between having a patient balance with a PBM or having one with the doctor's office is that PBMs will not take the financial hit. We will. We're also very proactive at enrolling our patients in patient assistance programs, not only through the pharmaceutical companies, but also, as you may be aware, there are other types of foundations that at the last minute open up with funding. I have a list of patients on these expensive drugs at my practice where literally the minute I get an email, whether it is at 8 a.m. in the morning or 8 at night, I get into the computer and I enroll my patients because that funding really can go as fast as within 24 hours. That's something that we can provide. On another occasion, the PBM refused to send Daniel's medication a week prior to his normally scheduled infusion because it was too early for them to fill under end. Please understand that this white bag medication is actually a prescription. So when you get your drug, it has the patient label on them. It's like when you fill your pharmacy prescription at your Walgreens or anywhere else, right? Sometimes they come back to you and say, too early to fill. In this situation, the patient was delayed 2 weeks for his treatment. You would think that these large organizations, whether a PBM or an insurance company, would have all the whistles and bells put together nicely. They do not. They're not keeping up with the Joneses in terms of the changes right now that are occurring, specifically business supply issues, including anticipating for delivery delays. I have been informed by my distributor at Milwaukee Rheumatology Center, along with many of the other colleagues I collaborate with, that there are delays with the FedEx shipments. So our offices are literally able to adjust to that like that. The minute we get notification, we literally move in the days where we can order the medication for our patients to ensure that we're going to have it in stock at that time. I have not seen that happening from white bagging mandates at all, but being denied because it's too early to fill. That's a disgrace. And that is one of the reasons why when I was approached by CSRO to testify here with this really fast heartbeat, I just decided to agree because you guys need to know that this is going on. I recently had, and this was my second reason to be here today, a patient in tears, total tears, because the PBM sent her to collections, refusing delivery of her meds. Young patient, teacher, prominent school district in the Milwaukee area. I personally was totally devastated. I took it so personal, as if it was happening to my sister or a family member, that with permission, I asked her if I could take her case into social media. We didn't have a law, and we still don't, to prevent for white bagging. And I said, this is my only option. We've tried everything else. And she agreed. I said, I need a favor from you. I need you to call your PBM and tell them that Nilsa Cruz is going to go into Twitter and tweet about your situation. Within 2 weeks, the patient called me indicating that her medication shipments were not only resuming, but the PBM also took her out of collections. Her words were, you must have friends at higher places. And I said, no, public shaming sometimes works. The shipments being sent to PBMs represent big boxes. These are not tiny boxes, because remember, these are medications that you have to keep control, nice temperature, nice packaging, you name it. But they are one patient per box, and the boxes are this big. My office is being asked to be a warehouse. I don't have that space, resources, or capability to be able to receive 1 box, 2 boxes, 3 boxes, you name it. White bagging creates lots of waste. That waste is not represented by the buy and bill model, by the way. Provider offices must have specific protocols in place to specifically address white bagged waste. This is wasted drug and wasted dollars paid for by employer groups and the patients. I'd like to elaborate on that one just for a little bit. My colleagues and I have recently started to approach employer groups, not only in the state of Wisconsin, I'm also a national patient advocate for rheumatology. And I do have colleagues who have actually negotiated direct contracts with employer groups only after employer groups have realized that they have been literally ripped off by the PBMs. The cost that they're being charged by the PBMs or insurance companies for these medications versus the cost of having the patient being infused in what I represent would be the doctor's office are two different things. And this had happened without having to negotiate the contracted rates that offices already have in place with the payers. Those are called single case rates. And we do it one patient at a time. Patients can be abandoning or being switched to another treatment. That creates waste. In a white bag situation, what am I going to do with that drug? I cannot give it back to the patient. I cannot send it back to the PBM. I cannot give it to another patient. In addition, patient having reactions caused by delay of treatments. During testimony, and this has been said a couple of times, I'm actually surprised that this is for real. I don't have a contract that says that I can substitute my purchased stock for a patient who is mandated to white bagging. There are no rheumatology offices in private practice that I know of, and I don't know them all, that have a contract that says that you can do that. Today, that was absolute news to me because we have been told by government and payers all along that that is an illegal practice. There could be changes of dosing. Our drugs are weight-based. You could end up wasting drugs by not using the totality of the shipment if patient drops weight, or you can end up rescheduling to change the prescription to a higher dose. The prescription filled at the present may or may not be valid. Those vials cannot be used to offset a new prescription. I cannot return them nor assign them to another patient. I am known in the state of Wisconsin for carrying on my iPhone a picture of the refrigerator full of wasted drug. Pictures speak 1,000 words. That's the story to tell when we approach employer groups, and their jaw literally drops because they're not familiar with that. They were not aware of that. We're all patients, in conclusion. Healthcare providers need the ability to continue to treat the right patient at the right time with the right medication at the right dose without interference from third-party payers or PBMs. There should be absolutely no reason why myself or anyone else as a patient advocate should have to take onto Twitter or other forms of social media to try and make sure that the patient gets the medication on time and doesn't send to collections, particularly during these very hard, difficult moments that the nation is going through. Thank you again for allowing us to be here today and listening to our testimony. We're both available for questions.
Thank you for your testimony. Can you, as an office administrator, so you get these drugs and they're not being utilized? Okay, I'll just say obsolete because I don't know what else to really term them as. What is your cost to dispose?
I hold on to them because I like to build onto the pictures that I present to the employer groups.
But
I don't dispose. I hold on to them.
Well,
you don't have to keep them refrigerated anymore.
No, but I understand that. But are you not like hitting, if this is a common occurrence, aren't you hitting like storage capacity?
No, actually, I have a very, very, very nice box in my office. I have 2 remote offices. I work out of home and I also have my personal office at the clinic.
Okay.
So I have an area in there just for drug. Once the drug can no longer be used, I am no longer facing the issue of having to deal with refrigerated space.
So can you speak to that though? I mean, you can't just like pour it down the drain, right?
No, we have a company that we pay that comes and takes that away.
Okay. Thank you guys for being patient advocates too. Questions from committee members? No, thank you very much. Up next, we have Megan Zimmerman, Martian McLennan, opposed.
Freezing.
Megan, I'm going to ask you to sit in the middle just because of Wisconsin Eye. I think it works a little bit better for them. Thank you. Whenever you're ready to.
Good afternoon, Madam Chair and committee members. I personally just want to take the time and thank all of you for the opportunity to speak before you today and promise you I will be concise. And I know we're running tight on time and length, but certainly feel it's important that I speak and talk for the clients that I'm fortunate to partner with. So my name is Megan Zimmerman. I'm Vice President with Marsh McLennan Agency. We're a subsidiary of Marsh McLennan Companies, the world's leader in risk strategy and human capital consulting. In layman's terms, I'm an insurance broker, consultant, advisor. Those are the more common terms that we're used to. My area of focus is strategizing with employers, specifically self-funded employers, on their health plan. And as we've heard in many of the previous testimonies, the prices and cost is really unbearable for us as consumers of healthcare, our employees, and our employers. And I want to add, I'm somebody who specializes in looking at data and looking at insights and looking at claims. And so when we talk about some of the root cause here and the lack of transparency that we are all confused on and so desperately needing, even with the brightest and the best tools, we have a very hard time of pinning down cost. And I just want to add that, with the hospital price transparency law that was passed, and now hospitals are going to publish their, pricing, and that's going to solve all of this, and that's going to be a solution. It's certainly going to help. But as of July of 2021, only basically 5.6% of hospitals were in compliance with this law. It's really difficult to navigate that. And so then you're asking your employees and their employers to navigate healthcare when they don't understand the price, when they're going in for a simple treatment to ongoing treatments. It's hard to contain costs. With costs in Wisconsin in 2021 for the health plan, it averages around $15,000 per employee. And that's increasing at a rate with healthcare trend of anywhere between 7% and 8%. And pharmacy is trending at around 9%. So as a business owner, and then the employees who are the heart and soul of their companies, you can understand how that is just not sustainable any longer. And there's absolutely no disagreement here that this white bagging, and when it is done safely, is effective. And I think we're hearing testimony, and I'm deeply sorry for the individuals that have had negative experiences with this, but I think it's also important to point out that it's not everyone's experience. I have a lot of clients who've had a lot of success and continue to have a lot of success. And I go out and meet with their employees. I talk with them. I don't just meet with the executives of the company. I meet with the men and women who are the hardworking force behind the success of that organization as well. And I'm not hearing complaints and seeing a lot of success with these type of programs. So there is two sides, as we're well aware of the white bagging procurement process. And there's also a lot of successful stories that I think are important to highlight. But most importantly, I feel when we're talking about healthcare today is that the employees and their families cannot continue to be burdened with any more healthcare cost increases. It is absolutely not sustainable. Over 60% of bankruptcies in the United States are due to medical bills, and that's with insurance coverage. And I ask all of you if a $5,000, $10,000 deductible for the average American is insurance coverage. It's really hard to say that's insurance coverage because that's not affordable for many of us. And it's important that 1 out of every 6 Americans has an unpaid medical bill on their credit report that affects their ability to purchase an automobile, to buy a house. There's a lot of ripple effects to that, and there's no end in sight to those prices increasing. And often, many individuals who are hardworking, have insurance coverage, can not afford the treatments. So as we're talking about the disruption that has been experienced by some in receiving that medication, there's many individuals that can't even afford to go and get proper medical treatment because they are so scared of the cost. So when you are going through a very difficult diagnosis, but then you know you have tens of thousands, if not hundreds of thousands of medical bills waiting for you, is a very difficult situation to be in as well. And that's also important to the individual's financial well-being, which is connected to many other aspects of well-being. And I think it's important to keep in mind, the average American household spends more on hospitals than federal taxes. I would call this really taxation without representation. And that is a problem and a challenge that we all need to solve for. And certainly, as we've talked about earlier, with the merging and consolidation in healthcare, the lack of competition has drove these prices, and it is no longer affordable nor sustainable. And the average hospital markup on prescription drugs is 479%. I don't know where I want to go and purchase many items with that type of markup, and business owners and their employees and families cannot sustain that either. And it's also really important that when we take into account the responsibility employers have, the Consolidation Appropriations Act, starting in 2022, is requiring employers to report the annual amount spent on their plan's 50 most costly prescription drugs. And then they need to compare that to the previous year's top 50 prescription drug costs. How can an employer, as a health plan fiduciary, justify this increase to the plan participants? The plan participants undoubtedly would view this increase as mismanagement of their healthcare assets. So employers have legislation that they are navigating and are going to be needing to report on and have that fiduciary responsibility to their plan participants. And they're going to have to justify these type of increases when they are not needed. And we have had success and proven results with alternative sources for procuring high cost specialty medications. So all of this in mind, I encourage this body to consider the dramatical financial ramifications this bill would have on employers and employees here in Wisconsin. The heart and success of our business community and the families they support can simply not afford it. I thank you for the time and opportunity.
Megan, thanks for coming in and testifying. So one of the things that we have in front of us, I probably got 30 different studies here that's saying that, you know, healthcare hospitals are marking these drugs up X number of percent. So you just testified that they're marking them up an average of 476, was that?
479% nationally.
Okay, where did you get that study? I mean, what are you referencing?
I have all of the footnotes in reference to all of my numbers.
Okay. Okay. So when you're working with your employers, can you tell us like what percentage drugs are to their cost of their health plans?
It really depends on the population and can vary, but on average, I would say it can be anywhere from 20 to 30 to 40%, depending on the population and the prescriptions that they are utilizing.
Okay, thank you. Questions from committee members? No? Thank you very much for coming in and testifying. Okay, up next, we have Melissa Thiesfeld, Pharm D Chair, Pharmacy Society of Wisconsin, Nick Liddell, Pharmacy Society of Wisconsin, and Jordan, Mayo Clinic Health System. And if we call people up and it's not the right group, please let us know because it's kind of being a little fluid up here. So thank you. And again, we'll have everybody testify and then open it up for questions.
Thank you. And good afternoon, Chairwoman Felskowski and all of the members of the committee. I appreciate this opportunity to testify today in support of Senate Bill 753. As mentioned, my name is Melissa Thiesfeld, and I'm here today on behalf of the Pharmacy Society of Wisconsin. I am a pharmacist and I'm the board chair for PSW, which is an organization representing pharmacists from practice settings across the state of Wisconsin. Our membership includes pharmacists who practice in community pharmacies, in clinic settings, in hospitals, as well as in managed care organizations and in health plans. Pharmacists provide important medication management information and decisions in all of these settings. My colleagues in managed care use use evidence-based rationale to structure medication benefits for populations of patients. Population-based decisions, however, are not always right for individual patients. Patients, pharmacists, and physicians need to have tools to provide the best care for individuals and not be hamstrung by policy decisions for business reasons. When implemented for broad populations, white bagging compromises the safety of medications and negatively impacts individual patients, which is why PSW supports this bill. PSW's mission includes improving the quality of medication use for patients, and our strategic plan emphasizes advocating for patients' access to necessary healthcare and medication resources. PSW strives to put patients first in all of the work that we do, and this bill gives individual patients choice in their healthcare decision-making and helps to maintain a safe supply chain for medications. Pharmacists and pharmacies are critical components of an integrated and patient-centered healthcare team. But mandated white bagging introduces, as you've heard today, risk, confusion, and delays. Patients no longer choose who are part of their healthcare team. This bill would allow patients to get their medications from in-network pharmacies and pharmacists that they're familiar with and that they're comfortable with. Patients can maintain these important relationships that contribute to their safe and effective care. In addition to being a pharmacist, I'm also a mom. I'm the mother of a 10-year-old daughter who requires an injectable medication every month. Our family first began this healthcare journey with our daughter, Kate, just about a year ago when she started breaking out in hives from head to toe multiple times a day. After 3 months of over-the-counter, both over-the-counter and prescription medications, nothing was helping her. So our pediatrician and our allergy specialists worked together to determine that the next step that Kate needed was an injectable medication administered monthly. In this process, I soon learned that the medication would have to be purchased from a specialty pharmacy and shipped directly to the clinic. We didn't get to choose where the medication would come from, and all of a sudden, my family was right in the middle of a white bagging scenario. Navigating insurance coverage, payment, and shipping literally took weeks for her. Kate's first injection had to be delayed because our payment wasn't processed appropriately. The medication didn't ship on the day it was supposed to, and then it was addressed to the wrong person at the clinic. Nurses and physicians at the clinic called multiple times to try to rectify the situation. And on top of their phone calls, I was calling as well. And the whole time, Kate was miserable. Being 10 and having hives is not a fun experience for a little girl. We finally got her first injection and we had good results, and I was hopeful that things would run smoothly in the future. But when it was time for her second injection, there was confusion again. The price of the medication was now different. All of the phone calls to the specialty pharmacy had to be repeated, and we had to again re-verify shipping, re-verify payment, and talk about the scheduled administration date. I'm a pharmacist. I have experience working in a healthcare system. I have knowledge of the medication supply chain, and getting this medication for my daughter is hard work. Every month is different. It requires hours of my time and it requires hours of her care team's time. White bagging practices were forced upon our family, and they've disrupted the care that we receive. My story and Kate's story is not uncommon, as you've heard here today. This happens to many patients who face frustrating and confusing choices, and it's hard work for everyone to navigate. So on behalf of the Pharmacy Society of Wisconsin, I want to reiterate our support of Senate Bill 753. This is an important bill, and it aligns with PSW's goal of keeping the patient's best interest at the forefront of our work and decision-making. Thank you.
Good afternoon. Madam Chair and the members of this committee, thank you for this opportunity to speak about a practice that is negatively impacting the citizens of Wisconsin, including the patients that I serve each and every day. My name is Nick Liddell. I'm a director of pharmacy at the Aurora West Allis Medical Center in West Allis, Wisconsin. In addition, I serve on the Pharmacy Society of Wisconsin Board of Directors. Over the years of my role, I have personally seen a growing number of patients negatively impacted by the insurance practices we are discussing today. Unfortunately, these practices are not just impacting patients at my facility, it is impacting patients seen in clinics and hospitals across the entire state of Wisconsin. These practices have the potential to impact any patient that needs a medication administered by clinicians. Children, elderly, cancer fighters, those inflicted with GI and neurologic disorders, and many more. Due to the broad negative impact that I've personally witnessed way too many times, I've chose to come and speak today. Now, this is where I go a little off script. My heart's also pumping a lot. And I wondered if this was going to happen when I came up here, because I'm normally a pretty good public speaker. And I reflect on, why is my heart pumping so hard? And it's because it's so important. I'm speaking on behalf of dozens of patients at my hospital right now. That's a pretty heavy burden, not a burden that they've had to carry because of white bagging and these practices. It's just making sure that I portray the right message to all of you today. I wanted to just take a moment to answer some of the questions that were very good, but so that you have the answers to take back to your areas. One question was, or I felt was asked, is why do some health systems choose white bagging as if it's a practice they condone? It's because they must do it. There are certain medications when they come to the market from the FDA, when they're approved, are only allowed to be distributed in a limited fashion. What that means is not any pharmacy can buy it. Only a handful, possibly a dozen pharmacies in the United States can distribute it. Because of REMS programs, these are requirements that are required by the FDA to safely distribute the medication. So in those situations, if a patient is wanting to receive that therapy at our facility, I can't buy it. I can't procure it. I have to white bag it. It is the only way I can care for that patient and keep them in our health system. So that's why the bill is not written in a way to eliminate white bagging. We can't. Because of the other constraints in our supply chain, we have to keep it, but it's only for moments that we need it or we must procure it in that fashion. To be honest, I wish I had the ability to buy any drug that is needed for my patients. I run a great pharmacy. I hope you can see it someday. Quite proud of it. But unfortunately, and I actually think it's fortunately, we have these safety measures in place. Some of these medications are dangerous. If they're not distributed and administered properly, can cause harm. So that's why some medications are white bagged to hospitals, not so much by choice, but because it is the right thing for patients. Another question that came up is, there was a question about the federal government possibly expanding existing legislation to correct for some of the things that were discussed today. Most of what we're discussing today is pharmacy practice and orientation. The pharmacy practice is something that is managed by the state and not so much by the federal government. But when it comes to supply chain and those aspects of these practices, that's how the federal government has been involved. There's been a lot of studies mentioned, and I love to read all of them because I do come from a science background, but they don't measure what's actually occurring each and every day with my patients. They're not measuring their physical pain. Did you achieve a pain score of 10 in the last week because of the delays of your therapy? I haven't seen it in the studies. Does it measure the number of phone calls they make to coordinate their therapy? I haven't seen it in those studies. Does it measure the amount of time they have to take away from their children or from work to make sure that they receive this medication on time? I haven't seen it in any of the studies. So I do think the studies have their limitations, and I just want to make sure that it's recognized as we talk about this issue. Another discussion has been, what's the cause of all of this? And a discussion about contracts and prices decided upon by our health systems. The large problem for all of this is, in my opinion, drug companies. The prices are exorbitant. They're essentially unaffordable. If we keep letting drugs come to market in this fashion, the system will break down. This is not at the fault of our clinics and hospitals in your local communities. So if we're trying to place blame, I do not see it coming from our clinics and hospitals. In regards to brown bagging, there was a question about brown bagging. To simply state it, it's unethical. When a medication leaves the hands of professionals, especially these complex proteins, many of these drugs are super complex. Almost every drug that comes to market nowadays is not a simple drug. We're not talking about aspirin that can sit on a shelf for who knows how many years. We're talking about proteins that are very complex and they have to be handled with the utmost care. And brown bagging is just unethical. I will never allow it. I will never allow anyone that I know is considering it for it to be allowed. That's why it's in this legislation. And lastly, just to answer some of the questions and comments before I wrap up my testimony is, it is a complex issue. I'm not even certain for someone that works on this every day, I fully understand the issue. I sure as hell have learned a lot today from those that have testified, but it's a simple problem. It's a complex issue with a simple problem. The patients that I serve are being harmed. And it's not a patient, it's plural. At one hospital. I believe the last time I counted, we have 156 hospitals, and this does not include the hundreds of clinics that we have. At one hospital, one facility in Wisconsin, many patients are being harmed by this practice. As a member of the PSW Board of Directors, I've heard many stories from pharmacy leaders across the state. All describe the same issues I'm challenged with each and every day. The insurance practices described today are fragmenting care, causing delays, and putting patients at risk. But most of all, they're causing emotional and physical harm to patients. Real pain, real strife. If it wasn't for the tears, the emotional letters from patients, the relapses, and the stories of hardship, I'm not sure I'd be here today. Understanding this policy can help the citizens of Wisconsin. I'm glad I'm here to tell their story. To help explain the problem, imagine being diagnosed with Crohn's. I know that this disease was mentioned earlier in previous testimonies, but if you're not familiar with it, it's a common debilitating GI disorder. It's essentially your body is attacking your GI system. It's eroding your GI tract. It's extremely painful. Your provider wants to start therapy right away so you can get a debilitating flare-up under control and return to a normal lifestyle, return to work, and be in control of your health. You learn that your insurance requires white or brown bagging. So after many phone calls, confusion and coordination, you receive the medication delivered to your home, but you can't find anyone to infuse it. Why? Because very few care teams will infuse brown bag medications, as I've already described. So let's toss that medication away. Let's start over. After many phone calls, I can't even tell you how many phone calls these patients have to go through, and confusion and anxiety and anguish, and all the coordination that is put on their shoulders. What a great American health system we have. They have it worked out that the insurance company is sent to a local outpatient infusion clinic. After multiple meetings and phone calls with your pharmacist at the clinic, the care team, your nurse, your provider, we're able to coordinate care. The care team works with the pharmacy 1,000 miles away, required by their insurance. The medication's sent. It's a great success. What's wrong is that the patient sends it via courier that doesn't typically deliver to the infusion clinic pharmacy. It's essentially treated like a piece of mail. And when you try to deliver a piece of mail to a large hospital, even the best of systems, it can get mixed up. Or they're addressed to the wrong person. We've heard that mentioned many times. And the medication's lost. I can't count how many times medication is lost. Or we get it 3 days, 5 days, 7 days, way too late. So we start over. Many more phone calls, confusion, coordination. The medication is shipped and it arrives. Success. As we've heard in previous testimonies, the incorrect dose was sent. Because the care team that is closest to the patient has access to their medical record, knows exactly where they are and the needs that they have, we find that we have too little drug. For a physically painful GI disorder, that is commonly inflicted on many patients in my local community and some people in this room. So we start over. The correct dose of the medication is received and administered. If I was the patient, I would have given up by now, and I know many of mine have. They just don't go through the hoops. They're elderly. They don't understand how to navigate and advocate for themselves. And they receive the medication, but after multiple days of delay, if not weeks of delays. And unfortunately, if you're inflicted with Crohn's disease, you need to receive therapy again. It's not one and done. So the process is repeated all over. More phone calls, more breakdowns, more missed days of work, more sleepless nights, more chances that your GI disorder will relapse by not receiving your treatment on schedule. The timeliness of these important medications is critical. Most of these are immune modulating therapies that need to be given exactly on time. More frustration if you're the patient because you're not in control. I didn't make this story up. It's a nightmare. I couldn't even imagine it. It's happening I wouldn't say every single day, but it's happening dozens of times at my hospital. It's a real story. And actually, I have a patient in mind. It's a young lady that I have in mind with this story. And this isn't the only patient with Crohn's disease that has a very similar story. This isn't uncommon. Something that has not just happened once. These are real, and what's worse, preventable events that are inflicted on dozens of patients at one hospital in Wisconsin. It's time to put the health of Wisconsin citizens first and that's a big word there, prohibit the mandate practices of white and brown bagging. I want to thank you. Thank you for your public service, which I know is an enormous time commitment and a contribution to our state. Thank you for your professionalism. I believe this has been an exceptionally run session, but most of all, thank you for listening. Please support Senate Bill 753 so that you can provide the best patient care in Wisconsin.
Hello. We're on, okay. Madam Chair and fellow senators, my name is Jordan Dow. This is my first time testifying, so thank you for this opportunity. In my role at work, I'm the Director of Pharmacy Services for Mayo Clinic Health System in Northwest Wisconsin. Senator Staffschulte had a chance to be on the phone with you and Steve and talk to you about this issue. I know a month ago. Thank you for taking the time for that conversation. This is an important topic, similar to Nick. My heart's pumping too, partly for our patients, partly for our staff. Our staff have to deal with the headaches that many of you have heard about every day. Put in a spot where they're on the phone on hold for hours. That just doesn't need to be that way. And you heard earlier, our staff need to apologize because at the end of the day, we're the ones, telling the patient, sorry, we need to reschedule, even though we have your medicine right here on our shelf that any other patient could use, your payer won't allow it. So I'm here representing our staff, our patients, and I hope my comments resonate well with them and resonate with you. At all of our Mayo Clinic sites, which include more than 15 rural communities in Wisconsin, including Barron, Sparta, Bloomer, Glenwood City, some other ones, Menominee, Eau Claire, La Crosse, a little bigger locations. Our primary value is the needs of the patient come first. I'm here to tell you today that first and foremost, we view white bagging as an unsafe practice and absolutely does not put the needs of patients first. Second, it's inefficient and it's costly for healthcare providers and ultimately to our healthcare system. We've talked a lot about costs. Again, we haven't talked much about the costs of unnecessary waste, unnecessarily time wasted, and so many other costs that are administrative burdens tied to this practice. In our typical delivery process, as you've heard a little bit already today, we contract with suppliers and distributors to procure our medications in a consistent way that ensures our product tracking and traceability. So every day we get an order of medications, we know exactly where all these medications came from. We can ensure the temperature controls and the product arrives at our pharmacy on time. The thousands of medicines that we administer every day, it's not a small venture. It's not 5 bottles or something. We're administering thousands of doses a day in the locations I oversee. These are critical processes to us in order to guarantee product integrity and again, meet the transaction tracking information required by the FDA, Drug Supply Chain Security Act or DSCSA of 2013. Through our contracted means, our medicines arrive daily at the same time, again, at the same delivery point, and then they're efficiently transitioned into our inventory and temperature tracking system. So we know exactly what we have, where it is, and can get it throughout our process. We barcode every step of the way to know exactly what medicines are where and that they'll be ready for our patients. This approach enables us to manage our inventory efficiently. Again, we talk about managing costs. This helps us do that in an efficient way. Notably, many medicines that are targeted for white bagging are, again, fragile, high-cost medicines that you've heard about multiple times today, require very tight temperature controls and other things associated with them. So that's our current process for most medicines. White bagging shatters this product delivery process. Under a white bagging scenario, payers force our clinic staff and patients to spend time coordinating approvals, payment, and delivery before the product is even shipped. This causes delay in therapy for the patients, as you've heard many times today. Once the product is shipped, it often arrives at any one of our 40+ clinic locations in Northwest Wisconsin. I think you heard that talked about earlier. This product is coming patient-specific, and it's often coming to the provider office that ordered it rather than to the pharmacy, which is our one central delivery point that every other medicine's arriving at. This is very problematic for temperature tracking and ensuring product integrity. The medicine could easily sit on a receiving desk for hours and end up out of range, and its integrity can be compromised, and we start over. In this scenario, the product must be wasted. So again, we're throwing away potentially thousands of dollars of medicine that patient's already paid for. And the product must be reinitiated, which is a time waste for everybody involved and ultimately causes a delay in treatment for our patients. Again, the product does not arrive with the 3 T's that are required by the FDA under DSCSA for any change in product ownership. And that's the transaction history, the transaction information, and the transaction statement. I think a good question was asked earlier related to that. Is there a regulatory issue here? Again, that issue, I think in my mind is in question. I think payers would probably say that that's still the patient's property and you're receiving it on their behalf. In my mind, if we're taking that product and we're going to take it into our sterile compounding facility, we're going to mix that product. In my mind, that's us taking ownership of it, and we're ultimately taking ownership of the patient outcomes. We're preparing that in a facility that we've spent millions of dollars developing to ensure it's safe, and are constantly monitoring and testing, and then taking it to the patient for administration. In my mind, we're taking ownership, and absolutely the 3 T's should be supplied to us as part of that process. Again, this creates uncertainty in our quality assurance for our patients, and we believe it's unsafe and not in their best interest. Similarly, white bagging is inefficient for our staff and our patients. In a typical scenario, when a patient receives a new diagnosis, we can begin treatment as soon as the patient and the care team agree on a treatment plan, even the same day as diagnosis. We can do this because we have the product sitting in our refrigerator, our freezer, wherever that product is based on what needs to happen with it. We can do this. Again, it's ready for our sterile and hazardous compounding procedures and mixing in our clean rooms and then providing to the nurse to administer to the patient. Again, potentially even that day. In a white bagging scenario, when a patient receives a new diagnosis, if it's required to be white bagged, the patient needs to work with a care team, the payer, make the many phone calls that have already been talked about in many cases, pay for the product, coordinate that delivery date and schedule their visit. In our experience, that typically takes 4 weeks at minimum. During this time, the patient's disease literally is progressing. They just got a new diagnosis that we could treat that day. Instead, they're waiting 3, maybe 4 weeks or longer. Again, 3 to 4 in a good case. And again, that's the physical ramifications of this. The mental and emotional impact is significant as well. And I think we just heard that from Melissa a few minutes ago about her individual scenario, which I had not heard before. And Melissa is one of the most organized people I know. If she's having a hard time navigating this, I cannot imagine the rest of our patients. Again, our patients are like all of us. Their conditions change. They need changes in their treatment. They might need a higher dose for their medicine, which results in delays and to reschedules while we procure more of their medicine. It's a shame, again, because we have that exact same medicine sitting in our refrigerator right next to it, but the payer tells us we cannot use it. I heard today that there's exceptions for that. That's the first I've ever heard of that. That was brand new information to me. In other cases, patients' conditions may change and we might need a different medicine. In this case, the previously white bag medicine that the patient's already paid for and is in our refrigerator, again, now needs to be discarded because the payer says that's for that medicine or for that patient's already paid for it. It's no longer a relevant treatment choice. And so it gets thrown away. That does not happen in our regular process for anybody else. Those medicines are not prepared and used for patients until that day of decision that it's ready to go for that patient. And then we don't bill them till after the treatment. So it's a totally different process that doesn't make sense. Ultimately, white bagging is unsafe, it's inefficient, and it's a disservice to our patients. It does not meet our primary value of putting the patient first, which is why I'm here asking for your support of this legislation to prohibit this practice. Thank you.
Well, thank you for your testimony. So you've been sitting here all day. You've heard a lot of testimony. And Nate, I would agree with you. The cost of drugs and a lot of other practices that are outside the realm of this legislature is the driving force of a lot of what we're doing here. So we have coalitions of employers. A lot of them are using third parties, so they're self-funded, begging us not to do this because of the cost. Then we hear about patients not getting their drugs. So what it boils down and what I keep seeing here is needs to be a negotiation between those that are providing the care and those that are paying for the care and coming to a consensus on what we're going to pay for that care. I mean, I don't sell health insurance anymore just because of Obamacare and all the complexities that go with it. But I have clients who have individual $10,000 deductibles, husband and wife, and are paying $1,968 a month for that care. When they both ended up going in and having procedures, now we have a second mortgage on our house to pay those deductibles. They can't afford it anymore. So how do we, in your opinion, as a governing body, how do we find the balance in that? The rising cost of healthcare and drugs are driving it. We know that. How do we find balance in that to do what's right by the patients? But also I need people to have healthcare, not just health insurance with these high deductibles that they don't go to the doctor anymore. So what's the solution? I'd love to.
And I wish it was a silver bullet.
There are no such things.
Yeah, I know. I think we've heard from some employers today. And those employers, the ones at least I've heard so far.
We have huge coalitions.
Large coalitions. Yeah. In my opinion, I guess I don't have an answer. I don't have a solution. I have a perspective. I believe our government gets involved.
Too much.
And some would say so. But you must get involved. I think you're charged to get involved when the wrong thing's being done.
So is our answer capping what's charged?
I think your answer is to stop what's unethical.
So is 400% over the cost unethical? Or is it just not allowing patients to have a choice of where they get their drugs?
And I think there's been discussions about free market, right? Let that be worked out.
So in other words, we shouldn't get involved.
No, I think and in my opinion, I can't speak for everyone else here, and I do not know how to navigate the world of government as well as you do. But there are appropriate means for free market to work, and that's through contracting, that's through negotiations. But not allowing backdoor things to occur that are unethical, that cause harm to the citizens of Wisconsin, that are unfair. And so I do think there are moments when things need to be passed into law to make sure that the free market does work its way that it should, and not allow alternatives that are harming people.
So I don't disagree with you, but what is unethical? Is white bagging unethical or 476% of our cost unethical? I just am pointing this out,
Sure.
not because I'm going to ask you to solve
Sure.
the issue. But that's a dilemma that this committee is going to have that discussion over. So I do thank you for your testimony, because as pharmacists, you guys see a lot. And we do appreciate you coming in and doing that. Do we have questions from the committee? Senator Ringham.
Thank you, Madam Chair. I'm not sure if this is a question that you can answer either, but we hear about government negotiating with the pharmacies. Is that something that would be feasible? Tough question.
My apologies. I'm not sure which piece of that you're referring to specifically. There's drug pricing, absolutely a top, priority issue for many years. All of us in this room are aware of that, I think, and live it every day, many of us. So, in terms of government setting, what's allowable for prices or what reimbursement is allowable, I don't know if that's feasible or not. To me, that seems more logical in a different kind of healthcare environment that's consistent, healthcare for everyone across the board, which isn't the environment we're in. So, Medicare, which is over half of our patients in the locations I'm in, is already in a lot of ways, government funded and plans, and are setting our reimbursement as Dr. Pat Corey, a friend and colleague on the other side today from me, but he talked about, we're making ASP plus 6%. So we're making 6% over what our costs are on over half of our drug therapies administered. So is 6% a reasonable margin? I would say yes, probably. So, and then we think about Medicaid and our other payer mix. So now all of a sudden we're talking about getting reimbursed less than what our costs are on those patients. And so that leaves our commercial patients, which is where our many different types of contracts come in, and where, the reality of US healthcare cost shifting happens too. And I don't think that's news to anybody in this room. So, so that to me is part of our challenge. I don't know that I have a solution, but in terms of where price escalation happens and then the reimbursement relative to the charges, that's just part of our realities that we face, unfortunately, today. So,
well, thank you for attempting. I'm thinking like Canada. You always hear how much cheaper the pharmaceuticals are there because the government negotiates the price with the big pharmaceuticals, not just the general pharmacies.
Sure.
But higher up the ladder, I guess you would say.
Sure.
But it just seems like we do pay exorbitant rates here in this country where other countries do not. And that's not because of what you do, but yet we do need to find a solution, and it's maybe higher up the food chain than what we're at. But it's a concern for everybody.
Senator Stashow.
Thanks, guys. Jordan, thanks for making the trip down.
Yeah.
It's always appreciated when other people make that trip. Let me ask you this, as somebody that's completely not in this industry.
Yeah.
When you talk about your role as the hospital and your role as the pharmacy within the hospital, and so in other businesses, small businesses like I have, if I don't like the way somebody is subcontracting or a provider of a service to my business, I don't do business with them. I go somewhere else. It's complicated in this industry because healthcare is something that people can't say, well, that's not something I want to do today. So tell me, is it possible for you to just say, we're not going to accept any insurers that say we require white bagging? Is that Is that feasible, possible?
Interesting question. You know, I'm not involved so much in the contracting and payer relations conversations from our contracting team and the folks that do those contracts. So, you know, in concept, I would imagine it could be. At the same time, of course, we want to serve all patients. We want to take care of our community. And so, you know, we don't want to exclude community members from care of our services.
And I guess the convoluted way I was getting to that is we talked earlier today, or folks talked about how critical it is to keep the key employees. And I understand that in my business as well as anybody else. I'm a small business, so I can't afford the health insurance, but someday hopefully we get there. And if we do, and my employees are saying, listen, the health insurance you're providing sucks. I go there and they have this white bagging policy and I can never get my drugs and I have to go back 4 times and now I'm missing work because of it. If they did that as an employer that's providing insurance, I would say, okay, well, now we're going to shop and do something else.
Right.
And that's why I ask, is it a policy that, you know, if you said we're no longer going to take anybody that requires white bagging as an employer, my employees say, well, I can't go to Westfields Hospital in Richmond anymore.
Right.
Where do you want us to go? And now, by the way, my appointment that used to take an hour out of my day is now a half a day because I have to run to the Twin Cities or whatever.
Yeah.
Is that possible? I mean, is it conceptually, is that something that could be done?
Yeah, I mean, that can happen. I think that in kind of related ways happens today, just around some hospitals accepting white bagging and some not, and those choosing not to because they feel it's a safety issue. And so then patients need to seek care elsewhere and run into those scenarios where they are driving and working with a whole different care team than what they're used to. So, yeah. And just one other comment, if I could, Madam Chair, I think that one other comment I just wanted to make, you know, I did hear, again, Dr. Corey talk about the quartz model and how, you know, they are a health plan that partners with healthcare organizations. To me, that's unique and different to most other healthcare organizations I'm familiar with. At Mayo Clinic, our self-funded plan absolutely will not white bag. You know, we're employers, just like the other individuals talking today on the other side. Mayo Clinic's trying to manage my, you know, pharmacy expense, and you know, from a employee benefit perspective. I don't know of other health plans that are self-insured healthcare organizations that are white bagging, because at least in our world, it's not in the best interest of our patients, and we don't think it's a safe practice. So I'm not surprised to hear Dr. Corey talk about how he was collaborating, having conversations, giving a 3-tiered approach. That's different than what most any other payer is doing. You know, I think the question keeps coming up: why can't we settle this with contracts? I think I've heard it said a few times that, you know, these are, in my mind, typically unilaterally implemented programmatic changes that aren't part of the contracting process. And so that's where the rub is, I guess. It seems like it should be part of the contracting process, but it hasn't been implemented that way, at least in most scenarios, to my knowledge.
Question? Thank you guys very much for testifying. Up next, we have Rebecca Hogan with Association of Health Insurers and Sergio Santiago with Association of Health Insurance Providers or Plans. And Sergio, I hope I did not slaughter your name. I apologize if I did.
Good afternoon.
I know. Thank you for
I
your
had to check,
patience.
even though we've been here a while, I had to check. Rebecca Hogan, hello, I'm here on behalf of the Alliance of Health Insurers. My colleague RJ Perlow, the executive director, would be here today, but he was not able to attend, so I'm here on his behalf. A lot of the things that I have in written testimony that is being passed around now have already been covered by previous testimony, employers that are here today. I just want to point out that usually when I'm here in front of your committee or the Committee on Health, I'm here on behalf of AHI talking about mandates, prior authorization, step therapy, PBM reform that we had the past 2 sessions. And it's usually about what insurers aren't covering or how we're trying to limit something. And these drugs are being covered. These are drugs that are the insurance companies and the payers that we represent have decided are needed and necessary for their patients. And just like the prior panel said, and you, Chairman, they're expensive. And we have to cover them because we need to keep our patients safe. And we're here because this bill just stacks the deck for one side of the table. And we can't afford it from our perspective, the employers that we pay for. So with that said, I'm going to turn it over to Sergio. He's here with AHIP and he'll be able to get into some more specifics.
Good afternoon. My name is Sergio Santiago and I'm Vice President, Drug Policy for AHIP. We are a national association whose members provide coverage for healthcare and related services to millions of Americans every day. Americans deserve access to comprehensive, quality, affordable coverage, and AHIP is committed to advancing policy solutions in support of those goals. As an advocacy organization committed to market-based solutions that make access to high-quality healthcare affordable, I thank you for this opportunity to speak with you today on behalf of our members who share serious concerns with and opposition to Senate Bill 753. As a matter of course, we believe everyone should be able to get their prescription drugs at a cost that they can afford. That means advocating and negotiating hard with Big Pharma for lower prices, as well as ensuring that patients are getting prescription drugs and therapies that are right for them. Health insurance providers stand shoulder to shoulder with patients fighting for both access and affordability. The problem has long been and still is the price of drugs. I know one of the other panelists mentioned this, and this is true, and they're not here today. And I can understand their reluctance to even observe this if they're here in person. But at any rate, there are many innovative strategies being used to lower drug costs for patients, and so-called white and brown bag dispensing through specialty pharmacies are among them. I think I'm going to address a lot of the statements that I've heard earlier or assertions that we've heard earlier from previous panelists. You have my testimony submitted for the record. So I think I'm going to devote a little more time to the question of specialty pharmacies. I think they are not getting a very good description, and I think it'd be helpful to address some of these concerns that we've been hearing. So part of that, I think, is addressing how and from where clinicians can obtain drugs for administration. Depending on the drug, that may be purchased by the provider directly from and shipped by the wholesaler or the manufacturer. This is whether you're a hospital or if you're a clinic. Or you may get them from a specialty pharmacy. This is because drug makers will often enter into exclusive or limited distribution arrangements with certain pharmacies because, as was mentioned earlier, and I think we all understand, these are very sophisticated drugs that require special storage and handling. As mentioned earlier, it involves temperature control, light exposure, so on and so forth. So a lot of times manufacturers will pick one specialty pharmacy to send their product through just to maintain control over how they're being dispensed. So the point is, hospitals and or group practices may in fact be getting some of their prescriptions already for their own in-house pharmacy from some specialty pharmacies. I would also add that specialty pharmacies are different from traditional brick and mortar pharmacies because they focus on dispensing drugs that retail pharmacies are not typically equipped to dispense. Moreover, specialty pharmacies ship their products directly to clinicians, just like a manufacturer or a wholesaler would. They use the same means, the same processes, the same carriers. It's no different. It's just coming from a specialty pharmacy instead of from a wholesaler or a manufacturer. And also, where safe and appropriate, it may get sent to patients. And I think you mentioned earlier, Senator, that you had been receiving brown bagging, and I'll get to that in a second, but there are some unique circumstances involved there as well. I'd like to clarify that specialty pharmacies must also abide by all state and federal legal and regulatory requirements, including chain of custody or pedigree, as it's known in the industry, for tracking the source of these medications. And all of this is governed, of course, by the Drug Supply Chain Security Act, in addition to meeting extra safety requirements for certain specialty drugs that are imposed by the Food and Drug Administration on the drug manufacturers. Some of these drugs are highly dangerous. They require high touch, meaning a lot of attention from clinicians and from the pharmacy as well. So most specialty pharmacies will have clinicians who specialize in a particular drug and are coordinating these evaluation and mitigation strategies. They call risk evaluation and mitigation strategies, REMS, that involve usually extra monitoring or extra contact with the patients and the providers to make sure that the protocols are followed and so on and so forth. So this isn't just some fly-by-night operation that we're talking about when we're talking about specialty pharmacies. The specialty pharmacy staff also help coordinate a patient's care by providing close monitoring, collecting data, sharing information, and so on. One other thing I'd like to mention too is that, we've heard a lot about possible waste and, errors and so forth in shipping. Specialty pharmacies and plans are on the hook for these errors. If a dose is sent in error, the pharmacy and the plan are on the hook for that cost, not the plan sponsor, and certainly not the patient. If a patient's paid for the drug, we will make sure they get the drug when they need it as they were supposed to get it. If there was an error on our part, they're not paying for our mistake, we are. And so are the specialty pharmacies. And as has been noted, with the cost of these drugs being so high, it's a pretty costly error. One or two mistakes, let alone as many mistakes as we're talking about here, would probably not make this a very good mode of doing business, because it's just not profitable or in any way helpful to anybody if we're constantly paying for drugs we're not using. So I think that that's something that needs to be kept in mind. Patients and employers are not necessarily being put on the hook for this. It's our mistake, we fix it. On top of providing these additional unique services, specialty pharmacies typically provide these drugs at a substantial discount compared to those dispensed by hospitals or physician groups. And this leads to cost savings for patients, families, and employers. This is, as has been noted, and is certainly noted by the employer groups that are here today, it's significant. These drugs are difficult to get discounts for because many of them do not have a generic substitution, or in certain cases for biologics, they don't have a biosimilar necessarily that's even available, let alone that is interchangeable or even less expensive or comparably expensive to a biologic. So the issue here is that realistically, for many of these drugs, there's not a lot of room for rebating or any other kind of discounts beyond usually bulk purchasing. So oftentimes, because specialty pharmacies working through health plans will leverage the number of patients in a particular health insurer's pool, they can negotiate volume discounts. And that's why we see some of these prices are so much lower than they are when they're acquired by the hospitals. At any rate, so I think I'd also add that in terms of compounding, I think we hear a lot of inaccuracies, or at least some questions about compounding. I think there's a distinction to be made here between specialty pharmacies and compounding pharmacies. Compounding and medications are services that are provided by any pharmacy. What's affected by the federal regulation or the federal law, the DSCSA, is that what happened, and I think there was a reference to this earlier in Massachusetts, was there were companies that were, or pharmacies that were bulk manufacturing these compounded drugs without being specific to a particular patient. And that's where we had a lot of sort of manufacturing problems and things of that nature. That's not what we're dealing with specialty pharmacies. Now, specialty pharmacies may compound. They're just like any other pharmacy in that sense. They're run by pharmacists. If the script says to compound it a certain way and it's appropriate to send, they will do it that way. But they will follow the instructions. So I think, I think there's an attempt to sort of conflate some of these issues that we've had with certain kinds of pharmacies with specialty pharmacies. And as to spoilage and transport and things of that nature, I think having spent time and actually visited specialty pharmacies and automated pharmacy fill centers, it's pretty remarkable. They're Six Sigma efficient in terms of doing the physical tasks that pharmacists do. It's not a replacement for a pharmacist. The pharmacist is always in charge, and they are monitoring to make sure that the fills are being made and done according to the prescription. But as far as errors and things are concerned, they will process the script as they receive it, and they will get it. Another thing that's fascinating about it is, and again, I saw all of this in action, was when it comes to the actual shipping part, as mentioned before, they will come in containers that are appropriate to preserve and protect the medication inside. What maybe folks don't know is that as part of that process, once the claim is received, or the script is received, the pharmacy will also run a series of algorithms to make sure that they know from the point of departure where the drug is being shipped from that pharmacy to its destination. They take into account all of the weather patterns that they will encounter along the way, the conditions under which it will be transported, and they make sure there's more than enough preservative or whatever is necessary to protect, or coolant to protect the medication involved. So, we hear a lot about stuff sitting in a trunk or sitting in a car. Usually there's more than enough to last for a few days out in the sun if worse comes to worse. But again, most of these situations involve, if not just in time, very close to in time shipments. So I think, again, if there's a mistake and it happens, the patient and the employer is not on the hook. It's on the specialty pharmacy and it's on the plan. So the only other thing I think I'd mention is that since hospitals and group practices receive their prescriptions for these clinician administered drugs the same way that specialty pharmacies do, and in fact get some of them from specialty pharmacies, I've heard some discussion about how some of the specialty pharmacies are owned in a vertically integrated organization that has also healthcare that's not only an insurer, but also a PBM and or a specialty pharmacy. I would say that one, not all drugs are available from one specialty pharmacy. There are multiple some specialty pharmacies. Some of them have these agreements that force you to purchase from a competitor. So there's that aspect. But also, I would say the arrangement is no different from a hospital system or a physician practice that has its own in-house pharmacy. They wholly own and operate those pharmacies themselves. I don't understand why there's a distinction here when they're doing the dispensing and the administrating, whereas when we have our folks supply the same product in the same dose to them, that it's somehow different because it's owned by an insurer and or a PBM. So with that, I'm happy to answer some questions. I know we've all been here a while, and I'm hoping that we can help you with reevaluating this.
So one of the things, and this goes back to kind of early on, when we had hospitals testifying, and even when Corrine was testifying and Nate, that Corrine had been approved for this treatment throughout the year. And then in the middle of the treatment or in the middle of a contract, all of a sudden things change. So Senator Stachel had alluded to this. If there are contracts in place between the insurer and the hospital, how is it that midterm things are changing?
Well, Senator, I'll say first that I certainly can't speak for any individual plan, and I'm sure they all have different contracts, as been noted. I would suggest that most of these contracts and these changes are accounted for in the contract, in the sense that there is a right that's been negotiated as part of the contract for an insurer to make changes to their benefits or structure within a certain parameter that has been mutually agreed upon with the hospitals. So I think this notion that they are making these changes out of the blue or out of turn or outside of contract I would challenge that. As far as making changes in midstream with providers, I certainly am incredibly sympathetic and grateful that Corrine had that situation resolved. And certainly that's not the aim of our approach to white bagging. I think depending on the circumstances, it could be a matter of a provider deciding that they no longer wanted to participate at the rates that they negotiated or participate at rates that competitors may be willing to match, and therefore we may be switching. My understanding is that it is generally discouraged to switch providers as a general rule and a provider team in the middle of a stream, which is probably why she received that continuation of care, because she had been so far down the line. Usually that sort of thing applies to someone who is just starting out. before they start taking their medication and before, so that there's no disruption. Now, again, ideally, that's what should happen. And I can't speak to the exact circumstances and I won't pretend to, but other than to agree that it was awful, and I'm very sorry that that happened, I don't think that is a characteristic approach for these kinds of situations.
So the other thing is, so we had our pharmacist friends just testify, and the one's daughter has been going through that. Now she's a pharmacist and she's spending all this time. I mean, people aren't making this up. So where is the breakdown happening?
That is a good question. I cannot say for sure because I don't know about each of these circumstances and I don't want to pretend to know all the circumstances involved. There are any number of things that could be involved here. I think, in all honesty, it's not a simple process. We all know that, any provider is not going to be happy with dealing with prior authorization. It exists. It's a necessary evil, unfortunately, in the sense from the provider perspective, because while we respect the physician's authority and expertise and knowledge, we also have to think about the greater good of all of our insurers, all of our insured lives. And we also have to consider that we have access, as well as they do, to best practices from clinical societies and so on and so forth. So we have to use those sort of approaches to compare whether under the circumstances of a particular patient, it is appropriate to necessarily cover that without requiring additional information. And that's the purpose, of course, of prior authorization is if we say no, it's because we need more information or the criteria does not match what clinicians have decided as a matter of best practices or clinical, standards is not appropriate. So I'm not going to sit here and say that it's a seamless, easy process. And that doesn't involve lots of phone calls and lots of interaction. It also involves, a lot of times where a lot of the information is incomplete. We'll say we need more information. We get some of it, but we don't get all of it. And, again, hopefully the rapid adoption of electronic records and improvements in health information technology will help facilitate that. I know that Medicare is pushing very hard to, standardize and push a standard medical record and prescription policy. So I think that will continue to get better. There's also work on real-time, benefit checks and or prior authorizations and approvals so that hopefully a physician can do this at the site of care while they're visiting with the patient. So again, there's a lot of room for improvement. We're not going to sit here and say that it's perfect and it's smooth, but I'm certainly hope and would expect that it's going to get better over time. And we need to work on some of that friction and figure out why that's happening.
So when I visited with HSHS in Oconto County, the pharmacist there was aware of the fact that there was a, what do I want to say it? Like the drug doesn't arrive. There's an alternative where I can use the drug on my shelf, but they worried about payment. I was surprised today to see the number of people that are saying that they'd never heard of that before. Do you know how many of your member plans or what the percentage is that has in place, my drug does not arrive?
I can speak to AHI members. Based on the conversations that I've had with AHI members, they all have this exception in place. Now, I have been just generally surmised there could be a circumstance where maybe a self-insured employer might have a different arrangement through their TPA, but on behalf of the plans that we work with. And one of our members just implemented this in 2022. Another one implemented it in the middle of 2021, and another has been doing this since 2020. So that's the time frame we're talking about for AHI member companies.
So when you say that, are you referring to they're implementing white bagging in that time frame? So as part of what's happening is that white bagging is relatively new and we haven't worked out the kinks. Is that? I'm going to defer to some of my colleagues here. Senator Jagler.
Oh, I was just nodding. That's the exact question I have. Because when we get to this, I'm going back to the point I had earlier. What if we're not here? What if this can't get fixed? You guys have been in our office. Hospital Association has been wonderful. Our providers have been great in explaining this. 4 months ago, I had no idea what white bagging was. Been told it hardly ever happens, hardly any problems. Now it's clear there are problems. And I go back to what happens if we don't get this fixed? What do you see the world looking like on this end, on this issue, as contracts are being re-upped? I don't know when they're re-upped. I'm sure this will be part of the negotiations. I'm sure you'll be better at it, but that's the one thing I haven't heard is anything from the people who are opposed to this, admitting there's some issues here for patients and saying this is what we're doing to fix it. So if you got, I mean, there's not really a question there, but
And I'd be happy to speak freely, honestly, about this. RJ, the executive director of AHI, and myself, we've been talking about this just because, we've been dealing in this space for quite some time. And there are some things that doesn't make sense. How are we going to do this? Rural hospitals, especially if they don't have the purchasing power, the amount on the shelves. I think this legislation has been an opportunity for everybody to have a discussion. And as people move towards next negotiating years, the shot has been, sent across the bow. I think it's in the interest of the parties to sit down and talk about this. It's my opinion that we don't need to legislate this. Obviously, I have a bias for a whole host of reasons, but this has been an exercise for people to hear what the problems are and whether or not there's just, process improvements that can be made. And I would hope that that can get worked out. Now that's on my companies and their contracts to figure out. I can't speak on their behalf, but I would think that this would be an opportunity to do so.
Yes, I would agree, Senator. I think that like any relatively new process, things always could be improved. And certainly it's not in our best interest to not improve a system that doesn't work. I mean, we don't want patients to miss doses. One of our primary focuses as a health insurer, as a folks who provide these benefits, is we recognize the value of adherence. Medication adherence is paramount, especially in the drug benefit space. If we can keep folks who are dealing with chronic conditions on their medications and that are not missing doses, they're much less likely to be admitted to the hospital for, emergency surgery situations or other things that are quite a bit more expensive otherwise. So we are not of a mind that, interruptions in care or delays and so forth are the right way to do things. And I think, honestly, depending on each situation, you might have a different explanation for why there are delays.
I know you can't speak for everyone, but have there been any contract renewals since this white bagging started?
Respectfully, I don't know the answer to that. I'm not involved with contracting of our members. That's their purview. But I would suggest that despite claims to the contrary, hospitals are actually quite effective in negotiating with health insurers for inclusion in networks. I would also add that we have very specific access requirements that are in place set by not only clients, but by the federal government for Medicare, for TRICARE. We have to have a certain number of, whether it's pharmacies, hospitals, so forth, access to those facilities by patients, whether it's in a rural area or in an urban area. I would note that in all honesty, many rural providers will have a significant advantage in certain respects, not all respects, but certain respects, because there are fewer competitors for insurers to negotiate with. And if we have to have them because of the lack of competitors or lack of alternatives in a specific area, they're in a much stronger position to tell us what they're willing to accept and not in terms of negotiations. So I think, it's important to keep that perspective that, we're not sitting here dictating terms to anybody.
Thank you, Chair.
I have one follow-up to that. So we heard hospitals say that they are not going to do white bagging. But yet in your testimony, because of these REM, and I'm not going to say it right, these REM drugs or whatever, this has been going on for years under certain drugs that are forced this way because there are only a limited number of pharmacies that can dispense them, right? So this model is out there. And as Senator Jagler said, until 4 months ago, nobody had heard about this. So at some point with these REM and these specialty pharmacies, it's been working. Is that
I would
a fair
say
statement?
I would say that's correct. And I think when you're dealing, it's important to recognize that not all specialty drugs have REMS requirements, these risk evaluation mitigation strategies. I think that's largely, you're going to see that with some of the more experimental or the more novel cancer drugs.
Okay.
But I wouldn't say that that's a common practice, but I would also mention that because of these limited distribution arrangements, that the hospitals will be receiving their drugs, whether it's through white bagging or not, from a specialty pharmacy, depending on these arrangements for these particular drugs. So I think in as much as they are a supplier, just like a wholesaler or a drug manufacturer, which isn't that common anymore, to be honest, but through a wholesaler or a manufacturer, they're just like any other supplier. And the difference here is that we are focusing on providing the product and paying them for the service of their clinical expertise, not for their inventory management or their drug acquisition management or price management. We're taking that work out of their hands and we're providing them with the product so that we're paying them. And, you know, since I'm mentioning the administrative portion of this charge versus the drug reimbursement charge, I'd mention that, again, to the point about having proper contract negotiations, I think this is a perfect example of where, you know, pharmacies and hospitals and other providers should be, you know, using the negotiation process to address some of these concerns. And, you know, if a clinic, for example, has a storage facility for their own products, which they acquire, it shouldn't be any different when they receive it from a specialty pharmacy. It really shouldn't. The only difference is they're not acquiring the drug and keeping it in stock. So I think in terms of the additional costs for managing and or disposing or so on and so forth, those charges or whatever those costs are should be included in a discussion over what the service charge should be. It's a catch-all for all of those administrative services. So again, I'm not going to sit here and say on behalf of clinicians that they are getting properly or adequately reimbursed, because I don't know that. But I would say that that's what that is for. And if that is part of the concern, then that should be considered part of the negotiation process with insurers and providers.
Thank you. Questions? No, thank you guys very much for your testimony.
Thank you very much.
Up next, we have Angela Foster from Marshfield Medical Center and Carl Selvik from Fort Healthcare. We still probably have about 8 more groups to testify, so I am going to ask our testifiers, I do not want to cut you off, but let's not repeat everything that's been said again. Let's get maybe some new information or something a little bit more in depth.
Good afternoon. Chairman Felskowski, I'm gonna be honest, I'm nervous. This is my first time ever. And to the members of the Senate Committee on Insurance Licensing and Forestry, thank you for allowing us the opportunity to come and chat with you today about Bill 753. I also want to thank Senator Jagler. I really appreciate, as being a member of your district, your willingness to talk with us this fall about this very issue and what we might, in fact, be able to manage as part of this ongoing conversation. I would like to say to Corinne, while she's not in the room, as a fellow breast cancer survivor, I'm glad she's in remission today. And I'm grateful for her care team and family who were able to advocate on her behalf. Thank you to her and to her family for their willingness to be public about their challenges. My name is Angelia Foster, and I'm the Chief Administrative Officer of Marshfield Medical Center in Beaver Dam. We serve the greater Dodge County region and beyond, and we provide high-quality healthcare for thousands of patients in our community. And we're an important safety net for those in our community who cannot afford life-saving medications like those that are being discussed here today. At Marshfield Medical Center Beaver Dam, we utilize the traditional buy and bill model. We purchase medications from our supplier, provide them to our patients, and bill the payer for the medication and that administration. This model affords us the opportunity to provide optimal care to our patients by ensuring that quality, safe medications are being provided through efficient care coordination. I can tell you that at our facility, we highly discourage the use of white bagging for many reasons, including the disruptions to the traditional model that was described previously. I will share with you, though, since we are friends, families, and neighbors taking care of our friends, family, and neighbors, We do at times have moments where our patients ask us for this very service. And so we did our best to accommodate a patient that had a payer mandated white bagging for their specialty medication. During the process of coordinating care, we received no contact from the specialty pharmacy providing the medication to us. The patient had difficulties navigating this process with the specialty pharmacy, similar to CRIN, and could provide very little information to our staff. We had no indication of where the medication would be shipped to or when it would arrive. Eventually, the medication was shipped to our hospital, was stored temporarily in our pharmacy refrigerator and administered to the patient. However, the result occurred only after countless hours of dedicated pharmacy and nursing staff working to coordinate care for this patient as well as the patient's times themselves. This patient alone had to be rescheduled 3 separate times due to delays in receiving the medication. And as I don't have to say to any of you, with staffing shortages at Marshfield Medical Center Beaver Dam at critical levels right now due to other things, we have made the decision that we can no longer try to accommodate on behalf of our patients the ability to white bag simply because we don't have staffing to manage it. Now imagine trying to complete this process for hundreds of patients. It's simply not scalable and it's not sustainable. We do not have the financial resources, the staffing resources, and storage capacity to effectively manage this process. And because of these issues and the importance of maintaining the high quality of care we have come to expect in Wisconsin, I'm asking for your support relative to the bill. I thank you for your time. Carl?
Absolutely. Chairwoman Felskowski and members of the Senate Committee on Insurance Licensing and Forestry. Good afternoon, and thank you for allowing us the opportunity to testify today in support of Senate Bill 753. I also want to recognize Senator Jagler. Thank you for meeting with us last fall in Columbus when we spoke. So my name is Carl Selvik, and I'm the Senior Director of Clinic Operations at Fort Healthcare. I'm also a pharmacist by trade, in addition to being a healthcare administrator. I was the previous director of pharmacy, and then I also started a specialty pharmacy in my career. So I'm pretty knowledgeable and have been in this industry for quite some time. I'm here today representing Fort Healthcare and the patients we serve in the greater Jefferson County area. That does include areas of Watertown as well. I'm also here as a patient myself and one with a very serious disease like Corrine that needs and has needed expensive pharmaceutical medications to treat since I was in college. I have a severe form of Crohn's disease that is fortunately in remission since I've been in college. But prior to being in remission, I did have to let all of my college professors and clinical preceptors know about my disease, as I would need special accommodations. And after telling them about my condition, I would often be told very motivational stories by them about how they knew someone with Crohn's disease. And in these stories, that person always seemed to either drop out of college, be unable to work, or have some disease exacerbation that was quite serious from this disease. I wasn't personally motivated by their stories, but I appreciated that they shared them with me. Now, luckily, my doctor and I did find a medication that controlled my disease symptoms, and I have been in remission for over a decade. So the question was, hey, how new is this? It's not new. It's over a decade. I won't age myself, but it's over a decade old. As one of the medications that I was asked to go on was a white bag medication at the time, and also brown bag. So that medication was called Remicade, and it was dosed by a patient's weight. Now, because of all the stories that you were told today, and because of the fact that I am a horrible patient because I know too much, I worked with my doctor to go on a different medication. So that was the top prescribed medication by my gastroenterologist. But that was the last medication that I was willing to go on because it would have been forced to be white bagged or brown bagged by my insurer. So I did go on a more expensive medication called Humira. That was actually more expensive for my insurer and myself. Now, luckily, that medication did work. It wasn't the first prescribed medication. And because of all these incidences that you've heard in white bagging, unfortunately, we didn't go through the process that we wanted, but I was lucky enough that my insurer allowed us to skip that process. So what I kind of want to take you through is what would patients like me have to go through with a weight-based infusion medication? Why, as a pharmacist, was this the last resort that I wanted to go on to treat my medication? And I need you to understand how sick I was. I have a severe form of Crohn's disease.
I was wasting away. I would go home and sleep because I wasn't in control. I could barely attend my clinical practices, and I almost had to drop out of college. And at one point I asked my dad when I was looking in the mirror and I looked green. And I said, "Dad, do I look green to you?" And with a good fatherly look, I said, "No, son, you look great." I did not look great at the time. Let me tell you that. But luckily, after many years, did get on control. Now I'm in remission. I am able to work. I don't have to miss work or any of those items. And by working with my provider and get on a controlled medication, my disease symptoms are completely controlled. However, as a patient, I'm very concerned. This medication won't work forever. That is how we know of this disease. Eventually, my immune system will start rejecting this medication. And I may have to go through this process. I may have to miss work. My current health system wouldn't allow me to white bag, and I may have to then drive 30, 60 minutes. I may have to miss half days of work just to get the treatment that I need. So I'm here asking both on behalf of our patients and myself to support Senate Bill 753. So the process with weight-based infusion medications that you've heard is that the white bagging practice really creates a disconnect between the contract pharmacy that is mailing the medication directly to the hospital and the hospital that is infusing it. And for medications that are dosed by weight, this disconnect absolutely creates negative financial and health implications for patients. As a patient myself, if I was on Remicade and I showed up for my infusion, and I just testified and let you know I was wasting away. I was rapidly losing weight. So if my weight had changed, I could probably no longer get that medication. If that pharmacy couldn't make that right dose from the medication that was sent to them, I would now have to be further delayed. And my disease could not have those delays. I would get very sick. So once a medication leaves the pharmacy, also know that it cannot be returned. So as a patient, I would incur another financial charge as I work with my insurer to then send out that medication to them again, because that would have to have been wasted if it was the wrong dose. So this would have caused delays, increase in cost to me, and ultimately my health would be put at risk. So you can see why I didn't want to go on this medication. Now, luckily at the time, my insurer did let me go on other medications, but I can tell you these days, you don't get to skip those tiers. We were able to navigate with my insurer directly and asked to be able to skip that. And so luckily we were able to. So I also want to mention that I support the brown bagging prohibition put into this legislation. So let me tell you about the drug that I am on, which is a temperature controlled medication that is mailed to me, Humira. And the last person that testified said, "Hey, we have these great algorithms and we look at the weather and yep, oh, absolutely, it gets to them and we control all of that." That's just not true. So the medication is shipped to me and is always required to be dispensed from my insurer's contracted pharmacy and then mailed to me each month. So we live in Wisconsin and we are susceptible to very cold winters. I've had my medication mailed to me, and by the time I arrived home from work, the medication was left outside in polar temperatures for too long a period of time and it was now unusable. So what that person failed to let you know is you can control for all the way till it's delivered, if it's delivered on time, which, as we know, it's not always delivered on time. But these are everyday working people. I'm an administrator. I have sometimes 12-hour days to take care of our community. It can't be left outside in polar temperatures for that long. So if that medication arrived that day and it was there, unfortunately, it wouldn't be usable. Now I'm a pharmacist, so I can navigate that and get a new supply. But it does delay my care. I've also had my medication not arrive on time because it's been delayed in the mail. It's been lost in the mail. It's been shipped to all these other areas. So that's really not controllable. And then I've also had financial costs increased to me when the contracted pharmacy that my insurer used did not allow for any rebate cards. So switching from that medical benefit to that retail benefit that we talked about, of controlling costs for patients, it actually cost me more money because they didn't allow for manufacturer rebate cards because that pharmacy was owned by my insurer. So at that time, I had to pay for the full cost of that medication. So, with my background as a pharmacist and a healthcare administrator, I fail to see how I've personally benefited as a patient from this white bagging or brown bagging legislation. And I do think I am pretty knowledgeable on the subject. So if a person who has a doctorate in pharmacy struggles to navigate this system, it is unreasonable to expect that our everyday patients can navigate this process successfully. So I'll just end my testimony by sharing the reality that our patients are experiencing today. Due to the concerns that you heard, many health systems have stopped allowing for white bagging to happen in their facilities. So if they do allow it, only allow it on a patient-by-patient basis. Senator Jagler, I let you know when we met in Columbus is that our facility doesn't allow that. And so you had asked, what happens if we don't do this? Well, what will happen to the patients in your community is we're one of the sole sources of healthcare and ambulatory infusion centers in our county. So if we don't allow it and the patients can't come to us, which is why we have a patient-by-patient exemption, because we are accountable to our community, regardless of their insurance, and we want to be able to take care of them, they'll have to drive long distances. They'll have to go out of the county. They'll have to miss days of work just to get their medication infused. And the patient will have to navigate that process. That insurer isn't going to tell them where they can go and get this information. They have no way of knowing which facilities allow white bagging and don't allow white bagging. So what we would do is allow it on a patient-by-patient specific example, and then help them navigate that system is probably how we would do that in the short term to get them to an infusion center that would allow that practice, that would be a network for them, but it would probably be at a long distance. So really, I ask you today, as an administrator of Fort Healthcare and as a patient that has been affected by this, I ask for your support of Senate Bill 753. It is critically important that the communities that we serve have continually access to the life-saving medications that their doctors have prescribed. And this practice has limited that and prevented patients from getting that. So, Madam Chair and Senators, thank you for your time today.
Thank you both for your testimony. Do we have questions? Thank you very much. Up next, we have Matt Ort. Did I say that right, Matt? Team Cheryl.
So I'm a private industry executive with experience in manufacturing and retail, and most recently I was the VP of HR. Thank you. The VP of HR and Medical Services at Merrill Steel in Schofield. The medical services part was added later after we had good success with healthcare. Didn't even care much about healthcare until about 6 years ago, and started digging in and seeing the cost and seeing all the suffering, and started problem solving and started having good success. Although a majority of employers have not gotten to that point and are still struggling greatly. Currently, I work at Team Cheryl Companies in Stevens Point. We are a retailer. We have about 60 stores, roughly 30 convenience stores, and some Subways, about 26, and some tire centers. And there I lead healthcare strategy as well, about 700 associates. So I'm also in central Wisconsin as part of that passion that developed over the last 6 years. I founded and lead a healthcare best practice group among employers and others to find ways to manage out of control costs and be able to provide good benefits to employees and families. We have about 50 employers in that and about 150 others, mostly providers, but various others who are interested in free market healthcare and improving healthcare for Wisconsin. So as part of that work, that passion developed, won some awards, the HR Professional of the Year for Central Wisconsin in 2019, the Healthcare Innovation Award in 2020, the National Employer Purchaser Healthcare Excellence Award in 2020, which previous winners were Disney, Boeing, and Walmart. My wife and I live in Mosinee. We've been there for about 6 years, and we are foster parents for the Champion Foster Parents for Marathon County. and we're actively adopting little ones. We take in newborns, often addicted to drugs. And we started a nonprofit called NOAA. It's a foster closet. And we won the Governor's Award in 2020 as Foster Parents of the Year. The reason I share that is not to boast, but just to share my love for the community. So I've been listening to a lot of the discussion today and been making notes and kind of changed my notes a little bit. But one thing I'm hearing, I guess, is, I empathize greatly with those suffering. I hear it every day. I spoke to 30 associates last night at an event we had. I had a line of 6 people line up afterward as I talked free market and our strategy to make this reasonable and talk about non-transparency and so forth. I had a line of 6. One person said, I had an ER, I have a $65,000 bill. Another person's in line, I have a $6,500 bill and I haven't even been diagnosed yet. And it's on and on and on. So I guess my opinion would be that what I'm hearing today is that we have maybe an opportunity. Problems are just opportunities in disguise, according to my view of the world. But we have a problem to fix. I'm not sure it's a legislative problem to fix because we have 100 more problems behind that problem. And if we're going to have 100 laws, if law could have fixed this one, the federal law might have fixed that custody chain or that supply issue. If law can fix it, we wouldn't be taking in newborns with meth addiction because meth is illegal of the mothers being addicted to meth. So I'm not saying I'm against legislation in some cases, but it feels like we're not problem solving well. My first job out of grad school, I worked for a Toyota supplier. I watched Toyota come in and fix everything, turnover and huge new product issues. Just it was a mess and they took it to great. I got recruited to Toyota. It was 8,000 people. You're making 3,000 cars every 24 hours. And I learned root cause problem solving, which is really my secret today. It's their secret. They're the #1 automaker in the world, #1 in the US now. It's their secret, effective problem solving. And I'd like to believe that if we work together and solve problems effectively, then we do much better. However, I'm still seeing many things from the hospital systems that tell me they maybe don't have intent, that they really want to add cost. One of those is the unwillingness to share prices. I asked the hospital to bundle 6 months ago, and they came back and they said, we're unable to do that. Bundling means saying how much for the knee surgery, not all the things, right? They said they're unable, not they're unwilling. They're unable. And I said, well, it's just adding 3 numbers, the surgeon, the facility, and the anesthesiologist. You can add 3 numbers, right? They weren't willing to do it. So lots of examples like that. Part of it is with misaligned incentives. When costs go up, certain entities make more. And the employer and the employees are always the one paying for it. As in this case here with this drug bill. We might get a flat tire, so we'll run the car with 8 tires and then we've got to pay for it. Right? We're just not really problem solving at all. So I think that's part of it. I feel like with healthcare costs out of control, we're in an emergency state. If we're not there, we're approaching it. I use the word unsustainable. I've heard that come up many times today from both sides of this argument. I have a whole presentation on it. It's called Unsustainable. It means the rate we're going, we can't continue. And I'd like to believe this is really about patient care, but I don't see it. I believe it's about monopolizing another piece of healthcare. I looked on CCAP, a group of us looked, it was a couple of years ago, but in a 90-day period, 400 families had lawsuits against them for healthcare in a 90-day period from one system. 2/3, this is from the American Medical Journal Public Health Research, 2/3 of the bankruptcies in America are related to healthcare. 3 out of 4 of those had insurance. That means over the last 20 years, the health insurance plans have degraded so much that they're now just catastrophic. They're not really insurance. They call that functionally uninsured, right? It only covers your premiums $800. It gobbles up your paycheck, and your deductible $6,000, $8,000, or $10,000. How in the world can you're paying for your medical care anyway, so what do? You avoid it and you get sicker. That's no good for anyone. Another statistic, by 2030, the average American family of 4 is expected, healthcare is expected to be 52% of their income. That's as much or more than the house payment or the auto payment. So this oath of do no harm, I've heard that come up today. Do no harm needs to apply to a person's financial stability as well. Overcharging and then often ending up in garnishment of wages, and liens on home is no way for a nonprofit to act. These nonprofits, by the way, if you investigate their finances, often have tens of millions or hundreds of millions in the bank. I wish we could say that is a for-profit business. So recently I called a local provider, and it was I wasn't even trying to play games or anything. I just, how much for this service that you do, by the way, 10 times a day. I didn't say that, but they know that. 10 times a day. They wouldn't tell me the price. I said, you're actually our preferred provider of all things, right? I mean, I just want to know. Well, they said, call the hospital system. I said, why would I call the hospital system? You do the work. And I wondered, I said, how do they know how to bill then if they don't know the price? And can I really trust you? I think the latter, my answer would be no, because you're intentionally not sharing a price that you do 10 times a day. And even if there's a little bit of variation, you're not sharing it. How can I shop? We don't, as someone said earlier, we don't shop for anything else that way. We won't tell you the price, but you have to shop here. That's a horrible situation. That's why we are where we are. I can get, in a little bit I do shop, if I go independently, I can get an MRI for $600, but the same truck drives to the system and they charge $5. The truck still charged $600. Who's putting the $4,400 in their pocket? I can get an ultrasound for $300 that costs $2,800 at the system, and they're making money on the $300. I can get a surgery for $23,000 that I pay $70,000 or $80,000. And if I go to Oklahoma, I can get it for $16,000. We can do better. So one of the things we've done, part of our main strategy, is what I did at Merrill Steel, and what I'm doing now is don't go to the system, avoid it whenever you can, because there's no way to win there. They don't tell you the price, and then you get all these surprise bills. I won't read it, but there's an example here at the end. If construction were like healthcare, if you had a roof leak and you needed a roof, that's exactly how it is. That's not an exaggeration. If you have time, I would ask that you read that. So the better path is to talk in simply not insurance code, which makes no sense. If we had a 15-minute visit for 3 topics, but I'm charged for 3 different things, just charge me for the 15 minutes or the 30 minutes. That's what we do with the independent clinics. But we're finding all sorts of partners. We're finding oncology. We're finding cardiology. We're finding imaging. We're finding surgery. And that's where we're shopping with partners who, someone said earlier, high value. We're shopping with partners who share the price. And often their quality is better. The book, The Price We Pay, the research from Marty Macri said that the price is often inversely related to quality in healthcare, which is not an easy way to process things. So again, we're failing the do no harm test. One entity or type of entities that have control over a certain product or service always leads to price inflation and ultimately price manipulation. That's the fear here. We're making a bad situation worse. We're throwing fuel on a very hot fire. I would say we're approaching, or we're in an emergency state. We need to look at those things, and we need to make healthcare affordable again. So I guess those are my key points.
Thank you for your testimony. And as you were testifying, I was thinking, I just listened when I do drive. I'm up in Tomahawk, so it's 3 hours twice a week. And I just listened to The Price We Pay. And your testimony kind of follows right along with that. One of the other things is I have friends now that go to Mexico, or I have a lady in our community that flies to Asia once a year, specifically for her healthcare, because she has chronic issues and she has they're self-employed and she has a very large deductible. So sad, but true. Questions for Senator Stasholt?
I heard you reference Oklahoma. Are you referring to the Oklahoma Surgery Center?
That's right. Yeah.
I'm a patient to there.
I've gotten to know the 2 owners, and I've actually been down there for a shoulder cleanup myself, which was about 6,000, which would have been over 25 up here.
I'd like to commend you on hitting what I think is one of the biggest problems in healthcare today. Probably 10 years ago now, I was in need of a non-mesh umbilical hernia surgery, pretty common surgery. And I had gotten divorced, and my spouse at the time had the insurance, so I didn't have any for a while, and was going to pay for it. It's something I needed. So I decided to shop it out, and I went to 5 different hospitals in my area. 3 of the 5 told me they couldn't give me a price.
Exactly.
And 2 of them took quite a while, but I got the price. And one of them was somebody I actually knew and said, even if the surgeon said, if I donate my service, it's still this much. And somebody told me about the Oklahoma Surgery Center, and I called down there and I said, how much for that surgery? They said, well, look at our website. They're
It's
all
on their
listed.
website. Yeah.
So you scroll through the website and it was like $1,700, which was a tenth of anyone. So I got an airplane ticket, flew down there, got the surgery, flew back, and I saved about $7,000.
They fly in over 600 people a year, and so it's non-insurance.
It's a
and-
model that we should
Yeah.
duplicate in Wisconsin, but
Mhm.
it's been frustrating since I've been in this building that there's some barriers to make that happen, but.
And we have some non-system ones even in Wisconsin that are within a few hours that are around 23 for that same surgery. That's a fair price. That's a reasonable price.
And you know what you're getting into when you leave.
And the surgeon that works for the Packers, and the surgeon that did mine does the Olympic athletes and the biking and swimming. I mean, these aren't.
Well, that was me.
Yeah.
Olympic athlete.
Yeah. Right. Yeah. I always say it. I used
Everybody's
to be athletic.
laughing.
I'm just an old guy now.
See, it's been a long day.
And I'd like to clarify just as a quick point, when I point out those things with the hospital systems, my daughter works part-time still as a CNA. I'm not talking about the doctors. I'm not talking about the nurses. I'm not talking about the majority of employees. I'm talking about some people at the top. This is kind of a national issue as well. But there's a lot of great people in those systems, but they're doing what they're told. So I just want to point that out. But if you are working in those systems and, how would you like to shop to not, and not see the price? I wouldn't call that the right thing to do. So.
Any other questions? Thank you very much for your patience today and your testimony. Up next, we have Steve Massey, Westfield Hospital, New Richmond, and that's it. Okay. You know what, Steve, before you sit down, can you sit in the middle? Because in Wisconsin, I get you better. Thank you.
Senator Staffield, I did not know you were an Olympic athlete, and we've met before.
In a former life. This job's tough though. Yeah.
Well, Chairwoman and the committee, I appreciate taking the time to allow me to testify before the group. And no, Senator Staffield, I appreciate I had a chance to meet with you here back at the end of 2021 to talk about some of the challenges that we've seen with white bagging. And so maybe just for the rest of the committee to hear. My name is Steve Massey, and I am the president at Westfield's Hospital and Clinic. So we're located in New Richmond, Wisconsin. I've been there for 10 years, and the organization's gone through a lot of changes. We've seen a lot of growth in our area in St. Clair County. But just taking a step back, we're also part of a large health system. And just to bring everyone up to speed, we're part of Health Partners. And so that's a large health system out of the Twin Cities, based out of Bloomington, Minnesota. But just a little bit about Westfield, just so you kind of understand just a little bit about Health Partners as well. So Health Partners is an integrated healthcare organization providing healthcare services and health plan financing and administration. Health Partners operates 3 hospitals. Westfield's is one of them, and 7 clinics, which we have a clinic in New Richmond as well. In Western Wisconsin, we provide care to over 75,000 patients in Wisconsin. Our plan, so Health Partners has an insurance side as well as a care delivery side, but our plan side insures over 65,000 members in Wisconsin. And in addition, Health Partners employs over 1,300 residents in Wisconsin. So again, a lot of big relationship with the state of Wisconsin. And so, we've heard today, and I've already noted that, I'm here to support the Senate Bill 753 that's taken the name of Kareen's Law. So, I'm just glad I was here to hear her and her husband's testimony. And again, I'm supporting the legislation. And the practice of white bagging results in significant problems. I'm not going to go into the details. I've submitted my testimony. In addition to what I've notated in my written testimony, just the administrative delays that leads to some of the issues with patients that we've heard today and the examples that have been brought forward. I think that complicates things as well, just the administrative burden that goes into the white bagging process. And I think fortunately for us, we've been able from a Wisconsin standpoint at Westfields, as well as the other health partner sites in Amory and Hudson, we've been able to push back and, get exemptions from the white bagging process, but we have seen the white bagging process impact patients in Minnesota within our care system through some really large organizations, Fortune 500 organizations that have implemented or in the process of implementing that through their self-funded insurance plans in the Twin Cities. And so again, I'm speaking just the fact that within our care system, we have seen delays because of the administrative burdens, some of the same complications that have been brought forward today by some of the folks that have had a chance to testify. So again, I'm here to support the Senate Bill 753. One thing specific about Westfield's Hospital Clinic, we've got a cancer center that's actually kind of a co-op or a joint venture between a couple of the hospitals within Health Partners, as well as 3 independent hospitals. It's a cancer center of Western Wisconsin. We all do a lot of infusions, both cancer related and non-cancer related. So, the idea of seeing an increase in the white bagging process, just has a lot of both our pharmacy leaders, our clinical leaders, as well as just our other facility and members of Cancer Center Western Wisconsin very nervous. And so I'm here also kind of speaking on behalf of the Cancer Center Western Wisconsin in terms of the concerns that we're seeing in both St. Croix County, Polk County, and Pierce County. And so again, how I feel is that focusing on safety outcomes, cost, choice, and value can be achieved through just the normal contracting process between providers, employers, and health plans. And so that I ask for support for the Senate bill. I think the other piece about, when you think about the fully funded plans, from an employer standpoint, because we're an employer as well, we have a self-funded. I know the question came up before around, the percentage of the pharmacy spend. We have about a 25% spend from our self-funded plan that goes towards pharmacy benefits. So it is a big chunk. If you think about what we're spending annually as an employer, we've got about 400 employees at Westfields. About 620 to 25 covered members. When you think about all the covered members for each of our employees, that takes up the insurance. And so it's a big dollar amount per spend. And but when you think about the fully insured and the self-funded plans, we're really not speaking about the fully insured plans. And so that's where, having the pricing discussion, the maximum benefit through that discussion, whether you have a fully insured plan or not, the benefits really hit everyone when it goes through that contracting process. So I know that was one of the questions earlier in the day around, we're not really talking about the self-employed who has to go out on the market to purchase a plan, and where white bagging isn't an option for them to benefit from. The other piece, my background's finance. I'm a former CFO. I was able to, get out of the finance world and get into executive leadership beyond the finance silo. But, I know there's studies that maybe have been presented about these markups. And I'm just really surprised, again, being part of Health Partners, we really talk about down to the front line about affordability and value. We talk about it every day as part of our vision about affordability. We talk a lot about the triple aim, where it talks about outcomes, experience, and affordability. And so we take it seriously. And so again, because we're an integrated system, we get to live in both worlds, both on the plan standpoint and the care delivery standpoint. And our prices for almost all of our medications that are administered in the outpatient setting and inpatient setting are out on our website. We do not mark up 400%. And so I can't speak for everyone, but that is not a practice that we would see. We know what our average wholesale price is, and there's not a markup that's 400 or 500%. And so, these may be studies that or practices that took place, but, we've come a long way with transparency. I know the Hospital Association has led the way. I can tell you, being on a border organization and working for a system that's based out of Minnesota, I know Wisconsin's well ahead of Minnesota when it comes to price transparency from hospital and clinics. And even before the regulation or the legislation that took effect that required us to put stuff out on our websites, we were well ahead of the rest of the country and well ahead of Minnesota even before that, in terms of putting prices out there and trying to lead the way nationally in terms of price transparency. And so, I think we've come a long way. There's a ways to go, but, we do want our consumers, we do want our patients, we do want our community members to be educated decision makers when they're choosing where to go to get care. And that's something that we take seriously. We have a community board, something we talk about at our board meetings. We have large employers, business owners on our board, and we talk about affordability and what it means. Whether it's the school district or the large John Deere implement dealer, we understand what it means. What they're spending their dollars on, and so again, it's something that hospital and clinics do take seriously, and it's something that this bill white bagging isn't needed to make that happen, from the eyes of from a hospital and clinic standpoint. So I appreciate the opportunity to speak in support of this legislation, and I am now available for any questions.
See, thank you for your testimony. I don't know if I heard you right, so I'm going to ask you to clarify. So Health Partners Health Plan insures over 65,000 members. Did you say that they practice white bagging?
They do not.
They do not.
Yeah, so that's a good point. Health Partners, as an insurance plan, we do not practice white bagging.
Okay, thank you. Questions from committee members? Senator Stasholt.
Along those lines, Steve, then do you take insured members with insureds that require white bagging?
We've pushed back in the instances that have come forward. This is a new practice for us. We did not see this 5 years ago. We've seen it ramp up, and we've pushed back on the cases. So specifically for Westfields and New Richmond, we've been able to get exemptions that have not had we've not had a patient have to leave to go elsewhere to receive the medications. We've been able to get an exemption.
Thanks.
Questions? Thank you very much for sticking around and testifying. Up next, we have Brian Dake from the Wisconsin Insurance Business. And then we have Jason Collada with Midwest Food Products Association. Opposed. Sorry, Brian, Wisconsin Independent Business.
Sure. I think Jason and I will go together here. I'll let Jason take over first.
Well, thank you, Chair Pelskowski and members. I know it's quite a hearing with a lot of passionate advocates involved, and appreciate you having this type of forum and doing what the legislature should on hot button issues like this. So first of all, I'm Jason Collada. I'm president of the Midwest Food Products Association. We represent a number of food processors located in 3 Midwest states, but we have about 40 food processing facilities in Wisconsin. I heard Reedsburg and New Richmond mentioned. Those are places that we have a strong presence. And I'm here, senators, I know Senator Stafschel, I think pretty well illustrated what the discussion is generally speaking, between quality and price. As a trade association, many of our members are self-insured, and there's a real concern that enactment or passage of this legislation will result in us having to escalate cost on the care that we provide. Recently, it's been interesting that healthcare has actually not been a hot issue that I've heard much about, because prices have been relatively stable from a lot of our members. Now that compares to, you heard an earlier speaker talk about the labor shortage everyone faces. We have a disproportionate amount of the canned vegetables produced in America come out of Wisconsin and Minnesota. And we're looking at 100% price increases for our tin plate, the steel that we use for that. And I just use that as an illustrative point. We're going to be suffering from foreign competition because that's the biggest input to our cost. And seeing something like this, where there's a concern that we could have a escalating healthcare costs, we're not excited about seeing that happen, understanding that there's issues with the system and with the provision of care. And so we are opposed to this. This does appear to us to be a contractual issue between the insurers and the providers, and that they really need to figure this out, as Senator, as you commented earlier. And so I'll hold my comments at that and allow Mr. Dake to speak.
Good afternoon, Madam Chair and committee members. My name is Brian Dake, President of Wisconsin Independent Businesses. By way of background, WIB is a small business advocacy organization. We proudly represent more than 2,000 small business owners across the state of Wisconsin. Most of our members, 85% in fact, own and operate businesses that we would describe as fitting within the legal definition of a small business, fewer than 25 employees and or gross revenues of less than $5 million. There's been plenty of testimonies today. I want to bring in the perspective of the small business community. You've heard a lot about many of Jason's members are self-insured. Our members are not. They have to buy insurance in either the small or in the individual or group market. So their options are either purchasing plans through the federally facilitated exchange or working with a broker. In 2019, WIB formed a partnership with 5G Benefits. They are a Fox Valley-based health insurance brokerage firm. And the owner of the company, Tony Gable, had reached out to us and had found some success in providing businesses in the small business in the Fox Valley with more affordable options than what were available through the federally facilitated exchanges. So he's offered that service to us. It's been nominally successful, not because of because he's been able to find things, but I think the reality of the marketplace is that small employers struggle to find health insurance that is affordable for themselves and their workers. We think this legislation would make the problem worse. We pay attention to the news. We pay attention to what transpires across the country and in Washington, D.C. And every time the government intervenes in the healthcare marketplace, the costs go up. If this bill were passed, we think the same thing would happen. I also wish to bring into this debate another factor that I don't think has been discussed today, and that's the labor market situation. If you're a small employer right now, you are struggling to find workers. There are many good companies out there that are able to provide a generous package of wages and benefits, including health insurance coverage. If small employers are looking to attract those workers to their jobs, they've got to have health insurance as an option, or they're going to be left aside. The best and brightest in the world are going to go where they can get the wages as well as the benefits. That is a big deal for us. So when we pass laws here at the state level that are going to increase costs, that only makes it harder for small businesses to afford healthcare, but not just afford healthcare for themselves and their employees, but to keep those employees around or to hire new workers to their payroll. So that really is at the essence of our opposition to this legislation. As Jason pointed out, and as I think we've heard throughout the testimony today, this really seems to be an issue in which I think resolution is best addressed between the payers and the providers, and leave the government out of this. So with that, I'd be happy to answer any questions you may have.
Well, gentlemen, I want to thank you for your testimony today. Do we have questions from committee members? Hearing none, thank you very much for coming in. Up next, we have Elizabeth Ports and Dr. Julie Mitchell from Anthem testifying opposed. Good afternoon, and thank you for your patience today.
No problem. Hello, thank you so much for your time today and for talking about this really important issue. I'm Elizabeth Ports. I am the Government Relations Director for Anthem in Wisconsin.
Hi, good morning. Or good, it feels like morning. Good afternoon. I'm Dr. Julie Mitchell. I'm the Chief Medical Officer for Anthem Wisconsin Commercial. And thank you very much for allowing us to speak today. We're really delighted to be able to testify against this bill. I am proud to work at Anthem, where our stated purpose is to improve the health of humanity. In Anthem's Healthcare Management Unit, we are in the business of member advocacy. We help members make the transition from hospital to the home. We connect members with primary care providers that meet their preferences. We help members make the most of their benefit plan. We provide social service resources to members with health-related social needs. In my role of Chief Medical Officer for Anthem Wisconsin Commercial, I work with physicians, nurses, social workers, pharmacists, psychologists, and quality associates to help our members and improve the health of the population of Wisconsin. And of course, I do that in partnership with Wisconsin's excellent providers. In my role as a primary care physician, as I am a primary care physician in addition to my role at Anthem, I frequently see how non-medical factors, such as financial worries over healthcare bills, often overtake the medical factors in determining the health of a population. Every day when I'm in clinic, when I discuss a patient's condition or what our next steps are to make a diagnosis, I hear questions about how much will that cost me? How much is that diagnostic test? How much is that medication? And so I see part of my role as a healer to make needed care accessible and affordable, or that needed care will not be accessed. That is why I support our specialty drug program. It helps members to receive the care they need when they need it at an affordable cost. And I'm deferring to my colleague Liz to tell us a little bit more about our program.
So I wanted to explain a little bit more as an insurer that actually uses this process about how we handle that process, what that process was with our providers in the state, and then answer your questions about how we as Anthem handle that. We can't speak for any other insurer in the state, but we can speak to what Anthem does. So we put this policy in place in April of 2021. So we began reaching out to our providers in April of this previous year. And we essentially gave them two options. We said, we can receive these specialty drugs at a heavily reduced rate through our specialty pharmacy, which is CVS. If you would like to continue the current practice of what is colloquially known as buying and billing, they can continue to do that, but they need to negotiate their rate with us to a much more affordable price, more in line with what we can receive from CVS. So Anthem works with 149 providers in the state, and of 149 providers, 143 of them have continued to work with us either through our specialty pharmacy or through continuing to buy and bill at that lower rate. That means that we only have 6 providers that we're working with in other ways that are not working with us with specialty pharmacy, and they are all from the same hospital system. So I heard a lot today about how white bagging is now mandatory. And I just want to highlight again that we've given our providers a choice. They can choose to become a part of our specialty network and continue to buy and bill at that lower rate, or they can go through our specialty pharmacy. They can choose based on the decisions they make administratively. Something else that we want to talk about is the exception process. We've heard a lot about that today. And I just like you were, Chairman, surprised to hear that many providers are unaware of this process, because for us, when we started this process in April, we conveyed the exception process to all of our providers in every conversation we had, especially if they were going to white bag. We also have an exception form, which I have here. This is our exception form. It is something that the provider has, and they can submit with their claim if they need to use an exception. Now, why would they need to use an exception? Let's say there's a delay of delivery or there is a dosage change. They can file this exception reform with the claim, and then they are paid at their rate instead of just the administration fee that they would receive by going through CVS. So we've also heard a lot about waste, and I wanted to address just from Anthem's perspective, if there is a delay of delivery, the employer is not going to be paying for that cost. The patient is not going to be paying for that cost. Anthem, or in some cases, CVS, is going to take on the cost of that delayed drug. So we're not going to be billing twice for the same drug. In addition to that, I've heard a lot about how the drug can't be returned, which is true, but it can be used again for that patient. So I don't know how common that is, but it is an option. The drug isn't immediately thrown away in those cases. If the patient is going to be receiving the same care at a future date, they can use that delayed drug. But the end game here is that even with the waste, the savings of using the specialty network far surpasses any cost associated with any amount of waste. We have not received complaints from our providers about this process. We are unaware of major issues with delay of delivery or the need for dosage changes. So I guess I would ask, and you said, Chairman, earlier, how do we solve this issue? I believe that this process is working for Anthem. We are negotiating with our providers. Dr. Mitchell said are excellent providers. They are our partners in delivering excellent healthcare. We are making this process work through the contract, which is what we should be doing and what our providers are working with us on. So like I said before, 143 of 149 of our providers are working with us on this policy, and it is going well. Did you want to talk about patient safety?
Yeah, I can just add that when we made the decision to have the exception form, our North Star was, of course, patient quality and safety. So we chose to make sure that the attending physician at the point of care, knowing the medical and non-medical factors that are going on with that patient, we know that we aren't the ones as a payer that know that attending physician can fill out that form without any express prior authorization. We have a whole unit that is devoted to concierge care to any concerns. And that's why Liz is saying that we haven't heard any complaints. We double checked with that unit. We have not logged any complaints from providers with any kinds of problems. And, you know, I think one thing that we can all agree on here, we've heard a lot, both sides talk about high value care, both sides talk about non-sustainable practices, both sides talk about getting to that triple aim, which is better care, better health at a lower cost. And I think we all agree that that's where we want to go. And I think that our processes are meeting that triple aim. We know for a fact that cost is a part of quality. Sometimes people are separating that out. And I'll give the example, and I'm quoting from Kaiser Family Foundation study. Half of US adults say they put off or skipped some sort of healthcare or dental care in the past year because of the cost. 3 in 10, 29% also report not taking their medicines as prescribed at some point in the past year because of cost. So we can't separate out cost from quality. It's all together. And that's why our program matches Anthem's stated purpose to improve the health of humanity. I think we're ready for questions.
Okay, well, thank you for your testimony. So let me ask you this, Liz. So if you have that 1-page form for the exception, do you have any statistics on how many times that's been denied, or has it been denied?
I am not aware of any denials.
Okay. Because that was one of the things, I mean, we heard from a hospital pharmacist when we were in northeastern Wisconsin that they said, well, we don't even try because we don't think we'll get paid. So what I'm hearing is that you're paying. And the other question I have is, you said 143 have chosen to work with you either using the specialty pharmacy or, I'm going to say, becoming a specialty pharmacist
Becoming a part of our network, yes.
Do you know the breakdown of that 143?
I don't. I can't say for sure what the exact numbers are. I would say an overwhelming majority are continuing to buy and bill.
So they are choosing to bill you at that lower rate, and then
essentially they are choosing to do what they've been doing in the past, just at that lower negotiated rate.
Okay. Questions from CUNY members? Thank you very much for your testimony.
Thank you for your time.
Up next, Jim Deach, Bellin Health, and Sarah Jensen, MSN RN OCN at Bellin Health. Good afternoon.
Good afternoon. Chairman Felskowski and members of the Senate Committee, thank you for providing the opportunity to testify today in support of Senate Bill 753. My name is Sarah Jensen, and I'm an oncology nurse by trade. I am currently the Director of Oncology and Hematology at Bellin Health in Green Bay, and I'm responsible for all of our outpatient infusion services within the system. Today, I'd like to emphasize the critical nature of standardization and processes as it relates to the safety of infusion patients. Much of my written testimony has become repetitive, so I'm going to try to address a few of the things that have come up today, and then I'll hit on a few points from my testimony. So I've heard a few questions about these exceptions of policies, and working as an infusion nurse, I've spent time with the pharmacist and with the patients working through these processes. When we do try to go for these exceptions, I'm not aware of the paper, but that doesn't mean that that's not part of the process now. We spend hours on the phone, hours. So when we have a patient show up for their infusion and there is no drug to give them and we need to make an exception, it's not happening that day. It's probably not happening the next day. We have to find the resources and the time to accommodate that process. It is not a fax of a paper and an immediate return of an approval. To my knowledge of the white bagging patients we've succeeded in an exception once, and it took almost 2 weeks to get. The other piece I wanted to touch on was the prior auth. I feel like there's been a lot of questions about how that falls into this bill. As someone who stands in our financial office frequently, working through prior authorizations, I just want to clarify that prior authorization process comes before any of this happens. So the physicians write these orders, and our financial people, the first step is receiving that prior auth if it's required by the insurance company. If that insurance company denies that drug, we don't even talk about drug acquisition. We don't know if they would have made us white bag. They don't know if they would have allowed us to buy and bill. So until the prior auth process is done, none of this really comes to fruition. So I just wanted to clarify that piece of it. We currently allow white bagging at Bellin. I can't speak to how long we'll be able to maintain that practice. This practice requires extensive resources. In my written testimony, I go through the processes we go through. I won't talk through all that. I think we've hit on it. But again, regardless of who provides the drug, to give it safely, you need pharmacists, pharmacy techs, nurses, quality departments, accreditation coordinators. I mean, the list goes on. You can't do this in a thrown up building with a doctor and a nurse. So we take the safety of the patient very seriously. Every step of this process requires clinical experts, equipment, resources, time, and standardization. These requirements don't change with white bagging. Every patient whose insurance forces a white bagging requirement does so with different rules, processes, and expectations. For example, sometimes the first dose can be dispensed by our pharmacy, but the subsequent doses must be sent by an external location. Some specialty pharmacies require the patient to call prior to the appointment to get that delivered. Some people let the hospital call. So these variations cause extra work. Each of our locations that manages white bagging patients requires additional staffing hours to navigate these significant intricacies. For each white bagging patient we spend an additional 2 to 4 hours a week between pharmacy, financial, nursing to coordinate the order, delivery, scheduling, and coordination of care. An extensive amount of time is spent on the phone between insurance companies, specialty pharmacies, and the patient. Variation in operational processes affects patients. I want to touch on Andy Bagnell from HSHS spoke about them not allowing white bagging, and there was some question as to if one of their facilities does. I can't speak for their O'Connell Falls facility, but I can tell you, operating in the same city as HSHS, St. Vincent's, and St. Mary's, they don't allow it because we get their patients. And again, going back to the sustainability of it, it is one thing to manage one white bagging patient. It is a ton of work. And if we put a ton of work into it, we might be able to do it safely. But the more people that struggle to do this safely and stop doing it, the riskier it gets for those of us that continue. So last month, to speak to Andy's point, our infusion center was contacted by a patient receiving an infusion treatment for a GI condition at a neighboring health system. This patient's insurance carrier recently changed a policy or program, I think is how it doesn't fall into the contracts, and refused to allow that health system to continue. That health system is HSHS, that health system to continue administering their own stock of the medication. This was again in the middle of treatment. There was some talk about how they try to do this at the beginning of treatments. I mean, yes, if that program is in place when the patient starts, it will start that way. But when that program starts, there is no differentiation between people who are already started and who are not. If you're on that plan and that's what they're changing, then it applies to you. So they had declined. This organization, HSHS, told the patient that they would not white bag, and that's understandable due to the risk involved. Patient calls us. We inform him that we do allow white bagging at this time, but that his medication must be ordered by one of our specialists for us to agree to this form of drug acquisition, again, due to the already complicated process it creates. Because this patient's insurance would not allow his in-network provider, HSHS, to provide the full service of infusion, this patient not only had to switch infusion facilities, he had to reconsult with a new GI specialist, redevelop his entire plan of care, also that his insurance company could dictate where that drug was purchased. So I want to add one more thought. The question keeps coming up, what if we can't fix it? I guess the alternative question is, what if nobody will provide it? And that's horrible to think about, but that's what people are starting to do. And I think our organization, Bellin, as all organizations represented here, really value the health of that patient, and we don't want to do those things. And we'll likely be the last to do it if it really comes to that, because that's not taking care of our population. But we also have to do it safely. And if we no longer can do it safely, then we can't do it. So if we don't figure this out, whether it's through legislation, whether it's through contractual conversations, it's already going that direction. That's what we're seeing. And the likelihood, based on all the testimony today, the healthcare institutions feel it's unsafe. And the chance that we go to a table with these companies and where's the agreement, right? Where's an agreement on if we're not willing to do it and they require us to do it? If there's no agreement, then they can require it. But if those patients can't find some place to get their drugs, then what? As you can see, white bagging has the capacity to increase safety concerns related to integrity of the medication. It does create delays in care, and it does create extreme stress for patients who rely on the timely administration to maintain their quality of life. So in support of our patients and the patient stories we did not get to hear today, I respectfully ask that you support the Senate Bill 753.
Madam Chair and Senate Committee, thank you very much for all your time. And I'm sure you got to be wilting by now. My name is Jim Dietschy. I'm the Executive Vice President and Chief Financial Officer at Bellin Health. We have about 5,000 employees, serve 12 counties in northeastern Wisconsin. About half of the county or half of the population that we serve, which is about 650,000 people, are rural. So what I want to really talk, we are, by the way, the official healthcare partner of the Packers. And if that gentleman who provided testimony before.
And we appreciate you keeping them healthy. Make sure it happens through the weekend.
But if the gentleman said he received services from a Packer doctor, he received them from us, and we must have given him a very good estimate. Because we do give estimates. We've been giving estimates for a long time. There's new bills out there to obviously make this even more transparent. And we're excited about that. That's something that's good. So I just wanted to comment on that. The other thing that I would say is we keep talking about these charges. I am responsible. I negotiate managed care agreements. So I know another gentleman testified that, he's sympathetic to the providers and the clinicians, not sympathetic to others, probably like me, but I'm the one that does that work. I can tell you that we do negotiate these agreements for pharmacy, specifically these drugs. They are fixed payments. We can charge $1 million for a drug, but if the contract says we're going to get paid $1,000, we get paid $1,000. That's what it is. And most healthcare providers, probably almost every one of them today that testified, I can tell you their payments are fixed based off of ASP or AWP plus a percentage, right? And that percentage is to cover all the costs that Sarah and many other people testified to today. That's how it works. When you negotiate agreements like this, you are not just negotiating for specialty pharmacy. You are negotiating for emergency care. You're negotiating for orthopedic care. You're negotiating for cancer care. The list goes on and on and on. Hospital services, clinic services. It's all pooled together. All right. That's how it works. When you sign an agreement, which we do, and it is a contractual term, you expect for that term of that arrangement, for the, however, if it's 1 year, 3 years, or 5 years, you expect the contractual terms of those arrangements to be honored, right? Including drugs, specialty drugs, doesn't matter what it is, right? All right, so I agree that we did agree to what Anthem talked about. We agreed to that on January 1st, 2020. They changed the policy on July 1st, 2020. We have their members that we take care of, all right? They tell us we're through an administrative policy, we're going to change that, all right? When we negotiate, we're negotiating on the whole, all right? Not just for the administration of that drug. That's what happens. Now, can we try to sue them? I suppose, but during that period of time, do we stop seeing their members and our patients? Should we do that? I don't think we can. Actually, we can't. We have to continue to see their members, right? So we're very comfortable, and we have arrangements that with some of the payers, actually many of the regional health insurers in our state based here, we work those issues out. So they're not issues. It's generally with the major payers. That's the issue. They put in administrative policies halfway through a contract. This was 6 months. We have a 3-year agreement, 3 years, right? Now we'd have to do, we have to go back to try to renegotiate at some point in time. Or do we leave all those members and the employers that we serve out? That's where we're at. So those are the issues that we deal with when it comes to the managed care contracting process. You heard a lot today. You also were asked, well, why don't you just do your own specialty pharmacy? Maybe that would work for us, but some of the insurers won't even accept that. They want us to use their specialty pharmacy, not the one that we would create, right? We work with health partners, that was mentioned before, in our own health plan. We don't do that. We don't do that with our own employees. So those are the issues that we generally deal with. You heard a lot before. It is a public policy issue. It's a safety issue. I'm more than happy to work this out contractually on the terms that we've agreed upon and to revisit it, not a unilateral policy from one side. That's the issue. Thank you.
Thank you for your testimony. Questions? Senator Jagler.
When I heard your part of the testimony, I assumed you weren't working with Anthem because you said if there's a situation where there's a discrepancy in the dosage needed or whatever, you can't fill out a form. So that while that can't be based on the previous testimony, well, they must not be Anthem. And then it turns out
You're accepting that for right now, but they changed it after. That's the issue.
But I mean, the point was that there is no simple form that you can fill out in this exception, but the previous person who testified said there is a form and it's never been denied. So this is.
So my question is I would be curious to know how many of those forms have been filled out, because we don't know about the form. So we've never used the form. But we do call. I mean, we try, we do everything we can to get these patients the medication as quickly as we can. But when we call, we have to sit on hold for 4 hours. How do you find out about a form? And I have never filled out a simple form. The form might be simple, but when you fax it in, there is no immediate response. These are, I mean, it's no different than an authorization. You send in an auth that has to go through the processes, which is probably appropriate, but it's not simple. And it's in the middle of a complicated process and a patient standing in front of you. So we do work with Anthem, and we do white bag Anthem patients, and we do try to do the right thing when we don't have the drug in front of us. But it's not simple. That's my point, is it's not simple. Again, we got an exception once, but it takes time. This isn't oh, your drug didn't show up, let me just fax this in and we can give it. And that was my point with that.
But it sure sounded like it 5 minutes ago that was the process. You can see the frustration that we have stacks and stacks and stacks and stacks of conflicting information. Now you try to extrapolate that. We're here, we're listening to all this information. We've had, most of us, meetings from in-district, our administrators, hospital administrators. We've had multiple meetings in our office. We're going to make the recommendation for the rest of the Senate based on our testimony today. And I'm having a hard time getting a straight answer from everybody. It's very frustrating.
Any other questions? Thank you very much
Thank
for your
you.
testimony.
Thank you.
Up next, we have Mark Ham, Advocate, Aurora Healthcare, Arlene, I'm going to say Eigler, Advocate, Aurora Healthcare, and Laura Dow, Advocate, Aurora Healthcare. And Arlene, I hope I didn't kill that. Once again, we'll have all three of you testify, and then we'll do questions at the end. Thank you.
Okay. Chair Falkowski and members of the committee, thank you for the opportunity to provide testimony in support of Senate Bill 753. Thank you also to the bipartisan bill authors and co-sponsors for prioritizing this important legislation. My name is Arlene Iglar, and I'm the Vice President of Pharmacy Operations for Advocate Aurora Health. Advocate Aurora Health is the state's largest integrated health delivery care system with 16 hospitals, 150 clinics, 70 pharmacies, and we serve nearly 1.2 million patients annually. I'm here today on behalf of Advocate Aurora, along with my colleagues, Mark and Laura, who will speak momentarily, also in support of Senate Bill 753. White bagging is a growing problem that we're seeing more frequently in our healthcare system. As we've heard from many others before, these policies interfere with care delivery to patients, require extensive amounts of time for logistical planning from our staff, and introduce unnecessary safety risks, all to source a drug that we may have sitting on our shelves. The policies are bad for providers, but more importantly, they're just wrong for patients, most of whom don't even realize that until they have a major health issue, that they have to jump over these hurdles to get their medication. They understandably assume that in-network means they have access to our pharmacies. And unfortunately, white bagging means that when our patients need help most, we sometimes can't be there to provide care. So to highlight some of these process problems caused by white bagging, I'll turn it over to Mark Ham.
Thank you, Arlene, and thank you, members of the committee. My name is Mark Ham. I'm the Director of Oncology Pharmacy Services for Advocate Aurora Health. And in that role, my team and our patients experience the consequences resulting from white bagging requirements. There's often a lack of coordination between the specialty pharmacy and receiving pharmacy that can lead to treatment delays, and I have two examples to share with you. Recently, within a few weeks ago, one of our pharmacy technicians was told a white bag medication would be delivered to her pharmacy. She looked at our schedule, saw the patient was scheduled, but noticed she still hadn't received the drug. So she called the specialty pharmacy, and she'd learned that the patient needed to contact the specialty pharmacy first to pay the copay before they would release the drug. During that call, the pharmacy technician learned that the medication was sent 10 days prior, but was sent to a different pharmacy in our health system. And because of this, the patient was delayed by over 10 days as we tried to track down where the medication went, why it got there, and then it had to be delivered to the correct location. This scenario wouldn't happen under our normal processes because the medications that we purchase from a wholesaler, we generally know when they're going to arrive. And within a certain amount of time, they show up at about the same time each day. The ordering process from a medication wholesaler to the pharmacy is direct, making it easy to identify which medications were delivered versus which medications were ordered. This helps us maintain our inventory to treat the patient on the day that they are scheduled. Another problem with white bagging is what we've already talked about with dosage changes. So as patients come into the clinic, they can be weighed and their dose may change for weight-based drugs. And in the case of white bagging, if the amount of drug that was sent is not appropriate for the dose that's needed that day, the patient is either treated with a suboptimal dose or they need to be rescheduled, which can take an indeterminate amount of time, as we've already covered today. At the end of this, the thing I want to echo is that it's the patient who pays the price for this. Unfortunately, these are just two examples that illustrate the consequences of interrupting our pharmacy workflow. And as the prevalence of white bagging has increased, we've also tried to adjust by reallocating our staff resources within our teams. And for more on that, turn it over to Laura.
Thanks, Mark, and thank you, committee members. I'm Laura Dow. I'm a nurse and a manager for oncology services at Advocate Aurora. As we've experienced more and more instances of white bagging, our oncology service line has attempted to streamline the process and minimize the impact on patients by transitioning one of our FTEs into a role that primarily focuses on supporting this complex process. Her duties over the past few years have changed significantly as she works specifically with our oncology infusion centers and specialty pharmacies and patients to coordinate their shipments. As Mark mentioned, even with enhanced coordination, we still experience frequent issues with delivery delays, incorrect shipping, dosing changes. There are just too many different people and departments involved for this process to be successful. I'd like to share two specific, and I'll make them brief, specific examples showing how white bagging has led to interruption in care delivery in my department specifically that have come up recently. The first example is a 79-year-old gentleman. He has chronic leukemia for which he gets a separate treatment. But in addition to that, to his leukemia treatment, he receives an infusion every 4 weeks to assist with his compromised immune system. He was scheduled to receive his IVIG infusion. However, it had to be rescheduled because his insurance is now requiring that this infusion is to be filled through a specialty pharmacy. Our pre-service department was alerted to this, went through all the right steps. Our charge representative, whose main focus is white bagging now, was involved to initiate delivery. Our team nurses helped to coordinate. There is just so much time and effort put in by so many different people. Ultimately, the patient was contacted by the specialty pharmacy, and he called our office this week when he was due to say he had to postpone his treatment because his medication is going to cost $7,750 to fill through the specialty pharmacy, and he has to pay that copay before they'll release that medication to us. He has, along with our pre-service department initiating this, he's been enrolled in a copay assistance fund to help support that large copay. He hopes to have an answer on this next week, but until that time, we wait. For this particular patient, if we weren't required to fill through specialty pharmacy, his medication would have been administered on time and we would have followed the same buy and bill process that we follow with the rest of our patients. In the second example, our patient is a 50-year-old woman. She has an autoimmune disorder for which she receives an infusion also every 4 weeks. Her medication required to be white bagged. Specialty pharmacy requires a conversation with her to arrange shipping and payment before they will release the medication. She's 50 years old. She's a wife, she's a mom, and she works full-time. And when I say full-time, she works full-time plus. And she has a difficulty connecting with the pharmacy in a timely manner because of her work hours and their hours. In reviewing her last year of appointments for this patient, over almost half of her appointments had to be rescheduled due to shipping delays. This impacts this patient because of these delays. These are times that she has to take off of work in order to get her infusion, which does take a half of a day. In addition to that, her symptoms flare on a regular basis because of these delays. Her symptoms flare, leading her sometimes to seek out additional medical care. All of these examples are just a glimpse into recent experience with white bagging, a process that interrupts coordinated care, delays treatment, among other problems. We again thank the bill authors for bringing this important legislation forward and respectfully ask the committee to please support the Senate Bill 753. Thank you for the opportunity, and we would take any questions.
Thank you for your testimony. Do we have questions? Senator Ringhan.
Thank you, Madam Chair. I've heard a couple of times just in the last conversations that drugs were delayed because co-pays were not paid. If the patient were to be getting a standard medication from your facility, would they be required to prepay that co-pay?
The medication specific copay, no. Some of the insurances will require a copay to be seen in our office, which is typically a much smaller copay. I've seen them $35 or $50, maybe even $100, but not almost $8,000.
Is that very common that it's that high? The copay is that high?
I would not be able to speak to the frequency of it being that high.
If it was that high once, it would be once too many. Okay,
And
thank you very much.
If I could just add one more point, an important thing to remember is there's a shift in the benefit that pays this. So this is now, as we go through white bagging, part of the pharmacy benefit, whereas it's part of the medical benefit when we buy and bill. It gives us more latitude to work with patients that may be having financial hardship so that their treatment isn't delayed.
Thank you.
I'm glad you said that. That was going to be my question to you. So when it's white bagged and they're going through the specialty pharmacy, they have to pay their portion of it for the drug. But when it's bill and bag, basically you're providing it. So then
Correct. It's like any other charge that you have going to see your physician. You get the bill after the fact.
so no, it doesn't fall under the pharmacy benefit otherwise.
It falls under the medical.
Ah, thank you. Did not know that. All right. Thank you very much for your testimony. So up next, we have Vanessa Freitag, Ascension, and Lisa Gilbert, Ascension. I think Rebecca next. Okay. Good afternoon.
Good afternoon, Chairperson Filzkowski, Vice Chair Staff Schultz, and members of the committee. My name is Vanessa Freitag, and I serve as Vice President of Pharmacy for Ascension, Wisconsin, a faith-based healthcare organization operating 17 hospital campuses and more than 100 healthcare facilities, employing more than 1,100 clinicians. I'm here today on behalf of Ascension to express support in Senate Bill 753, also known as Crane's Law. Now, I will acknowledge that I have submitted my full testimony. A lot of the material, it has already been discovered today, so I will adjust my communication accordingly. I would like to start by saying the contradictions you are hearing today between both sides may be due to discrepancies in what insurance organizations understand about their own white bagging policies. It translates very differently on the actual operations side. Ascension first encountered an emergence of white bagging in early 2020, when we received notification of changes to drug coverage through a quarterly managed care communication bulletin. White bagging policies have been communicated inconsistently and are outside of negotiated agreements. As a result, we have had little time to prepare and proactively assist our impacted vulnerable patients, which I find unacceptable. We have witnessed numerous incidents in which white bagging has had a tremendously negative impact on patient care. And I'll share some of those examples before I hand things over to Lisa. From a patient financial burden, I think this was just recently brought up as a talking point. Third-party pharmacies are requiring our patients to pay their co-payments prior to the shipment of their medication. That is a very important distinction. Our patients are reporting that they are not being offered or directed to financial assistance programs in which they qualify for, creating additional financial hardship and burden, and often delaying their care for individuals who cannot afford to pay that upfront. By contrast, when patients receive their medications in the hospital setting, financial advocates offer patients that support to pay for their care, including assistance in applying for drug discount programs, charity card benefits. We also have encountered instances when specialty pharmacies have refused to honor pre-approved pharmaceutical discounts that patients have attained with the help of our staff. This is simply unacceptable. Patients are being asked to navigate the orders for their medication through third-party specialties. Some of these patients are cognitively impaired in their advanced stages of their disease and cannot manage this responsibility on their own. Patients often have lab draws the same day as treatment and may have medication changes that same day. Hospitals can quickly pivot to the new therapy plan, but white bagging does not allow this. We've talked a lot today about how white bagging is inefficient and challenging for healthcare providers, but ultimately the negative impact falls to our patients. Lisa Gilbert is here with me today to offer her background about patient experiences.
Thank you, Vanessa. Hi, thank you for listening and for having us here today. I am the Oncology Financial Support Supervisor for Ascension, Wisconsin. I lead a group of financial advocates that deal directly with the insurance companies for prior authorization and directly with our patients to offer them benefit investigations to help them understand what they'll be held responsible for with their medical debt and their oncology diagnosis. I have a couple examples of specific situations for our patients that have happened just recently within the past year, and all of the situations with the major payers and recent changes to how they would like us to obtain these drugs for our patient. Our first patient was an immunodeficient patient who had been receiving treatment with us for years, same treatment, changed insurance companies in January. At that time, we checked prior authorization requirements with the insurance company. That's when they usually tell us if we have to obtain the drug from a different source than buy and bill our own product. No auth was required, and we did not have to do that. So we continued on with providing his treatment as we normally would. Come July, we received 5 months worth of denials, in which he received as well. So you can imagine his concern that he would now be billed for 5 months worth of treatment, thinking that his insurance isn't going to cover it and we're going to bill him for those. At that time, we called to investigate, and his insurance company then told us that these medications should have been purchased through a specialty pharmacy, and we should not have been buying and billing our own product. We are still in the process of appealing those denials for him, because Ascension, Wisconsin will still provide care to our patients regardless on how the insurance company is demanding that we provide the drug or how we obtain the drug to them. We want to ensure that they're able to be treated for the disease that they have. So that patient is still in the works, but we did do everything proactively to find out how to obtain the drug, and we were never instructed on that. My second patient example is a breast cancer patient. She needed her day 2 medication. Her insurance company wanted it to be a specialty pharmacy, and her situation was more so about the copay, not about a delay in care, but more so about her upfront copay that would have to be paid before the drug was shipped. That was $4,100 for 4 doses, each dose. Luckily, she came back to us and talked to us about that, talking about how expensive it was and that she would not be able to afford that medication. We then enrolled her in a program. This was not offered to her by her specialty pharmacy. We did that for her, gave that information. They were able to apply that to this benefit, and she was able to get 2 doses at 0 cost to her. The next dose was a little bit less. We found out that her benefit from her copay card had worn out, or she used the maximum benefit, and she now had to pay about $1,100 for that dose. She did that because she did not want to delay her care or cause any issues that might put her in the hospital. Her fourth dose, we began to do some calculation. Her insurance company was a smaller company that took her medical benefit and her pharmacy benefit and combined them. Until she reached a maximum of $11,000, nothing was really covered in full for her. But with our calculating based on things that have already processed on her medical side and her pharmacy side, it should have already been met. Her insurance company then agreed that there was an issue, and they're still working that out to possibly refund her part of that money. So you have a pharmacy benefit and a medical benefit that aren't connecting everything perfectly together, causing further financial concern for the patient. If we were to do that and offer her our buy and bill medication, we would proactively be able to enroll her in many different types of financial assistance to ensure that she would see no financial distress that may cause her to stop her treatment. Our third example is a patient that comes to our Center for Neurological Disorders. And part of that disease that this patient has also causes terrible migraines, in which was being treated with Botox. And then the treatment had changed. We sent over to the different pharmacy, the different prescription, which they claimed that they never received. They sent the wrong medication, and the patient was not able to get it because it was the wrong ordered medication. The patient then experienced some very terrible side effects from not being treated, had an emergency room visit and multiple urgent care visits before that drug ever wound up coming back to us. Now, if that was our drug that was able to be supplied to that patient, none of that delay would have happened. The emergency visit and urgent care visits would never have happened. Those are just three very different things that could happen. And I deal very close directly with the staff on the front end that are having to help the patient guide through all of these different things that are happening. I think that the insurance companies, the people that were representing them today, may not be firsthand involved in the operations at the pharmacies or at the customer service representatives, or understanding the different hoops that we have to jump through to be able to get this taken care of. Our patient with the denied claims, there were 25 documented phone calls between us, the patient, his spouse, and the insurance company, and 2 different pharmacies before we were able to get that medication for him. So all of those things together, we would like to ask that you do take a look and you do respectfully consider this law to go into effect for Corinne's law. So thank you for allowing us to testify today.
Thank you. Thank you for testifying. You know, you talk about the patient with breast cancer, high co-payments. And I think that's where this committee, again, and that's with some of the conversations that's gone on today with our employers. And why are those co-payments so high?
Mm-hmm.
Co-payments are high to keep the premiums down so people can afford to have health insurance. But there again, high deductibles, I have health insurance, do I have health care? And I think your example right there is, you know, it's kind of proving that out. Yes, I have health insurance, but I have an $11,000 deductible that has to be met. So cost control plays into people being able to receive that health care. And I think that's some of the dilemma that we've seen today, you know, with all the different testimony. Questions from committee members? Thank you very much for coming in. And thank you for your patience today.
Thank you.
Up next, we have Wendy Bees from Theta Care.
Good afternoon. I'm going to try to keep my comments brief because I think we've covered a lot of stuff today, and I don't know that I have anything novel that I can offer. But my name is Wendy Beasy, and I'm the System Pharmacy Director for Theta Care Incorporated. Theta Care Incorporated, my organization, services a 9-county region in Northeast and Central Wisconsin. Within our service region, we have facilities that service a small metropolitan area in the Appleton and Neenah area, as well as we have 5 critical access facilities and multiple provider clinics that are out in our rural communities and really serve as important healthcare safety nets in those rural communities. You've heard some powerful testimony today about how patients and families across Wisconsin have been impacted by mandated white and brown bagging. Our patients at VitaCare have not been exempt from the negative impacts of these practices, which I'm here today to share with you. I'm really going to focus in and I'm going to pare this down and I'm going to share just 2 examples from some of our patients that we've seen recently. Specifically, these 2 patients, the first one is an oncology patient. This oncology patient was scheduled to receive her treatment. We have patient care navigators as well. And that patient care navigator did receive notification from the patient's insurance that they were requiring her drug to be white bagged. The specialty pharmacy requires several weeks to process a prescription order. So the appointment was rescheduled for this patient with this new knowledge that we'd have to wait. After processing the prescription, OptumRx required the patient to authorize delivery. Unfortunately, the phone call that the patient received from Optum was an automated phone call. So the patient thought it was spam, hung up before giving authorization. Nobody ever reached back out to that patient. In the sequence of events, the next thing that happened was the patient's appointment was coming up. I believe this was January 4th. One of our oncology pharmacists could see in the patient notes that this drug was supposed to be white bagged and took it upon themselves to call OptumRx a few days prior to the new appointment to confirm that the drug shipment would arrive on time, only to learn that OptumRx was waiting for the patient to contact them to authorize delivery. The patient was then contacted by our pharmacist. When they started talking about it, the patient had no idea what white bagging even is, had no idea that her insurance company was requiring her med to be white bagged, didn't know who OptumRx is or how to contact them. And we ended up having to reschedule the patient appointment yet again, a second time. The patients finally received their dose, but it caused a 6-week delay from the time that the provider order was written to the time that the patient was able to receive treatment. One thing that I'll add, just in this specific example, our pharmacist did also reach out to the insurance to see if we could have an exemption and provide the drug for this patient to at least get them care right away until the process could be worked out. And we were told that the patient was not eligible for an exemption. So if there is an exemption process, it's certainly not universal to all insurers, because that was definitely something that we attempted to do on our end. The second example that I'll share with you today is similar to, I think you heard a little bit of it before, but another one of our oncology patients was receiving treatment at a non-Theta Care institution up in Green Bay. So a little bit north of us, different market. In the middle of his chemotherapy cycle, his insurance dictated that he had to change to having his medications white bagged. The institution that he was receiving his treatment at does not allow white bagging due to the liability and safety concerns with accepting white bagged medications. From that point, the patient was forced to take it upon himself to call around and find a cancer care center that would allow for white bagged medications. After calling around, he got in touch with us, and we do allow white bagging. So the patient was forced to reestablish care with a new oncology care team, as well as drive from the Green Bay market down to the Appleton market to receive his chemotherapy. So that obviously for the patient went from having care within minutes of his house to now having to drive anywhere from 30 to 45 minutes to receive his care. The one other thing I'll just add about it is we as an organization have talked about not allowing white bagging because of the safety and liability concerns. We've really struggled with that, and that's why we currently still allow for it, because it's not patient-centric. And that's our mission at our organization is to improve healthcare for the communities that we serve, and that doesn't align with that mission. But it's to kind of go back to what somebody said earlier, what happens if everybody does stop administering white bag medications? Where does that leave the patients? And I think it's a legitimate concern if we don't do something. So just to close, the stress and the delay of care, that the two patient examples that I shared with you, and many, many other patient examples, I had a hard time paring it down. And it when I reached out to our multiple facilities where white bagging is occurring, I had no problems getting patient examples thrown my way, and they didn't have to dig back very far. These were in the last month. But the stress and the delay that these patients are experiencing weighs really heavily upon them and their care teams. So I ask today that you put yourself in these patients' shoes, because this could be you, this could be your loved one, your child, your friend, could be your next door neighbor. None of us, you included, are not immune to this practice, as you've heard today, because more and more insurance companies are mandating white bagging. So I'm here today to ask that you support Senate Bill 753. Thank you.
Wendy, thank you for your testimony. Do we have questions? Thank you very much for coming down. Now, up next, we have Rebecca Hogan representing Wisconsin Manufacturers and Commerce. Opposed.
I do look familiar.
Deja vu.
Right, sorry. It's one of those months where people could be here and there, otherwise not here. Good evening. I think we can say evening. Good evening. I am Rebecca Hogan, as I said earlier today, but I am now here testifying on behalf of Rachel Vervelde, the Director of Workforce Education and Employment Policy at WMC. Just for your awareness, I was the Director of Health and Human Resources Policy at WMC between 2011 and 2013, the position that Rachel now has, just with a different title. So I have worn this hat as well as the hat that I was here earlier for. So I am gonna, I wouldn't normally read, but because it's WMC's testimony, I'm gonna be reading it for you. As you know, WMC appreciates the opportunity to comment on Senate Bill 753, and they are concerned that this legislation was introduced and is opposed to its passage. You're familiar that WMC is the largest general business association in Wisconsin, representing approximately 3,800 member companies of all sizes and from every sector of the economy. Since 1911, our mission has been to make Wisconsin the most competitive state in the nation to do business. According to our most recent CEO survey, our members say that making healthcare more affordable is the best way that state government can help businesses in Wisconsin. The high cost of healthcare has consistently been a top concern of WMC's membership over the years, and that is for good reason. Wisconsin is an outlier when it comes to the cost of healthcare. In fact, a 2021 study by Wallet Hub, and she did have these anecdotes or footnoted, found that Wisconsin is the 9th highest state for the cost of healthcare nationwide. Often we hear that the cost of healthcare is high because our quality of healthcare is much better than other states. Unfortunately, that is not the case. The same Wallet Hub analysis shows Wisconsin has slipped to 13th for healthcare outcomes. That is down 4 spots from Wallet Hub's same analysis in 2018. The good news is that it is possible to be a high quality, low cost state. For example, Rhode Island is the 4th lowest in cost and the 8th best in outcomes. Even our neighbor Minnesota is better than Wisconsin, ranking second lowest in cost and 9th best in outcomes. Wisconsin needs to keep its employer-based health insurance system and promote consumer-driven healthcare. The state legislature creating additional hurdles, as is done in SB 753, eliminates employers' ability to innovate and provide quality, low-cost healthcare to their employees and their families. SB 753 removes important tools that slow and sometimes even reduce healthcare costs for employers. The bill eliminates a process called white bagging that health insurers and employers have sometimes implemented to deliver clinically administered drugs directly to providers. This process allows payers to control the cost of these drugs since hospitals impose massive markups on these medications. A study by the Moran Company on behalf of the Pharmaceutical Research and Manufacturers of America shows that 83% of hospitals charge patients and insurers more than double their acquisition costs for medicines. But shockingly, the analysis is even worse when more closely examined. 1 in 10 hospitals mark up drugs 900% or more, with 320 hospitals marking up medicines over 1,000%. With this stark of numbers, it is easy to see why employers and health insurers have turned to other options, such as white bagging, to provide affordable clinician-administered drugs to their employees and patients. If SB 753 would become law, there would be no tool to get hospitals to the table and negotiate the price of these drugs. And as the data shows above, it is imperative that the hospitals are held accountable for their markups on prescription drugs. It is quite shocking that the legislature would consider giving hospitals a monopoly on these drugs and push other competition out of the market. Employers currently are challenged to provide quality, affordable healthcare to their employees and their families. The trend of increasing hospital markups on medication is unsustainable. 9 in 10 plan sponsors say high drug prices already jeopardize the affordability of employer-provided health coverage. The legislature should be doing all it can to promote innovation and price transparency in order to create more competition, not less. WMC urges members of the Senate Committee on Insurance, Licensing, and Forestry to oppose this interference in private contracts that will take away an important tool for employers throughout Wisconsin to contain the cost of healthcare while creating a monopoly in the market for clinician-administered drugs. Thank you.
So thank you for testifying for WMC. I do have a question. So we've seen a lot of statistics today.
Yes.
About what's being charged. But these are nationwide statistics from what I can say. Do we have anything that is Wisconsin-based? Do you know?
I do believe I saw a graph yesterday of prices between how many dosages were between 10 and 20,000. I do have a chart that I can share with you.
Would you
It
share
might be
that?
one member company, but I can.
We
Yes,
would, yeah, if you could
absolutely.
share that with the committee. Questions for committee members? Thank you very much for sticking around and testifying. And up last, we have, but not least, Michael Ballinger and Jeremy Levin with Rural Wisconsin Health Coalition. Cooperative, I'm sorry.
Sorry. Oh, Madam Chair and members, thank you for sticking out with us. I am Jeremy Levin, Director of Advocacy for the Rural Wisconsin Health Cooperative. You have my written comments. The cooperative is 45 members, community members across the state. And we're very happy that the bill has 80 strong bipartisan legislators co-sponsoring. I'm going to turn it over to Michael Ballinger, our Director of Insurance Contracting, and I may finish up with just some final comments at the end.
Yes, good evening, Chairman Falkowski and Senate committee members. Thank you for allowing me to testify today in support of Senate Bill 753. As Jeremy mentioned, my name is Michael Ballinger. I live in Amherst Junction, Wisconsin, central Wisconsin, Portage County. This is my first time testifying. I have over 30 years of managed care contracting experience, like Jim from Bellin mentioned earlier. That's what I do every day. Probably it's my sole function, so a little differently than even what Jim does. I have worked for about 10 years on the payer side, including several of those that were, or a few that were represented today, and 20 on the health provider side before joining RWHC. I am responsible for helping our hospital members, not only in their negotiations with the insurance companies, but also with navigating the ever-changing managed care landscape with insurance policies. The majority of insurance companies that have implemented white bagging, specialty drug alternative, whatever it's called, have done so under the guise of policy change, protocol change, program change, change to the provider manual, or something other than a direct contract negotiation. Contrary to what we've heard, such changes have not typically been done as a proactive, good faith negotiation. And we heard the gentleman from Sherrill of working together, hardly the case in this. It's a take it or leave it, often through a notice buried in a administrative manual or online. It's been my experience that in the rare instance that they are willing to amend the terms, it is a take it or leave it. It's hardly a negotiation with the terms already set out. Some actually, when sending out notice about the change, included in the letter, if you're above X% of ASP, or if you accept X% of ASP, you're included. If you don't, you're not. Kind of a gun to the head negotiation. We also heard a little bit ago from Anthem about, and many of the payers or their associations that testified about these exceptions being available. I have for you, I didn't include it, but I will leave them excerpts from the Anthem website about the change to designated specialty pharmacy. Nowhere in here is it mentioned about an exception process. The letters that we've gotten or that our members have gotten have not included anything about an exception process. If these exceptions exist, which perhaps they do, why are they not more transparent? We've heard a lot about the hospitals not being transparent in their price or accusations of that. We're not seeing it in these documents. If it is such a process, you would think there'd be a link. Here's a form, click on it and you could get it. It's not the case. And again, I'll leave these with you. Okay. So besides these programs changing policies, whatever they're called, mid-member term or mid-contract term, the other thing that's changing, and it's also or ever subject to change, it's included in those same notices, is the list of the drugs. So a drug that may be on the list for white bagging today, very clearly they say subject to change. So it could be a different set of drugs this month, next month, or the month after. So a patient who isn't affected today, we heard some testimony of when they started treatment, it was included, and then their treatment course changed and they had to then go through these processes with that. It's not a one and done. Those are subject to change. And all of that, again, falls under the guise of an administrative change, which by contract, you negotiate that their terms can change. You don't think that those are the reimbursement terms that we're talking about here, but truly they are. There's, again, a lot of testimony today about the exceptions being available. They're not transparent in communicating those to the people, to our members. I can only imagine how the patients would feel about not knowing that something changed in it. We also heard that hospitals are good at inclusion in the networks and their negotiations, which again, we're not given that opportunity. These are done as a program change. If the contract is there, we would like it to be honored through the course of whatever that term is. Thank you again for listening, and we ask that you please support Senate Bill 753, not only for the sake of patient care, but continued access, especially for our members, for the Rural Health Cooperative that are rural and are continuing to try to provide the best care they can in our rural settings.
And I'll just add, it's great to have Michael at the co-op. Each of our member hospitals have their own patient business manager, our management offices that help patients sort of decipher the coverage that they have in insurance. Same offices that also help those with assistance. It is a very complex issue. Rural hospitals will have, upwards of 20 contracts, which will also have then subcontracts potentially. The purpose of health insurance should be to cover the rural recipients receiving the care they need close to home and not seeking ways to undermine the benefits of their health insurance coverage. We worry that health insurance, and it was mentioned earlier today that about 3 companies have started white bagging. Health insurance really is a copycat industry. So it's likely that once one implements this, we will be seeing further insurers following. White bagging we see as sort of just the tip of the iceberg of really eroding availability of care at rural providers. You heard both from Andy Bagnall of HSHS talk about care transition shifting and John Russell of Columbus on the fragmentation. Rural hospitals are connected with their communities, not only quality healthcare they provide, but the integral member of the rural community's economy and daily life. As health insurance companies seek to change care services covered at rural hospitals, steering services outside of the rural community are just further fragmenting the rural health care safety net. And you heard just that story between HSHS and Bellin, and that's just in Green Bay. Well, unfortunately, most rural hospitals and communities don't have a hospital just to go across town to get that care for. So it is a concern that we see of that really fragmentation and eroding rural care. So thank you so much for staying with us today.
So I'm going to ask you to elaborate a little bit. So Rural Wisconsin Health Cooperative. So you're helping these small rural hospitals negotiate contracts and stuff. I don't want to sound naive. This goes back to what Senator Jagler said, but I was under the assumption, and I know about the word assumption, that you guys were all part of networks, like you were owned by Ascension or whatever. So who do you represent? And
So of our 45 members, about half are a system owned or affiliated, and about half are what we would call freestanding independents.
Okay.
And that's not uncommon. I would say there's roughly, we represent probably 60% of the rural hospitals within Wisconsin. So what extrapolate 75 members or so. All of our members are also Wisconsin Hospital Association members.
I just learned something up in my area. Everybody's part of a network. I did not know that. So thank you. Questions? Senator Stashow.
I've asked it a couple times, Michael, I'm glad you're here. Right at the end, you kind of alluded to the fact that you're part of the negotiations on these contracts. What makes that contract not a contract so that they can get out of it? Isn't that a breach of contract? And if they're that fluid, so they're not actually a contract, why do you spend the time negotiating on them?
Job security. No.
That's why, yeah.
The contracts, almost everyone that I've been involved with, either side of the table, includes something that the provider agrees to, plans, policy, and procedures. And when we try to question that, said, well, you can't really mean you can change anything at any time. Well, the answer back is, well, we can't put different policies in place for every single provider and everything that they object to with that. Now, some of the larger systems, and when I was at a larger system, you have some leverage, contrary to what we heard before, that the rurals have leverage because there's no competition, but that may get some variation of that, where they may be at least get back to the table. But otherwise, it's done in the form of, we have a provider manual, it's online, we make a change, we put it online that we've made a change and you've agreed to it. So it's very generic, and you could argue and say, well, why do you agree to that? Well, they won't accept it if you don't. And it's done in a couple of different ways. Some payers call it a policy change, some call it a protocol change. Some stop so short as saying, well, we can't change the reimbursement, but what they're doing is saying, you can't get it from us. So we've not changed the reimbursement. If we would authorize it, you could still get it at that price, but that's not even on the table anymore. And you can see in the information that I left before that they're under a network bulletin. And that's where these take place and announced. Sometimes you get a letter, sometimes you don't. You have to go online. Someone else mentioned they have staff now that are looking through that, trying to stay on top of it. But even in preparation for today, I was in various websites looking for information about what is your specialty drug policy. Very hard to navigate. And I'm in the industry and have been there and done that for a long time. So for a member to find it, or someone, if you're not specifically looking for what that change is, or as I mentioned, I saw nothing about exception process in any of those sites.
Yeah, it's been really clear to me, and I think a few other people today, that these exemptions are sometimes available, sometimes not, but there's some work to be done on clarity, and maybe that's part of the new negotiations. I guess my last question is, and I think I probably already know the answer, but if you negotiate the contract and 3 months later they come and they say, sorry, we're changing it policy, or if you tell them to pack sand, what's the consequence to you? If you say, nope, you agreed to it,
well,
this is the contract.
Yeah, that's often a very tough decision for a hospital administrator or CFO to make, to say, we're going to decide to be completely out of your network. So now it's not only being able to provide those specialty drugs for those patients, but have to say, we can't provide any care for you. You're no longer in a network, or we can, but we're out of network and you're going to have to pay an even higher price for all of your services, not just specialty drugs.
And the reason that's a tough decision for those CEOs to make is because they don't want to lose the patients or the customer.
Not lose the patients from one perspective, you could say, or they want to continue to be a good community member and to provide care to everybody. We heard a lot of testimony at Ascension right before us that will provide care to everybody regardless of their ability to pay, and they're not alone in that. But so yes, it's to try to continue to maintain that relationship. It's a very tough decision. They get ugly. You see that in some instances where they go right down to the wire and stuff's put in the press of, someone was offering this and they wouldn't accept that. It gets ugly, and there's no winner in that. same like litigating over a provision of the contract, besides it being very timely. Usually not a good winner in that.
You know, one quick question. One thing that hasn't come up today and they didn't testify is OCI. I mean, I'm in the P&C industry, property and casualty. So when there are changes to a policy or changes to a benefit or changes whatsoever, they are required by law to send out, you know, to the insured as well, that there are those changes coming through. So I'm assuming, and I know we still have some insurers in the room, I'm assuming that you have that regulation also, but I shouldn't assume.
I'll maybe comment to one thing about that, just the insurance plan that RWHC offers to its employees. So the plan that I'm under, the company that insures us, and it's a fully insured plan, we're not self-insureds that we heard earlier, but they implemented specialty drug sometime, I think it moved a couple times, July, I believe. There was never any notice, because I went to our HR person and said, hey, did we know about this? Because it's done under the guise of saving money, right? But that money was not put back. We did not get a premium reduction. The members did not receive any communication. Now, again, I'm close enough to this that, you know, I looked for it. I didn't see it. I asked our HR person. They never got anything. Even at the time of renewal for our January renewal that just went into effect, here's our new network. There was never any, or your plan year, there was never any mention of, and it now includes specialty pharmacy. Please be aware your patients or your employees are aware that they have to receive these drugs certain places. It may be, again, communicated on a website somewhere if someone specifically looks at it. We never got anything as an insured employer or as a subscriber under that insurer.
I think we're gonna reach out to OCI and find out that information, and we will get it to the committee members. Any other question? Thank you very much for your testimony.
Thank you.
So that includes our testimony. I do have some registrations here that we'll be reading. Matt Schaefer, Medica, information only. Ben Van Pelt, SSM Health, information only. Nathan Butzloff, Wisconsin Association for Home Healthcare Medical College of Wisconsin, in favor. Rob Gunderman, Coalition of Wisconsin Aging and Health Groups, in favor. Connie Schulze, UW Health, in favor. Jesse James, 68th Assembly District, in favor. John Erpenbach, 27th Senate District, in favor. Melissa Duffy, Common Ground Healthcare Cooperative, against. Jonathan Moody, Quartz, against. Mark Gelhaus, Walker Forge, against. Sean Stephenson, PCMA, against. Ryan Rice, Prism Health Group, against. Jeff Behringer, Plumbing, Heating, Cooling Contractors of Wisconsin, against. Jeff Bielger, Wisconsin Roofing Association, against. Heather Cascone, PCMA, against. Matt Hauser, WPMCA, against. Lynn Sweet, Badger Mining Corporation, against. Lewis Smith, Blacksmith Advanced Physical Therapy, against. Gary Brochtrup, against. Darla Voigt, Colby Metal, against. Renee Langall, Midwest Carriers, against. Lynn Sweet, Badger Mining Corporation, against. Ann McCulloch, Colby Windows and Doors, against. Gary Protrup, Ameriquip, against. Tina Check, Wysocki Family Farms, against. Jeff Butts, Fond du Lac Area Businesses on Health, against. Kelly Ingley, OEM Fabricators, against. Ryan Lassay, All Metal Stamping, against. Rachel Andras, Trent Thermofoaming, against. Kim Bassett, Bassett Mechanical, against. Ryan Rice, Prism Health Group, against. Patrick Blackaller, Rice Lake Area School District, against. Shannon Gree, Colby Chrysler Center, against. Jim Beyer, the Fall River Group, against. Karen Loritz, Metal Tech International, against. Wendy Whitehead, Quick Trip, against. Katie Brammer, Enerquip, against. Thorsten Weiss, Trace-O-Matic, against. Brian Adesso, Menasha School District, against. Dawn Zimmerman, QPS Employment Group, against. John Baker, EC Steiberg Engineering, against. Randy Everett, Alto Sham, against. Dan Kipp, Create a Pack Foods, against. Larry Lambie, Value Added Distributors, against. Jay Esrich, KNS Manufacturing, against. Robert Bartholomew, Pulsemeister America, against. Larry Lambie, Transmotion, against. Bruce Harris, Hoffmaster Group, against. Larry Lambie, Bent Tubes LLC, against. Lawrence Moon, Sandstone Group Incorporated against, Ashley Avery, the Bettler Companies against, Ellen Steinhoffel, Steinhoffel's Furniture against, Lawrence Moon Sandstone Group against, John Doomstra Zero Zone against, Lawrence Moon Lakeside Manufacturing against, Tony Malafa Great Lakes Veneer against, John Torino Serigraph against, Mary Jo Wenzel Berrien Body Works against, Michael Lamont Wisconsin Counties Association Group Health Trust against, Carol Ann Schneider Seek Careers against, Mike White Right Height against, Kim Bauer Ultra Federal Credit Union against, Samantha Stauber Loan Companies against, Rick Fullington Weldell Manufacturing against, Alex Summers Ostia Health against. So I want to say thank you to the committee members. This was a long haul today. Thank you to Ledge Council Marguerite for sticking this out with us. I will say this is probably one of the most in-depth committee hearings and informational that I've ever sat through. Our office will be in touch with the committee as when we'll have our next hearing. And with that, we are adjourned.